Director, National Health Mission. Welcome, ma'am. It is also my pleasure to invite Dr. P. Sendil Kumar IAS Avargal, Principal Secretary, Health and Family Welfare, Government of Tamil Nadu, to join us on stage. May we humbly request Shri Saurabh Jain ji, Joint Secretary, Policy, Ministry of Health and Family Welfare. It is also our pleasure to invite Srimati Vandana Jain ji, Joint Secretary, Public Health, to join us on stage. And we also take the opportunity to invite Major General Professor Dr. Atul Kotwal ji, Executive Director, NHSRC, to join us on stage as we begin. Welcome, ma'am. On behalf of the Ministry of Health and Family Welfare, Government of India, it is our pleasure to extend a very warm welcome to each of our guests here at the National Workshop on Strengthening Public Health Infrastructure under Pradhan Mantri Ayushman Bharat Health Infrastructure Mission. The recent years have shown us how crucial it is to have robust health systems that can adapt to any challenge, be it pandemics, trauma care, or disaster preparedness. The PM ABHIM initiative is one step that bridges those gaps, builds capacities, and ensures that every citizen has access to timely and quality healthcare. This is a workshop that comes at a very crucial time to strengthen our public health infrastructure, improve our preparedness, and build resilience. As we begin our proceedings, may we kindly request all our guests to rise for the Tamil Thai Varthu, our state anthem.
நீராரும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராரும் வதனமென திகழ் பரத கண்டமிதில் தெக்கணமும் மது சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிலமை திறவியல்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. With that, we also take the opportunity to mark the auspicious beginning of this national workshop with a ceremonial lighting of the lamp. May we humbly request our esteemed dignitaries to join us with a lamp lighting, a timeless tradition that truly is a symbol of enlightenment and progress. May we request Additional Secretary and Mission Director, Srimati Aradhana Patnaik ji, Principal Secretary, Health and Family Welfare, Dr. P. Sendil Kumar IAS Avargal, Joint Secretary, Policy, Shri Saurabh Jain ji, Joint Secretary, Public Health, Srimati Vandana Jain ji, Major General Professor Dr. Atul Kotwal ji, Executive Director, NHSRC. Check. A quick photo op with our dignitaries. If we may please request you to join us, ma'am, for a picture. With that, it is our pleasure, ladies and gentlemen, to officially begin the National Workshop on Strengthening Public Health Infrastructure under PM ABHIM, extending a very special welcome once again to our dignitaries and our heartfelt thanks. Ladies and gentlemen, with that we commence our inaugural session. It is my privilege to invite Dr. P. Sendil Kumar IAS Avargal, Principal Secretary, Health, Government of Tamil Nadu, to deliver the welcome address. Welcome, sir.
Good morning, everyone. So I would like to, first of all, thank Ministry of Health and Family Welfare, Government of India, for choosing to conduct this national workshop for strengthening of public health infrastructure under PM ABHIM in Chennai. So on behalf of Government of Tamil Nadu, I welcome all the dignitaries on and off the dais. And this place particularly has a lot of historical significance. This much before the British came to India for trading purposes, the Dutch came here. So they established their trading post here. So this, the present day resort is part of that earlier Dutch fort, and they established their trading post here. So this entire resort is actually part of that erstwhile Dutch fort. So, in recent times, if we see this second India-China informal summit, which was attended by Honorable Prime Minister and Honorable Chinese President, so this was conducted here. So it has a lot of significance. So for this national workshop, we welcome all of you. And I take this opportunity to welcome Secretary Government of India, who will be joining us later in the day. And I welcome Additional Secretary and MD NHM, Government of India, Joint Secretaries from Ministry of Health and Family Welfare, Executive Director, NHSRC, and Joint Secretary from NHA, and Senior Additional Chief Secretaries, as well as Principal Secretaries and Secretaries from various states and union territories, and also directors, advisors, deputy secretaries, DDGs from Ministry of Health and Family Welfare. I also take this opportunity to welcome joint directors from NCDC and mission directors from National Health Mission from various states and union territories, and mission director Tamil Nadu, and officials from senior officials and heads of departments from Tamil Nadu, and also senior officials from various National Health Mission and from Tamil Nadu NHM also. So I hope your stay is comfortable here. If you have any concerns or issues, then our team is here to ensure your comfortable stay. And of course, under PM ABHIM, Tamil Nadu has been one of the beneficiaries. So we have 38 district integrated public health laboratories, which are either completed or under construction, and similarly some 37 critical care blocks have been established or under establishment. So I only hope that this today's workshop will set a stone and set a stage for helping us to improve understanding and improve the public health infrastructure throughout the country. So, and tomorrow also we have the Government of India team has finalized some 5 places to visit. So during the visit also we'll be able to give a glimpse of whatever has been done in Tamil Nadu. So I once again take this opportunity to thank Ministry of Health and Family Welfare. Thank you very much.
Thank you, sir. Following that, extending a token of our respect and gratitude, we would now like to take the opportunity to felicitate our esteemed dignitaries. May we humbly request the Principal Secretary, Government of Tamil Nadu, to kindly felicitate Additional Secretary and Mission Director, NHM. May we also request the Principal Secretary to kindly honor the Joint Secretary Policy. May we also request Dr. P. Sendil Kumar IAS Savargal to present a memento and felicitate Joint Secretary Public Health. May we also request the Principal Secretary to felicitate and honor the Executive Director, NHSRC. It is my pleasure to request Mission Director, NHM, to kindly honor and felicitate Principal Secretary, Government of Tamil Nadu. Thank you, sir. Ladies and gentlemen, may we humbly now request Shri Saurabh Jain ji, Joint Secretary Policy, Ministry of Health and Family Welfare, to kindly introduce the workshop and, of course, the theme upon which it has been convened. Good morning, sir.
Respected Additional Secretary and Mission Director, NHM, Ms. Aradhana Patnaik, Principal Secretary Health, Government of Tamil Nadu, dignitaries on the dais, Principal Secretaries, Mission Directors of various state governments who are present here, colleagues from the National Center for Disease Control, NHSRC, officials from various other departments, dear friends. First of all, a very good morning to all of you, and I welcome all of you to this very important workshop on PM ABHIM. As this workshop is not just a routine kind of review of the PM ABHIM scheme. It is very, very important and very timely, because now we are in the last year of the PM ABHIM infrastructure program. And this workshop is not only to take the stock of what all has been done, but it is also about the future action plan for this year. And also, we have to ensure that now we have to move from infrastructure readiness to service delivery readiness that has to be provided by all our healthcare facilities. As all of you know, that PM ABHIM program was launched in the wake of pandemic. The COVID-19 pandemic has exposed our health system to various gaps in terms of infrastructure, in terms of diagnostics, and in terms of surveillance. So this is the largest infrastructure healthcare program that has been launched by Government of India, and the purpose of this program was to create a resilient healthcare system which can provide citizens a reliable quality of healthcare, which they can access not only for routine healthcare services, but also in case of any health emergencies. Our vision for this scheme is to create a resilient, equitable, and quality service delivery healthcare system. But this is a vision. We have progressed a lot on this vision. A lot of steps have been covered, but there is still a lot more that distance has to be undertaken. So I'll give you a few examples in terms of what kind of urgency we need to have in the implementation of this program for this year and for the future years. So if we see some statistics I will give you, the block public health units, 2,151 sanctioned, only 864 have been completed and 694 are functional. IPHL, 744 sanctioned, 216 completed and 213 functional. Critical care block, 621 sanctioned, only 34 completed and 2 are functional. So it is not only about the sanctioning, but it is also about the starting of work and getting it completed, because ultimately the citizens want is service delivery and not just infrastructure creation. The purpose of these workshops are threefold. First of all, we have to take a stock of what all we have to do, what we have done, and what is the plan of action for 25-26 in terms of identifying the various bottlenecks and try to address them. Also, the priorities for the next phase of PM ABHIM will also be discussed. We will take ideas from all the state officials who are present here, and also in terms of the state's preparedness and the accountability of the state in ensuring that whatever targets have been given to them are filled. And I'll just take you across to the various themes of this workshop, in which you can see very clearly that from where we are coming from and how this workshop is actually designed to implement the vision and implement the various goals that we have set for ourselves in this year and for the future years. So first of all, we have the central sponsored scheme and the central sector schemes overview, which will talk about the various on-ground implementation status, and also talks about the synergy between the various centrally sponsored schemes and the central sector schemes. Diagnostics plays a very, very important part, and we have a session on diagnostics and its integration with IPHL and BPHU, because we have to have the protocols for sample collection, their transport, then turnaround time, and then ultimately its testing and providing reliable service to the citizens. We'll be talking about the various parameters which are required for operationalizing the IPHLs and the BPHUs, and the focus is now more, it has to move from infrastructure creation to actually deployment of human resources, uptime, vendor management, and digital integration. We'll be talking about the NQuast standards for IPHL, which will provide the certification framework for IPHL facilities. The CCB session, because as I have already discussed, there is a lot of gap in terms of functionalization of CCBs. So we'll be discussing about the various functionalities that has to be ensured in terms of staffing, in terms of oxygen readiness, and the various SOPs and the equipments which needs to be there at the critical care blocks. We will be having a session on the emergency and trauma care. Also, we'll be discussing about the various issues related to preparedness of health facilities in terms of various infrastructure like the health emergency operation centers, the ABHIM cubes, and what are the various drills that the health facility should undertake to ensure that their health infrastructure is resilient and it is prepared for dealing with any kind of emergency. We'll be having a session on disease modeling in which the data can guide us in terms of what are the future diseases that can happen in any of the areas and what should be the strategy and the response of the state governments. Surveillance and IHDP integration with the IHIP network and the IDSP network. So whatever signals that we are taking from the fields through the surveillance network, how they can be translated into action, what in terms of the deployment of the various teams, and also the feedback loop. Once the information is there, how the feedback can be given to the health facilities and communities so that they can be better prepared. One health and AMR session is there, and a session on capacity building so that the healthcare workers who are there in the remotest of facilities, they should be equipped with all kind of skills through telementoring and other training programs, so that in case of any emergency, they should be ready to tackle that thing. We'll be having tomorrow's some field visits will be there where you can take a stock of what all facilities have been created by Government of Tamil Nadu for the overall PM ABHIM program. And from that, you can take actionable insights when you go back to your states and you can implement the program. So I'll conclude with again reiterating that the assets are existing. Now we have to make them operational, we have to make them functional ready so that they should be ready to provide the services to the citizens. We have to align our priorities, we have to fix the bottlenecks and ensure that whatever targets are there, that has to be executed with all the discipline by the state governments. The ultimate goal of PM ABHIM is to create a backbone of health resilient infrastructure which can be used by the citizens, and the citizens can rely upon that. Our guiding values are empathy, inclusion, and equity, and I sincerely believe, and the ministry's vision is that if this program is properly implemented, this will create a roadmap for a Viksit Bharat by 2047. So I would like to once again thank all of you for coming to this beautiful city of Chennai. The historical significance of this place has been explained by the principal secretaries. Let's hope to have a very productive discussions during the course of 2 days. And when we come back, we should be having a clear roadmap of how to go forward in implementing this scheme. Thank you very much.
Thank you, sir, for that insightful introduction. And now to deliver the inaugural address, it is our privilege to invite Srimati Aradhana Patnaik ji, Additional Secretary and Mission Director, National Health Mission. Welcome, ma'am. Good morning.
Very good morning to all of you. A warm welcome to all the principal secretaries, mission directors, all the representatives from the states, various representatives from the states of NHM, those looking after PM ABHIM as well as looking after public health, ED, NHSRC and the entire team from NHSRC, and all the representatives from the Ministry of Health and Family Welfare, Government of India. So warm welcome to all of you. At the outset, let me thank Principal Secretary Tamil Nadu, Mission Director Tamil Nadu and their entire team for the wonderful arrangements that they have done here. The concept of keeping such meetings in such locations has been actually done purposely so that all of us, while we are also focusing on all the important aspects of public health and working towards together to ensure that we provide healthy lives to the citizens, we also remain healthy ourselves. So that's why these conferences are organized where you also can rejuvenate yourself and keep yourself also healthy and happy. So thank you to the entire Tamil Nadu team. This workshop which we have arranged, there are two basic purposes. One is, as you are aware, that now, more than 62% of work has started against the around 19,581 works which we had sanctioned. Nearly 12,518 works have started. There are still around 7,000 works yet to start. Then against those works started 62%, 45% work is complete. But when we do the field visits, we generally find that though at the Ayushman Arogya Mandir level, there's no challenge because under NHM, under 15th FC also, and Ayushman Arogya Mandirs were earlier also functional. But for the newer components like Block Public Health Unit and IPHL and CCBs, we are finding many of them are already complete, ready to start, but still they are working in silos. So one impression was that most probably in the states, people are not clear what was the purpose of BPHU, IPHL and CCB. All of us, if you can recollect the days when COVID pandemic was there and how other services were completely shut down. We couldn't do TB tests, we couldn't do ANCs, we couldn't do immunization because everyone was focused on COVID and its management and control, and also because of the fear of other people coming to the hospital and contracting the disease because it was a highly infectious disease, and the hospital premises, the labs, everything, we had only one. So rest all services were shut down. Knee operations were postponed. All other services are mostly postponed. So during that time, that's why this concept came that we should be ready for future pandemic preparedness. So we should have facilities which, in case there is a pandemic in future, they can be isolated and all other services will not get impacted anymore. So with that concept, PM ABHIM was institutionalized, conceptualized and then implemented. This is the final year of implementation. Buildings are getting constructed. I remember visiting one district where I asked, what will you do after the CCB is ready? The local officials out there said कि हमारे office बहुत congested है, सोच रहे हैं पूरे office को वहाँ shift कर लेंगे. I said, no, the CCB purpose is not to shift your office. In some districts, people were saying we are thinking of outsourcing it for some services which we have not yet been able to provide. So that's why this workshop has been organized to basically give you the clear guidelines. Those guidelines have already been circulated. I'm not saying that all states are doing it, but still a few states are struggling how to make them operational and what is the purpose of the CCB or the IPHL. Further, there are districts where BPHUs are working in silos. IPHLs are working in silos. There's also a district lab, and then IPHL has also been constructed. They have not shifted it to one. So the integrated public health lab, what was its concept? Why it has been brought in? So all these things, we will give you a feel of that. Secondary to that, actually, if you all are aware that there are all these 5 components which are there in CSS, we are all regularly in touch and interacting with each other. But there's also a central sector component wherein states are hardly involved. Only for land requirements, states were approached, or for MOUs, states were approached. Otherwise, what is the purpose of those central sector components, HEOCs, points of entries, VDRL labs, BSL-3 labs, so ABHIM cubes, what are all these things which have been brought in the central sector component? So we have the public health division who will be making presentations on that, and we have to basically integrate all of them. We have the LIMS, we have the IHIP portal, every single component of the entire gamut of PM ABHIM, we need to integrate together. But actually at present, everyone is working in silos. The One Health concept, how it is to be implemented, how do we prepare ourselves for the future pandemic, so that when in future any such pandemic comes, there's no issue or there's no problem which we actually faced during our last pandemic. So all these teams will make their respective presentations. And how do we integrate the entire thing? How do we actually implement it properly in the ground? That would be discussed during the various sessions. So various joint secretaries and directors who have come from the ministry would make their presentations on this. And next, the second important aspect was how to take it forward. So this is the last year of PM ABHIM. As you are aware, we did the National Consultation Workshop on NHM on 16-17 July in Delhi. Similarly, this workshop aims to get ideas from you. What is your concept of PM ABHIM 2.0? We are not sure whether it would be extended, but we are trying at the ministry level to prepare the concept note, to prepare the EFC note for PM ABHIM 2.0. A few things which had come to my mind I would like to share during your discussions. You can further take it forward. PM ABHIM, the main focus was infrastructure strengthening, pandemic preparedness, health sector preparedness. So, but under NHM, 15th FC also had a lot of components which overlapped with the PM ABHIM and 15th FC. So, for example, BPHUs, those were taken up in 15th FC, the remaining were taken up in PM ABHIM. Similarly, for all the Ayushman Arogya Mandirs, buildingless Ayushman Arogya Mandirs, some were taken from 15th FC and the remaining from PM ABHIM. So both complemented each other. Now from the next 16th finance cycle, most probably will not get any health grant in 16th FC. We are not sure about it. We have asked for funds, but we don't know whether we'll get. So how do we complement that part also? Those buildingless sub-centers which are left out even after already sanctioning quite a good number from 15th FC as well as PM ABHIM. Are there still some buildingless sub-centers catering to 5,000 population in normal rural areas and 3,000 in tribal areas? Or do we have still gap in BPHUs, or do we still have gaps in IPHL and CCBs? According to us, we have almost saturated all the districts with IPHLs and CCBs and all the blocks also with BPHUs. So that is one part which is the continuing part. The second would be to operationalize all these facilities and ensuring continuum of care. So the next cycle also, do we ask for the maintenance and the operationalization of all these various components. The third would be under NHM, there's a lot of pressure to include infrastructure. We have always tried to avoid, because NHM, all of you are aware, is mainly focused on achieving outcomes through programs. So various activities, interventions to ensure that we reach the SDGs, we eliminate diseases, that has always been the focus. For that, if we require some minor interventions, like strengthening SNCUs or DEICs, establishing DEICs or daycare cancer centers, which are not very infrastructure or capital intensive. those can be taken up under NHM, but we get proposals for 500-bedded, 300-bedded district hospitals, 200-bedded sub-district hospitals, all these proposals, and we generally avoid sanctioning because they are very capital intensive. Lot of funds, if they get blocked, then all the other programs will get impacted. So can we think of shifting such also requirements to PM ABHIM 2.0? That could be one thought we can think of, so that the NHM pool is mainly focused on the programmatic interventions with little funds provided for such smaller interventions which are not very capital intensive. So that is one area where we can think of. Any other field you feel where you are not able to invest, like CHCs, we had some portion in the 15th FC, but I saw hardly any states took that fund for construction of CHCs. Upgradation is another area. Even some states, I remember, were requesting that we do not want to dismantle the building. The building is in good shape, but we want to add on some components to it. So an upgradation or an additional infrastructure support to the existing building. So all these we generally do not want to propose through NHM because there's a resource envelope constraint. Also in hard to reach areas, there are proposals, especially from the northeast and hilly regions and tribal areas, for residences for the manpower, which is health officials, which are present in the various facilities. There again, though we are sanctioning from NHM, but it takes a lot of money, funds are diverted, and then we have to basically shift it to 3-4 years so that every year some amount we can sanction. So all these are some areas which we felt we want to support the states, but we are not able to provide adequate funds because of the resource envelope constraint. We have Vibrant Villages program, we have the PM Janman program, we have the Juga program for tribal areas. So all these again, though we are sanctioning MMUs, but in the long run, we have to think of establishing multi-purpose centers in such places which are hard to reach, where at least the ANM, the Anganwadi worker can work together to provide basic health services, just like a dispensary, a clinic, basically, where CHO is not required, but basic screening and basic ANC and immunization and other services can be provided by the ASHA, the ANM and the Anganwadi worker, which we have already experimented and have started in tribal areas, in the PVTG areas in some districts. So these are some ideas which I had, so I thought to share. So all of you can think during the group discussions which we have during the day after the presentations. And tomorrow also we have field visits organized for various groups to visit the various facilities under PM ABHIM. And then in the second half, the basic discussion would be on how to take PM ABHIM forward, how to ensure that all these facilities are actually properly utilized and operationalized, and the purpose for which they were conceptualized is met, and way forward, how do we take it forward, and if PM ABHIM 2.0 is sanctioned, then what are the components, additional components beyond what we are already thinking of taking forward to be put in that. So warm welcome to all of you once again. It's a long day. We have lots of presentations, and every presentation we have made in such a way there would be 10 to 15 minutes presentation followed by group discussion, followed by discussion. So if anyone has any questions to the team, you can ask. I would request all of you to take advantage of the entire public health team which is present here from the Ministry of Health and Family Welfare. Joint Secretary Public Health Vandana ji is there with her entire team. IDSP team is here, NCDC team is here. So that integration and ensuring that the continuum of care is actually implemented in the ground level, that would be possible if all of us work together. Generally in states, we find that the NHM team and the DGHS, the directorate teams, they work separately. But there are states where they totally work in tandem and there's no issue. So those issues also we would like to discuss and take it forward and ensure that we all actually ensure implementation of PM ABHIM in the right letter and spirit. Thank you.
Thank Thank you, ma'am, for detailing out the story behind the inception of PM ABHIM and, of course, what to expect from our national workshop. At this juncture, in our inaugural session, we now witness the release of a technical guidelines resource focusing on surveillance and reporting of healthcare-associated infection. May we humbly request the Additional Secretary and Mission Director, NHM, ma'am, to formally launch the resource. Following the formal launch, may we humbly request all our dignitaries on stage to unveil the first set of copies of this resource. As ma'am said, the value of the resources cannot be undermined, and one such resource being unveiled by our dignitaries on stage. If we may request everybody in the audience to put your hands together as we extend our celebrations. Following our on-stage photo op, may we humbly request all of our dignitaries on stage and our guests off stage to join us for a ceremonial group photograph. We brought our inaugural session to a close with a picture. The setup has been done outside in the hall area. If we may please request our dignitaries on stage. All of our guests, our speakers, our guests to join us in the lawn area for a photo op. As we draw our inaugural session to a close, may we also request all of our guests to join us within the hall for our technical session right after the photo op in order to make the best use of time. Once again, as we extend our thanks to each of you for joining us at the inaugural session, may we request you to join us outside for a photo op, a group photograph that will commemorate this lovely occasion. All of our guests, our speakers, may we request you to join us outside. Thank you. to kindly bear the timeline in mind. As we started off, this is going to be an exciting day full of conversations and presentations, following which we have a Q&A allotted for each of the presentations as well. So in order to make the most of the time at hand, if I may please request all our guests to keep in mind the timeline, and for our presenters especially. A few more of us walking in. Through the course of your presentation, this is, I think, a message specifically to our speakers. Through the course of your presentation, at the 15-minute mark, you'll hear a short bell, which sounds like, that's the short bell. And at the 20-minute mark, we have a longer bell to remind you. So if I may kindly request all of our guests to begin wrapping up the presentation at the 15-minute mark in order to make sure that we complete the entire presentation at the 20-minute mark. Following this will be the timeline that's allotted for the Q&A, so we hope to have maximum participation on that account as well. With that, ladies and gentlemen, we're all set and ready to begin our first presentation, which is going to be on the topic of overview and progress of CSS components and, as our guest previously mentioned, PM ABHIM 2.0. To take us through our first presentation, it is my privilege to invite Shri Saurabh Jain Ji, Joint Secretary, Policy, Ministry of Health and Family Welfare, to take us through it. Welcome, sir. Good morning. If I may please request all our guests to give him a huge round of applause as we welcome sir.
So again, good morning to all of you. I'll be starting the first session. Can I have a caller mic? So I'll start, so as we have discussed that why the PM ABHIM program was actually launched. So this was launched in response to the COVID-19 pandemics and various gaps that it has exposed in the healthcare system. So we have the strengthening of the primary healthcare systems through the setting up of the building-less sub-centers, the Ayushman Arogya Mandirs at the rural level, and also the operationalization of the urban Ayushman Arogya Mandir in the urban areas. Also, the task was to ensure that the laboratories, the diagnostic laboratories, which was observed as a big gap, so these laboratories are set up both at the block level as well as at the district level, and it provides the support not in terms of the clinical support, but also it should discharge the public health function. It should be involved in the surveillance activities for any pandemic and the outbreak response. And then we have the critical care blocks that was given as one of the components. Thank you. The critical care blocks was for segregation of the building so that the infectious diseases can be taken care of, and also for any kind of health emergencies that occurs in the future. So ready infrastructure for that. So just a snapshot of this scheme, again, just for reminding all of us that this was a scheme. It was both has a CSS component and a central sector component. Total 64,180 crores was the scheme outlay. CSS central share was more than 22,000 crores. The state share was around 12 to 13,000 crores. Then we have the CS component of 9,540 crores, and also the 15th FC grants of around 20,000 crores. So that is how the scheme, financial outlay of the scheme was structured. So I'll go component wise. So first component was the infrastructure support for the creation of building-less sub-health centers. So the component was for creation of the infrastructure at the sub-center level, and to ensure that the sub-health centers which are the main responders in case of any emergencies, they should have their own building and they should be functional. So that was the idea of this component. The estimate construction time was 6 to 9 months, and it was supposed to have a construction area of 2,000 square feet. Financial support that was provided under the scheme was 55 lakhs as the capital cost, and no recurring cost was allotted for this component. Over the period of 4 years, some key challenges were identified. One challenge was the non-adequate availability of land. Also, the administrative delays in land acquisition, that was identified as one of the components. Some of the states have adopted various best practices to ensure that these schemes can be rolled out smoothly. So they have synergized their efforts with the Panchayati Raj institutions for identification of land. Various states are at different stages of progress, and some of the states have been requested. Andhra Pradesh, because it has been lately sanctioned, all these centers. So Bihar, Andhra Pradesh and Karnataka, they have to put more effort so as to ensure that by within the scheme time frame, this scheme is completed. Then the Urban Ayushman Arogya Mandir for providing urban healthcare services in urban areas. So under this component, the provision was for providing human resources, drugs, diagnostics, consumables, rentals, IT systems, and polyclinic services for providing specialist healthcare. The population criteria was that for every 15 to 20,000 population, we can have an urban Ayushman Arogya Mandir. Government of India provides support of 75 lakhs as the recurring cost for operationalizing of the schemes. Same kind of challenges were also observed in the operationalization of these centers in the urban areas. The land availability was one of the issues. And then in urban areas, because of the complex ecosystem, where multiple government agencies are involved, the coordination or the lack of it is actually one of the challenges which has been identified for which is affecting the progress of this scheme. And then financial flexibility, that is also dedicated financial flexibility, that is also identified as one of the challenge. Delhi is the recent state which has been onboarded on PM ABHIM, and they have been sanctioned the Urban Ayushman Arogya Mandir. So, and West Bengal, both these states, since they are the late entrants, they have to do a lot of efforts for ensuring that the progress is satisfactory. The best practices under this component is where the effective coordination with the urban local bodies, the health department is able to manage for identification of space and rented building for operationalization of the urban arm. Then next component is the block public health unit. So idea was not to only provide the clinical support, but also the public health functions. The surveillance activity at the block level, how it can be strengthened, how the sample can be transported from the block public health unit to the ID, to the district laboratories, and then to a higher laboratory in case of any pandemic. So that was the intention of this BPHUs. It has three major components: block public health surveillance units, block public health labs, and HMIS cell. The scheme envisages that it has to be completed within 9 to 12 months and with the area of 2,500 square feet. The financial support which was provided is for around 81 lakhs for capital support and 20 lakhs for recurring cost. These are also the key challenges which has been identified, where within the CSC premises, the lack of space is identified as one of the constraints. Bihar has to do a lot of effort for ensuring that they are able to complete their targets in time. And one of the best practices was that whatever for operationalization of the block public health unit is when the HR which was recruited for COVID-19 pandemic, this HR was used for operationalizing and providing services through the BPHUs. Then the integrated public health labs for enhancing the diagnostic capacity at the district level for detection, surveillance, and responding to public health outbreaks. The estimate construction time was 9 to 12 months. Construction area was 4,000 to 5,000 square feet. And financial support provided was both for capital and recurring cost. Here also, because of the lack of sufficient space in the district hospitals, that is identified as one of the challenges in construction and operationalization of the scheme. Uttarakhand, Delhi, Bihar, they have to put in efforts and they have to expedite the progress if we have to achieve our targets by 25-26. The best practice, some of the best practice in the setting up of these centers is the implementation of hub and spoke model and linkages with the IHIP so that the digital data can flow and at various levels for responding by facilities and the community. Then the critical care blocks, the idea was to strengthen the medical colleges, district hospital through providing all the advanced critical care facilities for emergency and pandemic preparedness. For 50-bedded critical care block, the area that was envisaged was 4,250 square meters, and for 100-bedded was 8,500. Estimated construction time was 18 to 24 months. Here, also the challenges was the space identification at the district hospital and the medical colleges, and there was a lot of variation in the construction cost in plain areas and the hilly areas, and also the kind of the expertise which has to be there for construction of such facility. That capacity is lacking in some of the states. These are the states which have to expedite their progress: Bihar, Haryana, Assam. And the best practice was that where some of the states which have faced lack of expertise with their contractors, they have leveraged the central PSUs for the preparation of their DPRs and execution of work. This is the financial progress, 5 years financial progress. So if you can see more or less the entire cost, the capital outlay is already approved. The work out of 19,000, more than 19,000 units, work has started in 12,158 units, which is 62%, and work which is completed is 8,719, which is 45%. So still we have 55% of the work which has been approved has to be completed. That is a major cause of concern as we go ahead. I'll just like to show you how these different across the components it has evolved. So if we see the building-less sub-health centers from 24 to 24-25, there is a spike because building-less sub-health centers was sanctioned for Andhra Pradesh, Karnataka, and West Bengal. So you can see between the approvals, the work started, work completed, and functional, there is a lot of gap at every level. Similarly, for urban Ayushman Arogya Mandir, the approvals and work completed, there is a gap of more than 2,000 units. For the BPHUs also, out of 2,151 units which have been approved, only 1,709 work has started, 864 completed, and 694 functional. IPHL also, there is a lot of gap between work approved, started, completed, and functional. So you can see for yourself and just see where your state is faring in all these parameters. And CCBs, that is one of the biggest gap in terms of the operationalization and making it functional. 621 approval, work started 447, work completed very less, and only 2 CCBs are functional as of now. So these are the financial progress across the years. So all the outlay has been sanctioned, but actually the expenditure is far below satisfactory. This is a very important graph which I will just like to show you. At present, we are sitting at 9,039 crores as our expenditure. If we go by this trend, by 25-26, we will be able to achieve 12,328 crores expenditure. We have to, the approval is given for 34,900 crores. So there is a huge gap. So unless and until we have a specific plans, we identify the bottlenecks and prepare a timely action plan, this kind of gap, it is very, very difficult to fill this gap. And what will happen is that at the end of 25-26, this will be the committed liabilities that will be there. And we don't know whether in PM ABHIM 2.0, whether these committed liabilities will be taken care of by Government of India. So it is in the interest of the states, please try to fill this gap as much as possible so that your committed liabilities can be brought to the minimum. And we can expect that if we can show a good performance, then we can have a strong case in going for having a resource envelope for these committed liabilities if we can show a good progress. Going by this trend, even 30 to 33, we will not be able to fulfill our targets. So that is how it is very, very important. So why PM ABHIM? So this is a context. We have a central allocation of 22,000 crores. Still around 6,000 crores is the released from Government of India, which is actually, it is limiting the progress in system strengthening. Still a lot of works are in progress. As I have mentioned, we have to go beyond the infrastructure creation to service delivery and strengthen the health systems through various innovations. Some progress in physical infrastructure has been there, but in terms of their actual service delivery from whatever infrastructure has been created, because under the scheme, we provide both the capital cost and the recurring cost. So we have seen that even if some of the facilities which have been infrastructure has been made ready, still the recurring cost is not being utilized by the state. So what does that mean? That means that actually that facility has not been made functional, maybe due to various constraints, HR or equipments. So these are some of the areas which we have to focus, and that is why the PM ABHIM 2.0 is what is being actually also shared by the state, why it is essential. So we have circulated a questionnaire with all these states that what are the different components on which they feel that they actually require the continuation of the schemes. So these are the various components, the benefits of the schemes, challenges in implementation, best practices adopted, modifications which are required as we go forward, and what is the way forward for PM ABHIM 2.0. So these are benefits. Under the benefits of PM ABHIM, these are very self-evident. It has ensured that the infrastructure has been created to provide better diagnostic reach and service delivery. The service quality has improved through better lab capacity and quality. The out-of-pocket expenditure has been reduced because more and more tests are now being provided at the IPHL and the BPHUs. And the system is strengthening for pandemic preparedness through surveillance strengthening. That is also being there from this scheme. So these are the challenges which the state has identified: land and civil works, finance, procurement and IT, HR support, operations. These are some of the best practices which have been adopted by the state. So they have ensured that a phased functionalization has been ensured. Stringent monitoring. We have seen that after this agenda has been taken in the Pragati meeting, lots of improvement, lots of expenditure has happened. So the state has also mentioned this thing that Pragati style reviews, dashboards and milestone tracking helps to ensure that the progress can be on track. And various local fixes like utilizing the central PSUs and the other ways for procurement and deployment of contractors. So these are some of the modification norms which have been suggested by the state. I'll just skip this. I'll just go to this last slide. Our Honorable Prime Minister has recently, under the Pragati meeting, the overall review of this scheme was taken, both for the central sector component and the centrally sponsored scheme. So some of the directions given was to prioritize the healthcare infrastructure in remote, tribal and border areas and aspirational districts. Prime Minister has emphasized that this is a golden opportunity for strengthening the primary, secondary and specialized healthcare infrastructure at block, district and state level. And the idea is to ultimately provide good quality healthcare and services to citizens. These are some of the directions given by the Honorable Prime Minister. One is the regular reviews of this has to be taken by the Chief Secretaries, joint reviews by the Chief Secretary, Health Secretary and the State Health Ministers. District magistrates and collectors have to be roped in for ensuring the timely completion of health projects, and monitoring committees under the leadership of district collectors, especially for the aspirational districts and aspirational blocks, have to be created. And a mechanism for regular review at the level of the Chief Minister, Health Minister and Secretary Health has to be there for regularly monitoring the progress under the scheme. And ultimately, all the steps have to be taken to ensure that the implementation is expedited and whatever targets have been set up for this scheme are being achieved by the states. So these are the response highlights which we have circulated the questionnaire. These are the response highlights, montage of all the responses that have been given by the states. Thank you very much.
Sir. Thank you very much, sir, for that insightful presentation. Of course, we'd now like to open the floor out to any questions. Just a quick reminder that each of your tables has a mic, so may I please request all of our guests who have any questions or any kind of clarifications to please reach out to the mic. Please introduce yourself and share your question with us. We'd like to open the floor out to questions. Our first presentation for the day, setting the context, taking us through PM ABHIM 2.0 itself and what our idea forward might be. Good morning, sir.
Good morning, sir. Ms. Baul Hassan from J&K, Jammu and Kashmir. Sir, actually, we get a recurring cost of rupees 75 lakh for establishment of urban arms. But if we are getting a government building, can we invest at least 25 to 50 lakh for the renovation of that building? Actually, that building is being transferred in the name of health by that respective department.
No, so what is the question?
Sir, question is that can we, the infrastructure of that building which has been transferred to health for upgradation of urban arms, usually we get only recurring cost for urban arms.
No, so that is what I have mentioned. In some of the states, they have adopted the practice of involving the urban local bodies. If they can identify a building and give it to the state, to the health facility, health department free of cost, then this, some of the states have operationalized their urban arms. Because ultimately it is, they are not providing, under this component, capital cost is not provided. So that building has to be arranged by the state.
Health and school education has transferred 4 buildings to Health Department of Jammu and Kashmir in Baramulla district. So we want to upgrade those buildings.
Yes.
Thank you. Yes, madam, these are government buildings. Thank you, madam. Thank you. Thank you. Yeah, refurbish.
Ma'am, can I give you the mic?
Yeah, madam. They have transferred it to health department. No.
You vacated after you have invested.
These are already functioning.
Thank you, ma'am. We also have a next question. Good morning, ma'am.
Mike.
Sir, our state has taken this conscious decision to not recruit the staff separately for PM ABHIM. They are doing the staff recruitment in regular, sir, in the state cadre. Sir, so can these funds be made a little flexible, that the funds which are allocated for HR, sir, we can use it, because there are going to be the cost revisions when the projects are actually coming up. And in the procurement also, the cost assigned is getting changed. Since we are not using the cost for the HR, can we use it in the other things, sir?
No, so we have provided both for the capital support and the recurring cost.
Yes, sir.
So at present, the recurring costs cannot be, some of the states have actually requested for allowing, because the time also is very less now for utilizing the entire recurring cost. So they have requested for allowing the recurring cost to be used in the capital component. Yeah, so but that a call has to be taken, but some requests have been received from the states.
Yes, sir.
Thank you, sir. I think we have time for one final question.
I think I'm Principal Secretary Uttar Pradesh. I think one of the biggest challenges will be to operationalize the CCBs. The IPHLs and BPHUs should not be too much of a problem. The two problems in CCBs are that the norms that the Government of India has given in the recurring cost, in the budget section, you have given 1 lakh rupees for specialist doctors. You just cannot get 1 lakh specialist doctor in 1 lakh. Also, since PM ABHIM is getting close and we do not know PM ABHIM 2.0 in what form it will come, the states will naturally be reluctant to appoint contractual staff at this point of time for the CCBs. I suggest that you allow states to recruit regular people and compensate their salary through the recurring grant, as was done in some time in Sarv Shiksha Abhiyan.
Time also. That was just to calculate the total, for recurring, what would be the cost. That's why it was done. Since it is almost, we consider it as a part of NHM only. So under NHM, whatever norms are there, that will be applicable here. So the specialists where you are taking at around 1.5 lakh for NHM, that also can be done here. For regular cadre payment, generally, sir, Government of India schemes, be it NHM, be it PMMA, it is mostly for contractual. So we'll have to take a call there. State can recruit because it is always promoted that states should have their own regular cadre. In some of the states, what they have done is the lab technicians, the officers who were already there in the old lab setup or the microbiologists, etc., they are being deputed here. So there you will not require. But CCBs, the requirement would be far more. So we can take a call on that. The regular recruitment at present, we cannot. It was only till 25-26. हाँ. तो आप regular ये से ही करना is better, I think. Yeah.
Allow us to use it again if you want. It's a state's commitment, and the scheme design is such. You must understand. You showed the whole graph that why the schemes are low. You know, you have sanctioned the scheme till 25, 24, 25. Every year wise you have sanctioned the scheme. So if the sanctions are towards the last stages, schemes will take time for a finally happening. So maybe the majority of your expenditure will happen in next 2.5 years, because now all sanctions are complete. As far as the regular staff is concerned, you have adopted there was a similar issue under 15th FC also, where you have said later on that only the infrastructure creation will be taken under the 15th FC, staff payments will be taken under the NHM. Same scheme of things for the continuation of the scheme, you can do it, and the money which is available under the infrastructure mission, let it be utilized for infrastructure only. Maybe if the blocks are bigger, allow one more BPHU to come up or a CHCs to come up, and ask the states open a window again, because there will be still schemes. Every state will have 100 crore, 200 crore rupees, which will be ultimately not be earmarked for any purpose. Ask a more infrastructure proposals for that immediately, and we will submit in another 2-3 months. Have a national one consultation with the states and sanction that, and take the variable component as a part of NHM.
And price escalation and all keep on coming. So we can use for improvement of additional infrastructure as well as procurement of equipment which is required for operationalization of these things. Yeah, inverse. Yeah, that is better.
You appoint your regular people and take it forward. Unless until you say that, it is impossible for us to convince our finance department. Unless, I think that is the best solution, right? And CCBs require extra HR. You cannot run CCBs with your existing thing. So, no, but the NHM का आरोपी तो नहीं बढ़ा रहे ना, उससे फायदा क्या है?
On that note, we have yet another
Excuse
question.
me.
Yes.
So, Saurabh, the related question, Aradhana, what you were now just talking, what ACS UP just asked. See, this CCB has to function in non-pandemic times as a part of the regular hospital only. It's like a regular hospital. So it has to gel in the mind of our people that it should be a regular hospital. It's not something which is, some foreign thing which they have to run separately. So for that, what we are suggesting that instead of waiting for the CCB infrastructure to get completed and then utilize the HR, if you permit the HR to be utilized, we will use that HR, and within our existing hospital, we will do whatever bifurcation is there. That will also help us to ground the HR within time, because when the infrastructure gets completed, hiring the HR, that itself takes time, stabilizing them. So if you just permit, as soon as a CCB is sanctioned in a district hospital, you just permit the HR to be hired by the state. We have taken in one place, somehow it came under, sanction by Government of India. But other places, I was told by my team that we have to seek separate sanction. So if that can be done, we have sent a proposal. We have a lot of savings also. And since the time is less, this is something where we can utilize also. And then, of course, we will in the state funds for that HR.
So for the HR, since PM ABHIM is only till 25-26. So after that, the state has to take
We
the
will- we
load of
will
the
take
HR.
care, yeah.
For 15th FC, it was that it will be then come under NHM. But for PM ABHIM, it was not there because PM ABHIM is separate from NHM. That is the only issue. So we can give that approval, but then next from 25-26, after 25-26, the state has to totally budget it in its state budget, not under NHM.
We will give that undertaking, that state will take
would-
it.
So, and one solution, what Partha sir was saying, maybe the regular part would be more effective because after 25-26, if this, we don't get any extension.
Yeah, so we will
So then
consume
that,
them under.
where will that HR go? So that could be an issue. Then if the state takes it forward, there's no issue in that.
MD NHM from झारखंड मेरा एक क्वेश्चन होगा कि जो जब से मैंने ज्वाइन किया है मैं देख रहा हूँ कि अगर बिल्डिंग बन रही है तो जहाँ नहीं भी बनी है उसके लिए हमने HR कर लिया है या फर्नीचर खरीदते हैं तो चाहे वो जिला हो या स्टेट हो सारे सेंटर के लिए खरीद लिए जो कि बिल्डिंग नहीं है जिसके लिए उसके लिए भी या कहीं पे अगर दोनों है वाटर सप्लाई नहीं है इलेक्ट्रिसिटी नहीं है छोटे छोटे चीज़ नहीं है तो कहीं HR है और कहीं बिल्डिंग नहीं है कहीं पे दोनों है तो वाटर सप्लाई नहीं है स्टाफ नहीं है नीचे CHOs नहीं है तो सबको कन्वर्ज करने के लिए ब्लॉक लेवल पे कमेटी को एक पावर दिया जाना चाहिए कि जितना बिल्डिंग कंप्लीट है उसी में बाकी चीज़ को वो यूटिलाइज करें और फिर जैसे जैसे हम लोग उसको फंक्शनिंग करते हैं और अगर कोई चाहे वो डिस्ट्रिक्ट हो या स्टेट हो अगर कोई काम को एक बार में नहीं कर पाता है तो एक सर्टेन टाइम के बाद फंड ब्लॉक लेवल में जाके कन्वर्ज हो जाए कि जैसे ही उसको स्टार्ट करने का हो उसको वो पावर हो कि उतने ही समय में उसी चीज़ को वो जिसका कि स्पेसिफिकेशन दिया रहेगा वो परचेज कर सके और वो चला सके क्योंकि बार बार वो कन्वर्जेंस जो है ये सारे चीज़ों का जैसे कहीं PA सिस्टम नहीं है कहीं पे बिल्डिंग नहीं है कहीं पे सब कुछ है मेडिसिन नहीं है अब ड्रग खरीदने के लिए कोई और ऑथराइज है तो सब लोग ऑथराइज रहें सब काम करें लेकिन जब सर्टेन टाइम जो कम से कम बंद सेंटर्स हैं उसके लिए एक सर्टेन टाइम के बाद फंड ऑटोमेटिक ब्लॉक को चला जाए तो इस तरह का कुछ अरेंजमेंट हम लोग को करना होगा कि सारे चीज़ कन्वर्ज हो जाए
ये तो शशि जी आप ही को करना होगा ना भारत सरकार तो लमसम देती हम कोई फैसिलिटी वाइज कोई पैसा देते ही नहीं है We just give a lump sum amount based on your proposal. So you at the state level have to do it. Which is the district which is performing well, which is the block which has completed where you need to provide HR. You cannot depute HR before completing the construction of that facility where you want to keep the HR. Same, you cannot buy equipments before the HR is recruited as well as the building is complete. So all have to work together. Convergence आप ही को करना होगा अपने district level पर, block level पर, state level पर, through regular monitoring by the state.
Thank you, ma'am.
Thank you, sir. Thank you, ma'am.
Can I just come in?
I think we have one final question. Is that right? Yes, sir.
What I've been saying is that, you sanction a lot of projects and you see some states, because of land issues, it is not being implemented. 1 year, 2 year, 3 year down the line, project is pending. Why not fix the time? And after 2 years, why not you give that benefit to some other state where it is performing well? This is my submission.
Okay.
Because there are some forest issues, there are so many land issues. It's never happening. So in such situation, after 2 years, you cut from that state and give it to a state which is doing well.
We are already doing that.
That's what my
Yes,
submission.
that is being done. Okay, thank you very much.
Thank you, sir. A round of applause, ladies and gentlemen, for Shri Saurabh Jain ji. Thank you, sir, for sharing those valuable thoughts. And with that, for our next presentation on stage, we're pleased to invite Srimati Vandana Jain ji, Joint Secretary, Public Health, Ministry of Health and Family Welfare, to talk us through the progress and impact so far when it comes to the CS components of PM ABHIM. Welcome, ma'am. Good morning.
Yeah, good morning all. You've just heard about centrally sponsored component. Now this is central sector component of PM ABHIM. So I will start with this. The main central sector component is around 9,339 crores, and it is further divided into. It's further divided into, like this is the pie chart. We can start with critical care blocks. We are preparing 12 critical care blocks in tertiary sector for an amount of 2,220 crores. Then for strengthening surveillance of infectious diseases and outbreak response, we are giving it to NCDC for 3,060 crores. Another component is points of entry, and this is strengthening surveillance capacity of points of entry for 294 crores. And disaster management, we are giving funds for health emergency operation centers and mobile hospitals, 330 crores. ICMR is getting 1,670 crores for biosecurity preparedness, pandemic research. And balance is for emergency response. This is yet to be decided. So these are the main objectives: strengthening surveillance of infectious diseases and outbreak response, health emergency operations centers we are setting up, and ABHIM cubes. Then strengthening surveillance capacity of points of entry so that we prevent cross-border transmission and strengthen our health screening systems of international travelers and develop quarantine facilities. Then these 12 critical care blocks at central hospitals. Another main is our surveillance of infectious diseases and outbreak. This will strengthen our integrated disease surveillance system, public health laboratories, develop epidemic intelligence services capacity, rapid response to disease outbreak, support zoonotic diseases control through One Health approach. This is the snapshot of key infrastructure deliverables under central sector component. Critical care blocks 12, metropolitan surveillance units 20, and 5 regional center, NCD center. State NCDC branches, we will have 27, biosafety level 3 laboratories 15, new points of entry 17, strengthening of the existing points of entry 33, health emergency operations centers 16, ABHIM cubes 50, National Institute of One Health will be there, regional research platform for Southeast Asian region 1, regional National Institute of Virology 4, and biosafety level 4 laboratories 2. These will be the key activities: epidemic surveillance, then IHIP and real-time digital reporting, community awareness, field epidemiology and rapid response teams, state-level training programs and technical support, health screening at points of entries, support vaccine diagnostics and therapeutic development, advanced laboratory network, health emergency operations centers, ABHIM cubes, and critical care. What will be the benefits to the state? The early outbreak detection, response and containment, workforce trained in public health response, improved compliance and awareness, access to latest research findings and guidelines, enhanced health system resilience. These are the expectations. We want support, operational support, enable integration of national infrastructure into state health systems for seamless functionality. Data and system integration, collaborate to connect state labs and health data systems to the integrated health information portal. Institutional linkages like linkage between central institution and the state health departments for disease control. And facilitation and coordination, of course, assist with land allocation, local clearances, and administrative support. Surveillance systems ensure timely reporting from health. This is very important. Like in our IHIP portal, still we don't get the entire data. Especially from private sector, we are not getting that much data. So if it is timely reported on our portal, that will be very beneficial for us to further see the trend. Research and development and capacity building of this is also very important, like we are organizing number of training programs, but staff nomination is, yeah, it's not, okay. Okay. Thoda sa. But yeah, now it's okay. Okay, man. Yeah. Mic if you can. Acha, this one. Okay. Then capacity building, I was saying that. For capacity building, I was saying that we are organizing a number of training programs, but we are not getting the trainees from the state. So we would like to have more of nominations from state. Policy and technical support, of course, for our guidelines, whatever we are giving, if we get the feedback on that. These are the emerging future priorities: antimicrobial resistance, then climate change and health adaptation, where we can work further, One Health approach, capacity building, data and digital integration, where we would like to have integration of state health portals and our IHIP portal, and linkages with state infrastructure and advanced diagnostics. These are some of the facilities which we are creating: MSUs, NCDC branch, then this is ICMR research, critical care block, AIMS Bhopal, ABHIM cubes, and this is quarantine center at Hyderabad. This is, thank you. Any questions?
Hello. Madam, if you are able to give the components, each component, some infrastructure works are going on in various states. If you can tell
we can give
what,
those,
if you can tell where state government support is required, you are not able to do because some issues are getting blocked, it will be helpful.
Yeah, we will give the details.
Yeah, so, and the thing is somehow, the close coordination with the state also is required if you want to complete the entire infrastructure of that. And I hope that entire manpower required for that is included in your
central
budget
sector.
only, na?
Yeah, we will be providing.
Okay. So after establishment, again, don't throw that on the state government for further maintenance.
Yes.
And maybe last but one slide, if you just can go back. So you're talking about AMR, all that. Only thing is, what is that you will be able to support? Because we are doing whatever we can do, but from the state, center side, what is that you will be able to help the state governments in strengthening the activities you listed out?
If there is a coordination, yes, madam.
Component-wise, we have detailed presentation. She just gave the overview. Now, component-wise for AMR, we have separate sessions. So, usme wo detailed discussions, I think, would be more effective. Yeah. And one suggestion which Sir rightly said was because the PM ABHIM CSS component, we are in regular touch with states, and that coordination and collaboration is there. But that's what all the secretaries were saying, that for CS component, that has not been there. So what we can do way forward is when we have our meeting with the states for CSS, we'll also include CS in that. So there the states, whatever support you require from the states, for regard land or MOU or to make it operational, and wherever states have any issues, so they can then discuss. Okay. So these are the 5 components. So इसी पर अब एक-एक करके अलग-अलग we have kept sessions for all the. Next slide करिए. So AMR पर एक सर हमारा है अलग presentation, climate change पर एक अलग है, One Health पर एक अलग है. So सभी पर सर एक अलग-अलग data integration पर एक अलग रखें. So उसमें will go in, they will, the concerned officers, directors will present and they'll discuss in details.
Yes, ma'am. Yes, that's why I have not explained.
Yeah, that's why she didn't delve on the details for each of the components because it is already there in the. ठीक है. ठीक, thank you.
A few observations regarding this slide itself, ma'am. The thing that we have been doing, I mean, this antimicrobial resistance, there was one workshop, launch of some technical guidance, then this One Health approach. But what one feels at the end of the day is, it is more, limited to the technical consultation. It's not percolating down the line. And the same is the case because after the pandemic, everyone realizes that this disease surveillance and everything, it has to work every time. Not, we don't have to be active whenever the pandemic strikes. So, because now it is being dealt by DMHS and what you mentioned in your initial remarks, that both are working in silos. NHM, that we are giving those program support and also civil, and DMHS is looking after the regular things. So either some cell within DMHS supported by this, so there is some ownership. As of now, one person is in charge, he is looking after disease control and IDSP and everything, and he's also looking after this. But there has to be a cell like in NHM, vertical cell, so that this continues, because these are climate change and these are the things which will be requiring our attention after we have saturated our HR, after our civil and everything. So I think we need to focus this a lot.
Thank you, ma'am. Any more questions from the back of the hall as well? Please do feel free to reach out to the mic on your table. All right, ladies and gentlemen, please join me in extending a very special thanks to Srimati Vandana Jain ji for that lovely presentation. Thank you, ma'am. Our next presentation focuses on the synergy between free diagnostic services and IPHL BPHU. To take us through this topic, it is my pleasure to invite Shri Harsh Manglaji, Director, NHM1. Good afternoon, sir, and welcome.
Next, no. Good morning, all. My task is to brief something about the convergence or the synergies between the FDSI and the new concepts of BPHU and IPHL. As we all know that FDSI was launched in 2015 and the revised guidelines were launched in 2019. We all know that 3 types of services are there: pathological service, X-ray services, teleradiology services, and certain minimum essential diagnostics we have to prescribe at each type of facilities. This we all know, and we all trying to provide through NHM funding in past few years. Various models have been adopted by various states. Majority of the states are in-house services of the diagnostics. A few states are in PPP mode, complete PPP we can say, and few states are in mix. So these are the 3 models which are running in the states. 4 components, essential components are there in FDSI. That first of all, we all expect that the full set of diagnostics should be available as required as per the IPHS. Many states have kept even better than that. And sample transport is the essential part, because hub and spoke model has been now being used to bring the economies of the scale and also to bring the proficiencies. And then IT platforms are being rolled out. DVDMS has been expanded to capture the diagnostic module, and LIMS is also being used in various states to, capture the data of all the diagnostics done and their reporting aspect also, and quality assurance and control, obviously the very important part of all the systems, including the diagnostic services. So as I mentioned that as per the report, we have 23 states are almost having the in-house facilities. Majority of the diagnostics are provided in the in-house services. And this is also intention of the ministry also, that with the funding of FC15 and the NHMs and all other sectors combined, now we want that states should go for the in-house model more. They should establish the services so that, reliance on the PPP partners is less. Then almost 6 states are having outsourcing model, something like CGHS rates. They have contracted the parties. Then 5 states are having the selective outsourcing, that they have outsourced the low volume, high cost diagnostic in the PP and rest in the in-house model. And 2 states are adopting the rental regent model. We have to be very cautious about the this part of low volume, high cost outsourcing, because with the introduction of the partners, we are realizing that low volume, high cost diagnostics are converting into high volume, high cost diagnostic also. So there has to be some managerial watch on this aspect while we are assigning the contracts to the partners. Now, IPHL has been explained by Joint Secretary Sir. This has been the attempt to provide the strengthen and develop comprehensive diagnostic testing facility under one roof. So IPHL, we want to integrate all the diagnostic facilities which are scattered through various parts of the district hospitals. So we want to bring it at one roof. Then along with testing, this also caters to the surveillance part, which is the future. Among the 200 IPHL which have been made functional, although smaller states, but many states have completed almost 100% of their work. This is the objective of IPHL, that we want to integrate or converge the diagnostic services at 3 levels, like at functional, physical level. We want to bring all the diagnostic in under one roof, so a patient has not to run to various sections of the hospital. And similarly, functional integration, like all the programs diagnostics are also to be bring in the one section, so that all the programs are not running parallel labs, they are not having parallel HR, they are not having parallel equipment. So all the convergence has to be done, and ultimately data integration, that one data set, one MIS reporting can be done to analyze, to take the options of the decision making based on that data. And ultimately, surveillance will be strengthened, and it will give time to respond to the better to the public health threats which may come in the future. These are the key functions. I will not go into detail. We all know about the functions of the IPHL. Then similarly, at each block level, there has been a unit envisaged, one block health level facility or CSC, which we want to develop at BPHU. And it will act as hub for all the spokes like PSCs or the sub-health centers in that block. 3 components already explained by Joint Secretary Sir, so I will not go into detail. Only thing that surveillance again is the major objective of this setup. Now this is the main integration slide, because diagnostic services were working in silos. So now with the onset of the IPHL, BPHU and all this integrated setup of data management, then each sub-health center, or we can say arm, will be connected to IPHL, and then IPHL in the center, it will connect it to the state level health laboratories and regional and national level laboratories. So this ideal mapping has to be, now we have to work all on this model, so that, all the diagnostics in the state and the nation are integrated, and, a beautiful setup of the information flow can be, witnessed. LIMS plays a very important role. We all know it automates the process. It gives the scope for improvement, scope for monitoring. So wherever it has not been used, we also request that LIMS should be introduced in almost all the facilities in future. These are the equipments at IPHL which are mandated as per IPHS. If we employ all these equipments, then all the tests at the DH level can be done. So the objective from the NHM and FC was always, that states should take up all these equipments from in-house so that, their control is better, their teams are trained at their own level so that dependency at the outsiders is reduced. Similarly, this is the equipment list at the BPHU also. Now, how the deliverables are synergized between the essential diagnostic services and the objectives of IPHL and BPHU. As I have already mentioned, the core objectives is accessible and affordable diagnostic closer to the community. This has been the motto of all our services in the NHM. And then the assured services has to be provided. We have not expanded anything beyond the IPHS for these IPHL as well as BPSU. So same number of diagnostics we are expecting. Then rational administration of diagnostic services. We want to see that, the diagnostic service is not overly utilized. It is not irrationally used. So with the integration of all these, setup, the irrational use of diagnostics should not increase. So our team will be in a position to, see that what is the patient to diagnostics ratio and all these things. All professional monitoring things can be employed after the onset of the integration. Then integrated data and lab management. We all know that HMIS, LMIS are being used already. Quality assurance and quality control, I will come again in the next slide. So, as NHM has always been health system approach, and the BPHU and IPHL have been brought up from the concept of the strengthening of the infrastructure and also the HR component, because they are part of the ABHIM. So all these things will be clubbed, and the result will be ultimately like enhanced in-house capacity. It will bring the efficiency and cost effectiveness in our operations because it will reduce the duplication of resources. Ultimately, there will be saving of resources. Then sample transport mechanism can be thought of in the better manner. In NHM also 6-7 states have experiment with the drug transportation mechanism. Similarly, the diagnostics transportation needs much improvement in the states, and ultimately the referral system will be better. Unwanted diagnosis, duplicate testing, referrals need to be controlled and need to be looked into. Now, only one slide I have kept for the one portion of integration, like quality assurance and control. They are two similar, but there is small difference in assurance and control. As we can see from the screen, that assurance is the process part, administration part. Like if we monitor the quality portion on the administration side, then it is almost coming in the quality assurance, that how we are managing our quality testing stages, training of the staff, equipment, maintenance, etc. And quality control means test accuracy and precision. We all know that if we give our sample to 2 or 3 blood labs, then the result will be differing. Not only the method of diagnosis will give different result, but the same method may give the different results. So all these things, we need to see that, people want to see the only better results, but it should not give them the, unreal results. So quality control is the most important part, and in public health setup, generally we ignore it. So it is a request that it should be taken very seriously. With the direction of Additional Secretary Ma'am, we have added the diagnostic module on the DVDMS. So earlier we were all using this for drugs procurement and also stock taking and all these things. Now diagnostic portion has also been brought into. So consumables and all the kits and small portions we have already entered in the diagnostic DVDMS module, so that its stock can be monitored, its availability can be monitored, and based on that how many numbers of diagnoses are available in the portal or in the state, we want to actually monitor that. So it is a request to all the states to be in touch with our team in NHSRC. Dr. Ranjan is working on this, and with this, we have already 10 states have already onboarded on this diagnostic module. We have discussed with many states. Discussion has already been taken place with many states, like 25 states had been oriented, and probably in next 6 months or so, we will be releasing the progress also what we are observing on this portal with the states. These are few examples. We all know T-Diagnostics of Telangana and Tamil Nadu is a very good hub and spoke model. Hammer Lab in Chhattisgarh also, hub and spoke model. So just for the knowledge, thank you.
Thank you, sir, for taking us through that. If I may please request anyone who might have a question to raise your hand. We'll pass along a mic to you. For our guests at the back, we've got a mic on your table. Please do feel free to reach out to it. Thank you.
Harsh, I had a query. You mentioned about this DVDMS, and in your presentation, Rajasthan was one of those states which was oriented but not on board. But actually, we have our e-Aushadhi system functioning since 2011, and the same CDAC, I think it is looking after DVDMS, and CDAC is running the e-Aushadhi. So rather than, you know, reinventing or creating something new platform and the entire system switching over, we should have some portability thing so that the data is captured.
Ma'am, wo ESD and DVDMS are one and the same thing. I was just mentioning about the diagnostic version of the DVDMS. So drug part, there is no issue. Only thing that we have to map the... So ma'am, that portion we may need to link with the DVDMS so that, you know, that e-Upkaran list, Upkaran is also maybe ma'am equipment part. But the consumables parts, the, you know, detail, reagents and all availabilities we will track from the DVDMS. So what our objective is that through e-Aushadhi, what you are saying ma'am, it is not different than DVDMS, same. So all the consumables can also be shown there as like my consumables. And then what is the progress of their procurement, their availability, that we want to see. It's nothing new portal, ma'am.
Only thing is now as part of NHM or part of health, public health, we are taking up the essential tests.
Yes, sir.
Not only BP, sugar and anemia, that hemoglobin, essential 41 tests identified by the technical committee on annual basis for the people with NCDs.
Yes, sir.
So renal function test, then liver function test, complete blood picture, and for the other things,
Yes.
some 41 tests. So that we can do with the BPHU as well as IPHL.
Yes, sir.
That is the hub and spoke model. The only problem is the cost is coming almost 250 rupees per person on an annual basis. And this will be almost, of course, even NFHS survey data around 35 to 40% of the people has to be taken. So it is a huge expenditure which is which cannot be done in NHM. NHM free diagnostic component is very limited. So if we can propose some way in which this free diagnostic component is at least given some more, then we can have a annual checking of the people, and health record can be perfectly maintained. Because ultimately, if you want to maintain good public health, you should understand the people with the problems and the people who are likely to have serious problems and start taking preventive action from the beginning.
Yes, sir.
So that is the reason. Suppose even in Andhra Pradesh, if you take, we have identified 1.5 crore people to be monitored with NCDs and other health conditions. So 1.5 crores means around 250, almost 350 crores will be the expenditure on an annual basis. This will be a good investment in the health sector.
Yes, sir.
Because it will at least capture the health profile of the individuals, and that EHR is maintained. Whenever he goes to any consultation, at least immediately the EHR, he can, his profile can be easily seen.
Yes, sir.
So that is why I request in whichever way to, whether it is a PM ABHIM as a recurring expenditure component, any way, let us just do this.
Sir. Yes.
We saw this in the morning, sir, in the stall of, I think, sir, what sir is saying, Tamil Nadu is doing that, sir. They are taking the labs to the people in very hard to reach area. And sir, they explained the whole initiative and it was really good, sir. But the sir point that is made by sir is very valid, sir, that right now we are focusing on the people coming to the labs and the funds are being allocated according to that. If we see this Tamil Nadu initiative, sir, they are taking 6 semi-auto analyzers to that place. So the cost obviously increases, sir, because the people who are not having the symptoms are also being tested. So, sir, the sir made a point made by sir to increase the funds in this, sir. to have at least once annual checkup like that, sir, it will be very good, sir. And sir, I would request, sir, if Tamil Nadu can make a small presentation in detail, sir, because that's a very good initiative that they have taken, sir.
Yes, so I will request Arun to find time.
Good
Only
afternoon,
two
sir.
lines I will say on this, what sir has said and what... Yes, Jeevan.
Hello.
What Gayatri was mentioning, basically see this e-Upkaran, e-Aushadhi, DVDMS, all is being run by CDAC. So what we have done is actually at the national level also, CDAC, we are paying crores of rupees for implementing DVDMS in all the states. And CDAC themselves have again approached each of the states individually and have done MOU with the states and getting funds from there also. So when we came to know of this, so we did a meeting at the national level. Now they have agreed. So we'll have a national MOU and the funds will be routed of NHM only through there, so that it would not be duplication. And they will help the states because they have only developed. It's the same, but the one DVDMS should be linked with e-Upkaran, e-Aushadhi, it's all the same. So that we have told the CDAC team already. The second thing to just add again is the other issue was for integration of portals, because we are talking of this various portals. We have finally succeeded in getting integration of portals done. The integrator app is fully ready. NHSRC has hired a team. There also you can understand where the integration is there, how we can save money. From NHM itself, we were paying nearly 30 crores for maintenance of various portals. Now the same we are doing in 10 crores. So almost 1/3. And this, again, states which have their own portals, they will help for API integration. So that would also help, all the programs coming on board. And the one which Harsh was presenting, and then Saloni also, and sir, you were saying, and then Saloni added to it, that I think we'll have to keep as a part of the NCD program. Because what you said was for NCD, Tamil Nadu is also doing for the NCD. So maybe in the NCD program, which we are doing for TB now, asymptomatic population also screening, not only symptomatic. Similarly, we have to think it would require additional funds so that we can put in the next 5 years way forward. But under PM ABHIM, we won't be getting, because the focus there is mainly on infrastructure. That's what. Component should be there, point well taken, sir.
Ma'am, just I will add that, sir, it is always good to have a monitoring of how many number of diagnoses we are prescribing to the people, like you said, annual or quarterly maybe. We have seen in many states, sir, people are coming on their own in monthly basis. So that should not happen. So ideally, there should be some range of the diagnosis, repeated diagnosis, and NSRC is still working on that, sir.
In fact, Himachal government has also done this. They said free diagnostics and free, for all people. So people have started coming every month. Free hai mera sara test karke do. So now they are also going back in. It should be only annual, but it's a state initiative.
So what we will do is, we will communicate whatever tests we have identified, duly consulting with all the technical experts. We have identified 41, both microbiology as well as biochemistry. So that you can also get from others and get it checked and give your own standardized test. Whether it is 40 or 20 or 80, that does not make a difference. But NCDs, because if you want to monitor NCD, so those are the things which we thought it is required, but it can be checked up by a relevant agency and guide.
So one thing I just, sir, one thing, see, you were mentioning about integration of the labs from sub-center up to district lab. This IPHL and whatever my limited understanding and BPHU, what we have done is integration of tests which were already happening at district level at different labs. So we brought those different labs into one building.
Yes, sir.
Now, one other component, what you mentioned that some states are doing, we are not aware, so if you can throw some light on that. Now, sub-center, you said we do certain number of tests. Primary health center, we do certain higher number of tests. And then block level, certain higher. Now, if a person has to get a higher level test done, there are only certain diseases, communicable and all, for which the sample presently flows from the sub-center or primary health center to higher level. Not for all other tests. For all other, the person has to travel.
Yes, sir.
So is there some component under this, or whether there is a flexibility to use some funds for providing all those tests which are there at the district and block level to the people at the sub-center so they can go and give sample there, sample transport. So is there some state is doing that under these funds, or is there some flexibility for that?
Yeah, actually, Andhra Pradesh, what we are doing is, we are having two systems. One is mobile medical unit, which goes to every village twice a month. So, along with the doctor. So, we are putting the diagnostic equipment in it and taking to the village. That is one. Second is, because government wanted it to be done quickly, so we have also started taking the sample from villages by putting a lab technician, transporting and checking it the hub center. Hub can be either BPHU or IPHL or our CHC or district hospital as per the local need. So those people will take the sample, bring the sample to the hub and get it tested and give, means it is a LMIS, it is integrated to the EHR.
That funding is available, or is it
No,
state funding?
this funding presently we are bearing. That is why we are asking support from, we are tapping some fund from NHM, but only thing is major part we are bearing. That is why
Sir,
state
I will supplement, sir. Sir, whatever we are, sorry, sir.
Sample transportation is a part of NHM. Many states are using that. So this sample transportation and a hub and spoke model, MP I know is using
only
it. Odisha,
money.
I think is
It is only money.
Andhra is taking it forward up to the village level. That is an outlier. My point is that you now have an option of PM ABHIM 2.0. And at that time, when you will be thinking of PM ABHIM 2.0, right now it is all pathological tests which are included in PM ABHIM. The radiological tests are not included in PM ABHIM. So in the radiological tests are now becoming very important, and this can be done only with a teleradiology concept because you will never get so many radiologists. So my point is that if you can include in PM ABHIM 2.0 some radiological tests on a teleradiology basis, on a PPP basis, it might help people.
Sir, we will note it, sir.
Good afternoon, sir. Sir.
Yes, please. Yes.
Do we have a option in PM ABHIM 2 for so that we can propose equipment and machinery for IPHLs? And one more situation, we are caught up in a situation that in certain city blocks, local governing blocks, we are not getting land for establishment of block public health units. Can we establish that block public health unit in the adjacent block which is nearest to this city block, where the land is not available?
You want to get clarification of the establishment of the BPHU
Yes,
in the adjacent block?
Yes. Actually, we are...
I think the BPHU ABHIM team can clarify on this because of the policy part.
Yes,
so I think Kosto will reply on in his
and sir, one more thing, that under PM ABHIM 2, we should get an option of proposing machinery and equipment for IPHLs. क्योंकि आप expectation सर बढ़ गई है, IPHL थोड़ा सा और high level पे हम लेना चाहते हैं. For that, we will require some machinery and equipment. Under PM ABHIM 2, if it is possible, a provision should be kept for.
He has point of that he is not getting sufficient land somewhere to
Yes,
establish.
sir.
He want to establish BPHL in the adjacent something block. So he has some
Both
location,
the blocks,
location
both the
clarification he
blocks will be
wants.
on the same medical block. मैडम एक्चुअली हमारे कुछ सिटी ब्लॉक्स ऐसे हैं जहाँ पर टोटली साइट अवेलेबल नहीं है. हमने वी हैव ट्राइड G+1, G+2, तो वो नहीं बना पा रहे. तो जो उसका एडजेसेंट सिटी ब्लॉक है लोकल गवर्निंग जो नियरेस्ट टू दैट फैसिलिटी है, तो वहाँ पर क्या हम एडजस्ट कर सकते हैं? एक नो मैडम, PHCs 24/7 PHCs. Yes, sir. Yeah, okay. It's in some hilly districts. We are facing this problem in hilly districts of Ramban and Doda. Thank you.
Technically, it should not be an issue, I think. Now, only one
you
facility
can
in block.
give the justification and send the proposal. We'll approve and send it to you.
Okay.
But you have to ensure that integration. It should not be if it then
Yes, yes, yes.
We have
standalone facility and then no one is going there.
approvals are, madam, there. But we want to shift those. Actually, approvals, you have approved 287 BPHUs
I
per
think
unit here.
state can take the call.
Okay, thank you, madam.
I think we have one final question. Yes, ma'am.
Namaskar, sir. Sir, I am CEO SNA also in PMJ Yojana in the state. And under ABDM, Ayushman Bharat Digital Mission, we have been pushing a lot of digital health initiatives. And just like CDAC is doing e-Sushrut, we have taken up next-gen model of NIC in all our hospitals. So next-gen has its own lab module, its own store module and pharmacy module. So the functionality there is something like this, that we can also integrate our fully automated machines with it so that the results can also be taken up digitally and data can be maintained. So my request would be, as many of my districts have been performing really, really well in this scheme, and districts like Bijapur have got earned maximum incentives under digital health incentive scheme in ABDM. My request would be, if this can also be considered while you are coming up with the IT functionality of the IPHLs, because that would help us integrate everything in one go, not just the inventory, not just the records of the reagents and consumables, also the results that are obtained can be used for surveillance and all. So I just wanted to make a request. Next gen comes easier to us because NIC teams are there in all the districts, as you would know. So it is very easy to maintain and very easy for us to, solve the queries also when it comes to management. So if that can also be integrated, it would be really
We will examine, we will see, the team can visit there and we will see.
Sir, thank you,
Thank
sir.
you for reporting. So thank you.
Thank
you
you,
all.
sir. Ladies and gentlemen, please join me as I extend our heartfelt thanks to Shri Harsh Manglaji. Thank you so much, sir. With that, our next presentation focuses still on the same concept of IPHL, BPHU, but this time we look at it from the operationalization perspective. May we invite Shri Kaustab Giriji, Deputy Secretary, NHM2, to join us on stage and take us through the presentation. Good afternoon, sir. Welcome.
Hello. Good afternoon, everyone. So I'll be speaking mostly about the operationalization of the IPHL and the BPHU. So in the past 4 years, JS Policy Sir has also showcased that how infrastructure is actually being created, but still there is a lot of gap between operationalization. So the temples are being created, but consecration has not happened. So there are some bottlenecks and challenges that we think the states are facing for operationalization. So we are trying to dispel some myths and facilitate states that these centers are operationalized. So if you see IPHL, so the name contains everything. Integrated Public Health Laboratory. So integrated, so unified. So there are, under various programs under NHM, there are a lot of disparate laboratories set up in the district hospital. So we want all those labs to be integrated. Then public health. The comprehensive public health systems approach, we want that the integrated public health lab have to have this health system approach. And lab, as the name suggests, it's a diagnostic hub. So we want that the IPHL, through IPHL, diagnostic services at district level is strengthened. Infectious and non-infectious disease surveillance aspect is also taken care of. Then capacity building of BPHL and CHCs, like it will act as a training hub for all the BPHUs and the BPHL at the block level. And it should collaborate with the block level as well as at the state level and various other laboratories that are there in the state. So the status is this, out of 744 approved, work has started in 591 units, 279 units are completed and around 213 facilities are functional across the country. So this is the process flow and infrastructure for the IPHL. The construction area that it's a flexible thing, but as per the operational guidelines, around 4,000 to 5,000 square feet is what we are envisaging an IPHL should have. The construction period is also normative, 9 to 12 months. Capital cost, including the equipment, some of the participants were asking about this. So 1.25 crore is the capital cost, which includes the equipment, and recurring cost of 49.05 lakhs is also being provided. So this is how the process will flow for the IPHL. The patient will enter the hospital, and most of the hospitals have these HMIS applications, either through e-Shushruut or through e-hospital, or some state-developed softwares are also there. So through this registration, the patient will get registered itself, and after referral from a doctor to the, for some sort of pathological or other laboratory testing once recommended by the doctor, he will enter the IPHL. So this is the enclosed space of IPHL. The patient will enter the IPHL. The entry will be there. There are this software through which automatically the registration is pushed into the laboratory software. So from there, the patient will have his or her sample collected, and he will exit. So this is the uniform, mostly, this is how the interaction will happen with the patient and the IPHL. Now, after sample collection, the sample will go for processing, then it will get validation, approval, report will be generated through LMIS, and the report will be sent to the doctor, and there will be an upward flow of information. So through the LMIS, and if the report has some public health aspects, then that report will be, the data will be pushed through IHIP platform, and the data will flow to the central dashboard of IHIP, so that it will help in the surveillance aspects as well. So LIMS, there is a separate detailed session on LIMS, so I will not go much in detail, but just to give an idea that most of the district hospitals and medical colleges have this HMIS, and LMIS is a part of this hospital management software. For example, e-Shushruut and e-hospital has this LMIS, which needs to be activated and integrated with the hospital module. So there is a separate session. I will not go much in detail about that. So IPHL and BPHU, the concept is that there will be upward and downward linkages. So the downward linkage is that the IPHL will act as a hub for all the laboratories which are at the block level as well as the PHC level. And it will also have these upward linkages with the state lab as well as the national apex labs and the regional laboratory network. So there's also another session on the linkages as well. But just to give an idea that how IPHL fits into the entire gamut of things. So human resources. So many, as we have already discussed, and many of the participants, the honorable secretaries have also questioned that how do we run the infrastructure that has been created. So I am just giving an illustration with this. This probably will solve most of the doubts, but I hope that this is a very useful slide. So the minimum HR required for the district hospital functioning as per the IPHS norms is the first column. The specialists, there are 3 specialists recommended: lab technician 11, DE or data analyst 1, sanitation staff 2, and total the staff required for IPHL HR requirement is around 17. As per the operational guidelines of PM ABHIM, recurring support is as a part of IPHL, and HR support is provided for 6 personnel. So if you can see the illustration, this is a live example. This is a laboratory in Mizoram. So there are specialists 3. Already they have the HR in the existing IPHL setup. So they are using that, the state laboratory which was functioning previously. They have just utilized those resources for running the IPHL as well. Lab technician, they have 11. They have recruited 3 through PM ABHIM funds. DO analyst, 4 are there. 1 they have recruited through PM ABHIM funds. So the IPHL can be made operationalized through the existing HR which was there running the district health laboratory which was previously in the district hospital. So PM ABHIM is a kind of a supplementary funds. So after doing some gap analysis, support can be taken from PM ABHIM so that the whatever infrastructure is created can be made operational and functional. Besides this, the IPHL will also act as a training hub, and it will train the lab technicians and HR at the block level and the PHC level. So with respect to the services, there are, the FDSI source states that there are around 105 tests which are being carried out at the district hospital across the country. The range is from 32 to 134. So the range is very large, right from very limited test of 32 to 134. So IPHS mandates that 134 tests are to be carried out at the district hospital level. The various test area and the number of tests are divided and shown here. And the major the equipments which are required for carrying out these 134 tests are also given. So you can just go through this. So the monitoring and functionality. So we have prepared a checklist to determine whether a particular lab will be determined as functional or not. So these are the major indicators: the service delivery, surveillance, training, and others. With respect to service delivery, like how many clinical tests are being carried out, what is the turnaround time for those tests, whether IHIP and LMIS reporting is there or not. With respect to the surveillance aspect, whether outbreaks are being reported on IHIP or not, and whether the outbreaks are responded by the rapid response teams. Training, whether HR is being trained on surveillance, and there are others like reduction in OOP or not. So functionality assessment checklist we have already circulated, and based on that checklist and the assessment, around 200 facilities are functional right now in the country. So these are some of the photos of the infrastructure that has been created in Tamil Nadu, Telangana, Chhattisgarh, Rajasthan. Lots of pictures are there with us, but these are the very few illustrations and examples that we have provided. Now, coming to block public health unit. So as the name suggests, block, it will be at the CHC level or at the block level. Then public health lab. So it will be an integrated surveillance and diagnostics. So it's not just limited to the laboratory or diagnostics, but surveillance is an important aspect. And unit. So it will have public health surveillance, laboratory, and HMIS cell. I'll talk separately about that. So major objectives is that the public health capacity will have to be increased at the block level. Then it will provide comprehensive diagnostic and preventive services closer to the community. Disease surveillance, outbreak detection, and epidemic response. Facilitate referral linkages with higher level health facilities, and monitoring, reporting, and data-driven decision-making at the block level. So this is the current status: 2151 approved, work started in 1709, work completed in around 850, and around 700 are functional. So these are the various components. Most of the interaction that we had with the states, they consider BPHU as BPHL only. They think that the main function of BPHU is to establish a laboratory, but it has other components that are very essential with respect to pandemic and surveillance aspect. So there is public health surveillance. So surveillance is something that the PHSU will carry out. So disease surveillance is the main function, public health response and trigger alerts, the intersectoral convergence and One Health. So this is an important aspect that the surveillance unit will carry out. Community-based screening, then laboratory, then they will carry out this diagnostic investigation, then it will act as a hub for the peripheral health facilities, and they have to timely report the data. The HMI cell is also envisaged to be created at the block level. It will carry out the data analysis of the surveillance data which is being captured. Then it will also have a cross-disciplinary data analysis with respect to the animal husbandry department, the environment, the human health, the other departments which are involved in One Health, and integration with IHIP. So the BPHU infrastructure, as per the guidelines, it's a normative one. 2,500 square feet, BPHO, the lab will be around 100 square feet, 1,000 square feet. The surveillance unit around 1,000 square feet, HMIS cell around 500 square feet. The construction period is around 9 to 12 months. Capital cost is 80.96 lakh, which includes the equipment, and recurring cost is around 20.145 lakhs. So this is the process flow. More or less the lab aspect will be the similar one, but there are these two main units, the public health surveillance unit and block HMIS cell, which will have a very important role in surveillance part. So this is how the public health surveillance unit and HMIS cell process flow will be happening. There is a provision of epidemiologist or the entomologist at the public health level, at the block level. So the community surveillance will be carried out by the epidemiologist or the entomologist. Similarly, there is a provision for data manager, a data analyst at the block level. They will compile, so the community surveillance will go out in the community, carry out the investigations and whatever surveillance activities have to be carried out. They will bring the data will be compiled, analyzed, and actionable insights will be taken out by the HMIS, by the data manager and analyst. And they will also then create a alert. If required, they will send those alerts to the rapid response teams. Then they will also transfer this information and actionable insights to the district surveillance unit, the state surveillance units, and then those will be integrated with IHIP. They will also have this additional responsibility of capacity building and preparation of block health action plan. So this is also another illustration that how support is provided under PM ABHIM for filling any gaps which are there. So this is the number which was required as per IPHS. Support is being provided under PM ABHIM for this HR. And example is that the HR in BPHU, this block medical officer was already there. Epidemiologist was engaged by one of the state through the PM ABHIM funds, and lab technicians, program managers. So you can use the funds, that recurring support that we are providing for engaging HR, so that this BPHU is not functional only for lab purpose, but for surveillance aspects as well. So this is the lab. Around 15 to 97 tests are performed as per the FDSI, and as per the IPHS norms, 97 clinical tests are mandated. So this is the same functionality checklist. We have already shared it with the states. Similar aspects of service delivery, surveillance, training, and district health action plan and reduction in OEP are the components, the parameters through which we are determining whether the BPHU is functional or not. So these are a few of the examples. Thank you so much for the patient hearing.
तो ये हमारे यहाँ पे what we have is BPHU only at the Taluk hospital, what the terminology we use. What you mentioned now, CHC, so that gives scope for a much larger number of establishment of BPHU. So one lab which is at the Taluk hospital, I think the more focus there at present is on the lab, diagnostic lab part. Once it comes to CHC, one is it will have in the same Taluk, one will be a Taluk hospital, another will be one block PHC or CHC, where this lab can be established, and then it can have more surveillance role also. Can that be done under the norms? I am not, my team is there, so they may be knowing more details, but two labs can be set up like that?
Sir, generally, the IPHS, we have designed the entire scheme according to the IPHS norms. So I'm not very sure where Taluk Hospital falls in our entire healthcare delivery setup. Subcenter, then, which is at the population of 5,000. Then we have PHC, 30,000. Block level CHC is around 1,120,000. And then comes the SDH and district hospital. So whatever block we are saying is at the CHC level, which is catering to the population of around 1,00,000 to 120,000.
1 lakh to 120, whatever CHC population is.
Yes, sir, that's the...
Taluk is much bigger slightly, 2.5, 3 also it goes.
So provisioning that we have done is for block level.
Sir, I have a question, sir. Vinay, sir. This is with respect to block public health unit. So lab is one component, sir. In Kerala, we have been focusing on devising a detailed SOP for the surveillance part also, sir. So not just the CDs, communicable disease, we have tried to include the other programs also, the RCH program, the non-communicable disease also. So I just want to know whether there is a detailed SOP or guideline issued by the ministry with respect to the working of the surveillance unit of BPHU, sir.
So there was a lot of back and forth on this guidelines for BPHU. So we are under the process of finalizing the release of guidelines, and we will release it in another couple of weeks, maybe. Yeah, but it required a lot of deliberation, so it took a lot of time for us to finalize that.
Two things.
Sir.
One, I think the surveillance at block level does not make too much of sense. All the digital data is coming anyway at either UDSP or IHP or whatever state's platform have. And they will do the data analytics and give it to the block rather than the blocks making their own analytics. I think that is an easier model than each block doing their analytics. That is one part. In the process flow that you mentioned of IPHL and BPHU, I think one, you showed that the report is coming to the patient and the doctor, right? I think at that time, we can easily, in today's technology, take the report directly to the patient through WhatsApp or SMS. Instead of, so that can very easily be done, and it will reduce the out-of-pocket expenses of thing. Thirdly, and this is a major point, IPHL and your IPHS norm assume that all districts of this country are of same size.
Yes.
Blocks of this country are of same size usually, 1 lakh or 1,50,000 from CDP days. But the districts are of not same size. So when you say that IPHL norm is this, or an IPHS of district hospitals is this, we must keep into mind that it is not same. A district in Mizoram and a district in Uttar Pradesh is not same. So you might have to rethink about these IPHL standards based on the size of the district.
Okay. Very well, sir. The first part, sir, you talked about surveillance at block level, sir. So this is the learning from the pandemic, sir, that the surveillance activities are not being carried out properly. And because the block level has the, if it is equipped, it will be easier to carry out surveillance from that part is what the various committees and the learnings that we had from the pandemic, based on which this scheme was devised. So it's point well taken, sir. If few of the states think that surveillance is better carried out at much higher level, and the insights are provided at the block level, that is also okay. But we think that surveillance can be a part of the manpower which is deployed at the block level. But it varies state to state. Another thing is, sir, another aspect is, sir,
so the rapid response teams are actually at the block level, they go and do it. Outbreaks happen at the village level. So that's what we want, that the same team is equipped and trained for doing the analysis. Yes. Yes.
So another aspect is, sir, they are also doing the preparation of block health action plan, which is an important component, because we are trying to integrate PM ABHIM, NHM, all the health related aspects. Because a dedicated manpower, a data analyst is there, then probably he can provide a comprehensive health action plan at the block level. Another point that you made is with respect to providing report to the patients through electronic means. So LMIS, once it is established and operationalized, the entire digital ecosystem will be in place. The reports will be made, the reports, because LMIS is there, the whatever flow of information that we had said, it will be digitally, sir. Telangana is already doing it. They are providing through WhatsApp, the pathological reports directly to the patients as well as to the doctors. So if LMIS is implemented, I think that aspect will be taken care of. Third portion is with respect to the size of districts. Sir, that's a very big policy decision, I think, because IPHS will require modification. IPHS 2022 is what we'll have to then explore, that how do we change the size of, instead of uniformity in the size of districts.
We had already per district or per block. It should be population because IPHS norms was population based. Right. So
Sir,
maybe PM ABHIM 2.0 we can think on this and then
Sir,
do it. Yeah.
One question regarding the costing norms of the IPHL. One question regarding the costing norms of the IPHL and BPHU.
Okay.
For those where it is set up within the existing setup, then it is feasible. But when we are constructing the new, it is not getting within the same cost, because as per your reports, construction 3,000 rupees per square feet, and for 3,000 as a 2,500, it's costing 75 lakhs only for the construction component. Then equipment components taking almost 40 lakhs. Similarly for the IPHLs. So there is a need to relook on the cost components or giving the scopes for them.
So I understand there is no one-to-one mapping here for IPHL. That 1.25 crore that is being provided, it is a capital cost. But to construct an entirely new lab setup in 1.25 crore, including the equipment, is not feasible. So that is why, see, PM ABHIM has been, there are budgetary and resource constraints. So we hope that state will use some prudence and do gap filling through PM ABHIM rather than constructing entire new lab setup. If it is required, then it is fine. If it is required that the district hospital is something which has a very bad lab or very dilapidated lab, then the entire cost may be used for construction of the 5,000 square feet lab. Probably, but if the lab is there which can be refurbished, which can be used, some sort of plus minus can happen. So that is something that we expect the states to probably see how best and optimally utilize those 1.25 crore that we are giving.
Because
but one-to-one, I
increase
understand
the load.
Once
possible. We are going for effective surveillance, it will increase the load. Present hospital facilities, lab areas is only for catering that hospital, not for all. When we are carrying the samples from the whole district, then automatically that would need. And in labs, there are issues of the sterilization, issues of the maintaining the temperatures, everything, access controls, that would costing more. So there is a need to read.
The challenge is there with respect to resource. We'll try to, for PMIM 2.0, we can probably try to increase the envelope for laboratories, but as of now, this is the norms that we have. Probably state can supplement those funds.
This is what I was coming to. State has to supplement. See, because this was just the basic infrastructure and the operational cost for 5 years that was given. After that, PM ABHIM guidelines are very clear. Suppose tomorrow there's no PM ABHIM 2.0. We don't know. We'll be proposing, but if it is not sanctioned, the entire burden, the state has to take it forward.
Because, ma'am, during the review, observation comes from the civil wings that they have built the buildings, but the soft components, furnitures, they are missing, ACs, they are missing, autoclaves and these components, they are missing. So making it functional would remain the issue. Wherever hospital have, they have made it functional, but for certain we need.
Just one more, just you, they're sitting here, you may be aware, I'm just flagging it. This, you mentioned e-hospital module. E-hospital module, and Sushruta, you mentioned that these do have LMIS module. But what we came to know there is, LMIS module, it is only basically capturing information. What is critically required there is this machine, whatever diagnostic machine reads the parameters. That should be subsumed in the software. That doesn't happen. For that, we have to again approach some private vendor, and they give some other patch. We have been trying to convey to NIC if that can be done. So just through your forum, I'm just flagging it. If you are aware, it's fine. Otherwise,
yes, I understand, sir. Like Chhattisgarh has done that aspect where the readings are being automatically captured through the devices. In the software, there is no manual entry. So, I think one size fits all approach will not work here. States probably may talk, we can facilitate through NIC because the equipments and their specifications are different in different states. So even if we prepare one module for all the states, it may not work for all the states togetherly. So probably we'll have a discussion with NIC as well, that what is the best thing that we can do so that the manual intervention is minimized.
Sir, good morning, sir. I'm from Jharkhand. Yeah, here, yeah. Sir, I'm from Jharkhand, and already IDSP has the provision of strengthening of district public health laboratory, and now we have IPHL, and as we have showed that it could be a downward linkage, and equipments are in DPHL for testing of epidemic-prone diseases, and as per the IPHS norms, in IPHL we are having the 34 testing for microbiology side. So, and equipments are same in both for microbiology aspect of testing. So, it could be a converted in a DPHL can be converted into IPHL, because the moment we start establishing IPHL, then this concept of DPHL will be same, or it should be merged in the IPHL. That is my question.
So, if I understand correctly, you are saying there is a DPHL,
yeah,
which is a separate setup
under IDSP, yeah.
Under IDSP, and IPHL is which is established at the district hospital.
Yeah.
And the DPHL is at what level?
At district level.
Is it a part of district hospital or is it a separate?
Yeah, through
entity?
IDSP program, no? Through IDSP program.
Through IDSP program.
Yeah, through NHM IDSP program, DPHL is mandated at district hospital for testing of epidemic-prone disease samples. And now IPHL having all the things, integration of hematology, pathology, microbiology. And as IPHL norms, there are 46 testing for microbiology side. So now DH has having the own DPHL, and now under PM-ABHIM we have to establish IPHL. So this could be a downward linkage. Yes. So as we have shown the hub spoke for BPHU, samples will be coming to the IPHL. Yes. Then this DPHL will be still existing and should be merged in IPHL. That is my question.
So,
because grants in AD is coming through IDSP NHM across the country. Yes. For testing of epidemic process sample at DPHL level.
So this aspect we had encountered while we had visited Uttar Pradesh as well, that they were given approvals for establishing this district lab, public health lab through IDSP. So what we suggested to UP and for other states as well, if it has been set up, if it is already set up, probably try to integrate so that the efficiency can increase, because you'll be deploying all the personnel at that public health lab as well, then IPHL as well. So it is better that if you can integrate, if the IDSP functions can be carried out by the IPHL, there is no need for a separate public health laboratory which is catering to only IDSP functions. So if it is approved already, you can surrender those funds as well, because this is duplication.
No. I think already since 8 years back, suppose that capex cost has been given for establishment of DPHL, and now for running of the IPHL, we are having the capex and opex cost both. Okay, and equipments mostly for DPHL and IPHL both are same. So already grants in add for OPEX every year coming through IDSP network under NHM. And now IPHL has also OPEX cost 49 lakhs and CAPEX for equipment buying 1.25 crores.
No, you can integrate it.
Okay.
This is what we believe, that integration is required, because probably few years back it might have been approved, but now because the IPHL concept is there, which is a very whole and bigger, it is all-encompassing concept. So I think we can discuss and probably find out that how many such parallel laboratory networks are there, and if they are doing the same function as is being envisaged under IPHL, probably then some sort of integration has to happen. There is no point in having two labs doing same functions, same manpower, doing the same functions. So.
Sir.
So this is Dr. Hiten, I'm SSO Himachal, sir. So just a submission.
I'm not able to.
Hello?
Yeah, better.
Sir, just a submission regarding LIMS. Actually, in our state, we are through ECRP funding, we got to have HIMS, which is e-Sushut also. So the basic challenge, what I would like to apprise you all is that when we talk about LIMS, so the doctor should write the prescription and he should prescribe the test. Then only the LIMS picks it up, sir, for like, fine, in the lab we can integrate them through wiring and all through the software. But however, finally, it runs only if the doctors from the OPD and indoor, they write tests and those tests get tested. Then only, I mean, the beneficiary will also get benefited, that he will, I mean, the response time will be good for the test and all. So that part has to be taken care of. That means that you have to apply the HIMS in the entire hospital. Then only, sir, the LIMS will be successful.
No, what is the question?
So this is the challenge we are facing, sir, right now. So I don't know how LIMS would be implemented for IPHL, sir.
So LMIS is, most of the softwares, the LMIS is a part of the hospital management software. There is, what we have seen is that LMIS is not a standalone software. It might be in some places, but mostly the e-Sushrut and the e-hospital application has the LMIS module integrated into their hospital management software. So it is something that the vehicle has the engine part, the boot part, the tire part. So one of the aspect is the LMIS module. So I think if you think that if you want that the without doctor's prescription, the LMIS should function, is what I think you are asking.
Yes, I am just saying that this would be a challenge because...
Sir.
Thank you, sir.
Okay, we can discuss it probably separately because time is running out.
In the interest of time.
Dr. Abhyuday sir, Nodal Officer, Chhattisgarh, regarding LIS. Actually, we have implemented LIS before without integrated system. It's a separate standalone for the lab only. There is no issue if doctor is not writing lab prescription through LIS. It would be possible that you can do alone with the lab manual only. But now we have started with NIC, what ma'am said, we have started with NIC. My request is, sir, we are, because the pre-analytic, post-analytic and analytic phase, which mentioned in the IPHL guideline, it won't be possible without integration with LIS. So my request is, sir, NIC software can also integrated with our lab. We have already tried, but there is no dedicated person in the NIC Delhi because there are some partners who are providing integrated services for this lab software. They are doing this work, but for which we need a dedicated person at NIC at the national level and even at the state level. State level we have identified, but we are not getting support from the national level. So if we get support, then we can immediately roll out in our next gen this LIS module. Thank you.
Okay, we'll talk to NIC for this.
In the interest of time, ladies and gentlemen, we draw the presentation to a close. If I may please request you to give our speaker a round of applause, and thank you to all of our people in the audience who have shared your questions as well, sharing those real-time experiences. With that, our next presentation is titled NQ ACE for IPHL. It is my pleasure to invite onto the stage Dr. J.N. Srivastavaji, Advisor, Quality and Patient Safety, NHSRC. Welcome, sir. Quality, as we all know, has already been touched upon as an overview in one of our previous presentations as well. This time, we hand the floor over to Dr. Srivastava to take us through it in depth.
Thank you. So, very good afternoon. And in fact, I'm aware that I'm talking to top policy makers of the states and the program officers also, they are there. Just I will touch upon the few critical points because I have been hearing with a lot of interest on the issues pertaining to the operationalization, be it for the infrastructure, or the HR related, or certain, say, information flow related, whatever the portals are there. But within this whole framework, if my leakages are not plugged, then perhaps the out-of-pocket expenditure may not reduce on account of the diagnostics, whatever is envisaged. The short point I'm trying to make is that we are aware that when a patient gets referred from any facility to a higher center, the first task a doctor does it to ask for the repeat investigations. And the reason is very simple, that there is somewhere the trust deficit on the reports which have been put up to him or her. And we also know that in our country, about 17 lakhs people, I'm repeating again my figures, 17 lakhs people, they lose their lives because of the poor quality of care. And the lab plays an important role in that. In addition, when the patient goes to the hospital for some other sickness, he contracts some other infection, and about 80,000 people, they lose their lives because of that. We also know that the cost of the treatment is going up, and in the coming 2 years, no new molecule is in the pipeline. So with this, whole conversation, so unless our request would be that my presentation is very short one, so I will just come to the crux and the key points. So the quality assurance component has to be thought of now itself. With the 700 BPHL or BPHUs getting operationalized and 200 odd IPHL getting operationalized. I must acknowledge over here the state of Chhattisgarh, led by Commissioner Health, Dr. Priyanka Shukla, that at least this has been the first state, ma'am, that we have received application from your state for NQAS certification, for IPHL, though the standards were launched last year. A quick one, without bothering much on the statistics. We all know that for different countries, there's a problem of diagnostic errors taking place, and the trust factor I have already mentioned. And to manage a case of hospital-acquired infection, which are there approximately about 20 lakhs documented one in India, one case costs about 1 lakh rupees extra in managing a case, leave beside the human suffering what it causes. So the infections are important. Let me come to that. So there are many initiatives which are already in place. It is not something I'm talking new. But when these labs are getting operationalized, and Director NHM, Mr. Harsh Mangla, explained about control and assurance, I will not take you over there. Our request would be that kindly ensure, and that is where the policy decisions should be required, that each lab has some controls, quality control, and they are pretty expensive. So whether it becomes the part of PMABHIM 2, or in the current things, or it comes from the state budget, center budget, but all these labs will be needing that. Though it is not the part of my presentation, but I thought I will utilize this opportunity to mention this point. Second point I want to make is on the calibration. If my equipments are not working, if it is not giving the correct reading, then obviously the whole efforts are going to be futile and the treatment will not be all right. We all know commonly the NCDs, the blood pressure, and other related things. So the calibration becomes important. Third important thing is that every lab must join an EQAS. Is this the External Quality Assurance Program for hematology? It does not cost much of the money. You will be surprised, just it costs about, say, 6,000 to 7,000 rupees annually for the hematology, for the blood test. So, we all know CBC and other related stuff. So please insist with your program, manager, whoever is there, the colleagues sitting at the rear, that, I'm sure that as a health secretary, as a mission director, you will be able to spare that kind of money. So it is a question of putting the things in an operational framework. So every lab joining EQAS program for hematology, AIMS, Delhi could be. There are many state level also the labs which are giving that. And for the biochemistry, the critical would be like we have been recommending from NHSRC looking at the cost, CMC will load. And it costs about say 12,000 to 13,000 rupees. So, but challenge is not the financial resource. That is where I'm requesting for your intervention. Challenge is in putting a practice in place and which helps which increases the credibility of the lab reports that would go a long way in strengthening the system after having invested so much of money. And within these frameworks, all of you are too aware at the at the state level. These things have been in place over a period of time. And in the IPHL framework also, it talks about the quality and patient safety, the safety compliances. And last year on 28th June, in fact, it is more than a year, this NQAS for the IPHL was launched. And today, I'm thankful to ASMD and Joint Secretary Policy that today this document has been launched. And on the infection control, as of now, what is expected is that at least the people who are there, they will recognize. And as a first step, we are just giving the case definitions, so not something beyond. And the system has to be, because if I look at whether it is the ICMR or NCDC, many efforts have been undertaken, but they have been limited up to the medical college level at the tertiary care. When we are moving downward, even the district hospitals are getting converted into the medical colleges, unless we ensure these practices in place, our results may not be there. And we all know that how does it help? I just want to flag one thing, that as a country, as a state, still we don't have benchmarking of our health services. The hospital-acquired infection, it happens in the best of the health settings. But do we know that where do we stand today? A rough estimate is about 15 to 20%. Whatever the control studies have been undertaken, those are in the tertiary care centers in a very controlled environment like AIMS, CMC, or certain other tertiary care institutions. So it is high time that, post-COVID, the government has been investing, that we should know that where do we stand today. And the first only the step becomes that my case definitions are very clear, that the people at the field level, I know I'm not requesting for extra manpower that though in the ideal scenario, there has to be an infection control nurse and other related. I'm only requesting that let's make a beginning to identify a person, at least in the district hospital, who gets trained in the infection control in recognition of those cases, and then the journey begins. So these things are there, and we all know that why the formal accreditation is important. That becomes a kind of wake-up call. Though many advanced countries, they are moving away from the formal accreditation because those systems are so advanced. But in a country like India, in the low resource setting where we are working, it is still needed. And there are enough evidences. I will not take you through there. And these standards which I'm talking about are globally recognized. There is a body known as International Society for Quality in Healthcare and ISQA. So being the part of the government system, these standards are, like in the country, NABH and this NQAS, they are accredited by them. So is our training program, and so is our role as a certification body. As a mission director, as a health secretary, that is another request specific to you will be that please ensure that those people are deputed for these trainings who have that kind of aptitude. Without naming a state, we find there is a challenge that somebody comes who is not going to perform that kind of, say, responsibility. The back of envelope calculation is that to train one quality assessor costs government about 80,000 rupees. If I take direct or indirect costs, everything taken together. And since, you would also be interested in looking at the cost part. So these structures are in place. I'm not repeating that, but whenever you are reviewing the program, ask for at least the NQAS score of your IPHL, whatever is there. And if you start asking, and I'm sure that, Principal Secretary UP, sir, you will, after you have started reviewing, I know that program has picked up in the state of Uttar Pradesh. So these structures are in place, And so obviously there are, the standards, then checkpoints, departmental checklists that we will be sharing with your program officers. We'll move on. And broadly, this talks about, the point is that on point number B, the critical is that availability of the service. The second is that safeguarding the information, which in fact, a lot of conversation was taking place that how the data will flow from one level to another level. And you got to be strengthening the state certification mechanism, because at the Government of India level, when we project the data, we always take into the account that how many state certified are there, how many national certified, both taken together. It is not, so unless that mechanism is strengthened, the things will not. Post-certification, there are many activities which are required to be undertaken. Many efforts have been undertaken in building the capacities, but some more will be needed. So, and these are the certain actions. Now in HI surveillance, I will just take you to the last slide, which will be of interest. This is my last slide. So as of now, we have just started with the case definition. And this year, we want to, at least in the 50 district hospitals, so our request would be that kindly identify that which are 1, 2, 3, that bring upon your state, where this, at least the case definition part could be implemented. And as we progress, the other requirements will be projecting. And later on, in fact, maybe that after 1 year, 2 years, the whole thing flows in a centralized dashboard where we have the country-specific benchmark and you also have the state-specific benchmark. So these are the couple of requests, and thank you very much. Thank you.
Thank you, sir. I think we have a few questions already to start off. Should you have any questions, right there at the back, we have a table with a mic. Please do reach out to the mic, and requesting all of our guests to please identify themselves before you ask the question. The floor is now opened. All right, sir, I think we have a clear audience. Thank you very much. A huge round of applause. Yes, sir.
Dr. Srivastava, you mentioned that both NQAS and NABL are internationally recognized.
NABH, sir. NABH.
NABL is not.
NABH, sir, the NABL normally they follow the ISO standards, and NABL, the requirements are very stiff, which is like they follow the ISO 15189. So this is a bit, in fact, lower one and more towards the public health oriented.
So if, for example, in our state, many of the laboratories are NABL accredited.
Sir.
So if the NABL it is accredited, then can it automatically be considered that they are NQAS accredited?
Yeah, I mean, your point makes a lot of sense, and in fact, that is a very positive suggestion, and we'll certainly act upon on that.
Yeah.
Thank you, sir.
Thank you.
In MP also, we have 36 district hospital labs, now IPHL labs, which are NABL accredited. So should we move their NQAS application separately, or as sir suggested, it should be considered part of the...
Ma'am, give me a day. This is a new challenge. Give me just, 1 day's time. Let me go through. Because see, ultimately, why I'm not responding immediately is learning from the NABH. NABH, in fact, they have got the 3 levels of the accreditation. When it started, there used to be only full. But later on, they came entry level, then came the progressive, and then came the final. So I will have to, freshen my knowledge that what is the current protocol of NABL, and we'll certainly address this query. Thank you, ma'am.
Thank you, sir. Any further questions? All right. Thank you, sir, on behalf of everybody in the audience.
Thanks.
With that, ladies and gentlemen, our final presentation in the morning block, I'd like to welcome back our speaker, Shri Kaustab Giriji, to take us through the operationalization of CCBs. When it comes to the critical care blocks, we have a lot of thoughts, and that's what we're going to be taking a look at. Please join me as I welcome Shri Kaustab Giriji.
Thank you. So yeah, I'm back. With respect to operationalization of critical care block, I will not stand between you and your lunch. I'll try to finish it up as soon as possible. So this is the vision for critical care block. So critical care block are the infectious disease block. So after the pandemic, it was seen that the regular functions of the hospital were impacted because the normal wards were converted into the isolation wards, and the regular functions of the hospitals were not carried out. As ma'am had said, that knee operations were delayed, all the ANC services were hampered. So that's why to augment the capacity and treatment management of infectious diseases, and to respond to public health challenges and segregate the regular health services from the pandemic-related operations, this concept of critical care block was thought. So the critical care block or the infectious disease block is an extension of the district hospital or the medical college. And this is the status. 621 were approved, 447 work has started, 43 work completed, but functional is only 2 as of now. So during the regular times, so CCB and the medical college or the district hospital will be functionally integrated. There will be optimum utilization of resources. We hope that it will be optimally utilized. If a pandemic comes in the future, so this is how it will happen. The entry and this exit of the CCB, it will be a separate block. The district hospital will be a separate block. The regular services will not happen there. But stringent infection prevention and control activities will still be carried out in the district hospital. But for pandemic, isolation. Clear-cut demarcation between the pandemic-related cases and the normal hospital operations. So this is how the concept of CCB is envisaged. So CCB is also supposed to be a mini block, a mini hospital in itself. It should be self-sufficient. It should carry out all the operations, because if a COVID-related pregnant woman comes and she wants her baby to be delivered, so separate MCH wing should be provisioned for CCB, where delivery or the operations or the other regular functions can happen for all those infected cases as well. So as of now, we have approved around 621 CCB units. There are 198 100-bedded CCBs. There are 295 50-bedded CCBs in district hospitals, 228 50-bedded CCBs in government medical colleges. So the capital cost is around 44 crore, for construction 30 crore, and equipment 13.95, around 14 crores is provisioned. Recurring cost is around 7.91 crores, which it comprises of HR of 7.4 crores and other non-HR activities. Then for 50-bedded CCBs at district hospital level, capital cost is around 23.75 crore, including construction of 16 crores and equipment cost of 7 crores. Recurring cost of 4.5 crores, HR is provisioned for 4.3 crores, and other cost of 20 lakhs. 50-bedded government medical college CCB, capital cost is same, 23 crores. Construction is around 16 crores, equipment is 7 crores. There is no recurring cost provisioned for medical colleges, because we think that the medical colleges will be well equipped to run a small hospital block. So various critical care services should be provisioned under CCBs, like the emergency department. There should be a separate triage area. It should have close linkages with other departments, and diagnostic and support equipment should be equipped. Intensive care unit, it should have an isolated area for immune-compromised patients, isolation wards, oxygen-supported beds, high dependency units, then operation theaters, then labor delivery rooms and recovery rooms, newborn care corner, then dialysis units. Other services are also supposed to be provided through the CCBs. These are, the CCBs must be equipped, because it is an independent block. It should have a MGPS like a pipeline system. Oxygen generation, PSA plants. I hope that most of the district hospitals have been provided with PSA plants through PM CARES and other funds, so they can be used for generation of oxygen and provisioning those to the critical care blocks as well. ventilators and air handling units, effluent treatment plant, biomedical waste management system. These are the supportive services. I think the district hospital is already must be catering to all these services. So these are just ancillary services. They may or may not be a part of the CCB. So the human resources is like the existing DH or medical college HR will be used for getting the CCB operationalized. So for that, these are the general norms which we keep on repeating, that the state will create and fill up the regular posts. PM ABHIM recurring support is also provided. As I've just mentioned, that recurring support is already provided for HR. It is mostly for gap filling. Then optimum utilization, the already existing DH and medical colleges set up, the HR and the other equipments may be used for CCBs as well. So this is an example, Sihor, Madhya Pradesh. They have, it's one of the few CCB which have been operationalized in the country. The Sihor is a district hospital of 300 bed. The requirement as per IPHs across the various cadres is, I've just shown it here. The in position is 212 personnel. The CCBs, it's a 50-bedded CCB there in the Sihor. So the requirement as per the guideline is 101 positions are required. In position staff, which is working as of now in the CCB is 24. They have not recruited anybody under PM ABHIM. But if I just point out that with respect to nurses, the in-position nurses is 125 and around 10 nurses are being deployed. Probably at present only 10 are being deployed. But the gap is there with respect to 125 and 309. So that gap also can be filled through PM ABHIM. That HR support is because around 4.3 crore is being provided. The state have this flexibility of including any HR support they require based on their own analysis, that we consider that the nurses are the most important personnel, health personnel in the CCB. We want more of those, then they can use the PM ABHIM fund for those. If they think that specialists are more or critical, they want more specialists, they can use that, because the flexibility is there. The flexibility is there for the states to decide how they want to use that resource, the recurring HR support. This is another district hospital, critical care block at Guntur district in Andhra Pradesh. Similarly, if you can see, 170 are in position in the existing 300-bedded district hospital. The requirement is 527. As per the guidelines of CCB, 176 health personnel are required. They have deployed 62. So newly recruited under PM ABHIM, there is no health personnel recruited. In the GDMO cadre, 6 are being deployed for CCB and around 30 nurses are being deployed. So the states can think about using this 7 crores for probably filling the gap that they think that is required for making the CCB more effective and functional. So that flexibility is there. This is an illustration just to probably clear some doubts or myths that the state might be harboring, that we require 176 personnel to make any CCB functional. Existing DH and your medical college HR should be running the CCB as well. But if you require more support, some for gap filling purpose, some recurring support is being provided. So this is the CCB checklist for functionality, because hardly any, very few functional CCBs were there. We had not circulated this. We'll be circulating it very soon. But the most important aspect of CCB is the dedicated building and block. This is a sine qua non. This is the very essential condition. If we want to mark any CCB as functional, it has to have a separate entry and exit. It has to have a separate block. Few states had requested that we have created a new district hospital and we want only 50 beds, so we will dedicate 50 beds for this critical care block. We'll use these funds for constructing that district hospital itself. So that will defeat the entire concept of this. So even if you are using the existing district hospital block, you have to make sure that they have separate entry and exit. There is no mixing of air. There has to be a separate airflow mechanism for those demarcated areas which can be termed as critical care block. So there are various parameters on infrastructure, services, HR and equipment, and data reporting. These will be circulating and then evaluating based on the marks whether the CCB is functional or not. So for way forward, we expect that because the construction period is around 18 to 24 months, it will take some time. Identification of land is a huge challenge. But expedite timely completion of the units, at least those units which are under construction. Make sure that the completed units are made operational by utilizing your existing resources. If required, you can supplement it through the recurring support that is being provided under PM ABHIM. And integration for rational utilization of CCBs with the existing DH. Thank you. And because we will be taking our proposal to the Ministry of Finance for extension of scheme, as JS Policy Sir has already told, I will, at the cost of repetition, will emphasize that there are some parameters for which the outcome and output monitoring was designed during the previous EFC when we got the approval for the PM ABHIM scheme. So those parameters includes operationalization of CCBs, how many infectious cases have been reported, how many tests have been conducted. So we'll have to provide those figures to the Ministry of Finance. So unless some sort of operationalization happen, unless some sort of reporting happens, we'll not be able to put forth a very convincing case to the Ministry of Finance that we want to continue this scheme. So it's my request that at least try to complete as many works as possible and try to make those units functional so that we can report some positive numbers to the Ministry of Finance. Thank you so much.
Thank you, sir. We are going to pass around the mic. Good morning. Good afternoon, sir. Yes.
See, I slightly got confused. If you can go back to the last slide when you mentioned about making it functional. See, earlier we were talking that CCB in non-pandemic time, okay, it can't be made functional in the sense what we are envisaging it in the pandemic time. It will have to be a part of the hospital.
Yes.
Okay.
Yes, sir.
Right now in the hospital, there will be an OT, there will be an ICU, there is some allocation of places. So if it has to be a part of the hospital, some of the spaces which I have created in this new CCB, I'll have to reuse those for what is required now complementarily to the hospital. I can't create a separate OT, separate labor room right now because I have now 3 labor rooms separately, and if 2 labor room here, then there is a disconnect. Then already we are, you showed that how much HR is less in, only 40%, 50% vacancy. That becomes inefficient. So what I would request is, when we say functional, slightly be liberal in that space should be utilized. Now, we were also wondering now, ICU, CCU, 100 beds are put somewhere. Now here some 10 beds. So distributing that way will not be efficient. So we will have to utilize this space right now for certain other things, like dialysis unit I shifted. Of course, OT, I can't use it for some other purpose. OT has to be used as OT. But otherwise, a space is a space. It has to be. So that way, because you had marked that all ICU, everything should be functional, that would be a problem. Just keep that practical aspect in mind. Okay.
Sir, what we think is that, yes, we have to think of worst case scenario. So provision has to happen. Like infrastructure can be created only at the beginning. We have to make provision for all those things. How do you utilize in the regular times is up to the state and up to the district hospital authorities. If a maternal, if tomorrow pandemic happens, whatever infrastructure is there, it can be repurposed for our pandemic response, is what we think. For regular times, whatever you think is required for making the block functional, but if pandemic strikes tomorrow, within limited time, we should be able to make that block a self-equipped hospital.
Good afternoon, sir.
Can you please put on the presentation? So the HR one?
The two HR ones, yeah. Yeah. So I understand there are only two CCBs which are functional and that you have shown.
Yes, sir.
Right? So CCB is basically, as you say, is the worst case scenario.
Yes, sir.
When the worst case scenario happens, these 527 or 212 will not be fully functional here. They will be functional, but not fully. So actually, during that worst case scenario, out of this 212, some people will be working there.
Yes.
So your definition of CCB's functionality should not be based on right now what it is in position separately from the hospital. If you can change that definition, your functionality will increase. So CCB, what I mean to say is, you create the infrastructure, you keep it ready, use it for some purpose, and if such a worst case scenario happens, you move your HR from your regular hospital there. Yes. Then you can make it functional and can increase your numbers of functionality.
So we have, because of this only we had very liberal interpretation of functionality for CCBs. It's not a very stringent condition. If service delivery in some capacity is being started in the CCB, we are taking it as a functional. But for the reporting purpose, what we have to present before EFC is what are the number of infectious diseases, how many infectious diseases have been admitted under CCB, how many operations have been carried out. So for that reporting, if normal functions even you have started, we'll take it as functional, for reporting at least. But worst case scenario has to be kept in mind that it should, at least in some worst case scenario, this CCB should act independently. The structures and the infrastructure should be created in such a manner.
Good afternoon, sir. At present, there is no provision of constructing ramps in the CCBs. Though provision for providing 2 lifts have been provided there in the provision of budget 16.60 crore. But there is no provision for construction of ramps. I have discussed the matter with HSCC and they are saying that at least 2.5 crore per CCB is required for construction of ramps. I request if a provision is kept in PM ABHIM 2 for construction of ramps for these CCBs.
Construction of ramps?
Yeah. And one more thing, sir. There is no recurring cost for CCBs which are being constructed under ECRP 2. A provision should be kept for those facilities also, for ramps as well as recurring cost. And I have one more question, sir. Is it mandated that there should be an overhead bridge? A connectivity should be developed between district hospital and CCB. Is it mandatory or it is not mandatory to standalone structures can do it?
Second question, I didn't get the second question.
Actually, sir, there is a concept of connecting 2 buildings through an overhead through an overhead bridge. Okay. Is it needed for CCBs also, or standalone buildings will suffice?
So the question number 1 is with respect to the ramps.
Yeah.
So what we think is the IPHS 2022 is having provision for construction of ramp and all disabled-friendly infrastructure that has to be created. So I'll have to check whether, but I think it is a part of the 16 crore that we have.
But after having discussions with the executive agency, it is not possible for them to construct ramps out of these 16.63 crores.
Okay, I'll discuss it with you separately because I'll have to check with the team whether it is part or not.
Sir, for further operationalization, I will request you to cover CCBs established under ECRP 2 also. Those CCBs should also be covered now under PM ABHIM. Actually, ECRP 2 is going to wind up from March 2026.
ECRP 2.0, I think, yes, it has a sunset date.
Yes, sir.
So, funds have already been released to the state for ECRP?
The buildings have been established, but there is no, buildings have been established, but there is no recurring cost for ECRP 2 CCBs.
For recurring cost is not there in ECRP 2. Okay. But I think states will have to bear that burden.
But states will depend on center, directly or indirectly.
No, I have no answer for that. That how do you operationalize those ECRP?
One small
Sir?
question.
As the infrastructure has now been created.
In PM ABHIM 2.0,
Sir.
if you can rename the CCB as potential pandemic hospital or potential pandemic block, because critical care has a different meaning when we say critical care medicine. So as soon as you create a critical care block, people's expectation would be that it's a 100% functional hospital all the time. Whereas it is actually for emergency purposes, it will be less functional during normal times, and at the time of pandemic, it becomes fully functional. If you can use some other name.
Sir, I will suggest that some fancy name can be given by the states. We will put forth it to the Ministry of Finance that we want to rebrand this as some other. Yeah, okay, fine, sir. Okay, I think that is it.
Thank you, sir. A round of applause, ladies and gentlemen, for Shri Kaustubh Giriji for taking us through CCBs and their operationalization. With that, we now break our technical sessions for lunch. However, before we do in fact break, let me remind you to please join us back here at 2 p.m. Just like the first half of the day, from quality assurance to a whole lot of in-depth topics from operationalization, we've covered a whole lot of ground. The next part focuses on equally important relevant topics. So if I may please request all our guests to join us back at 2 p.m. so we can begin the next half on time. Thank you very much for joining us, ladies and gentlemen. Lunch is served. We hope you enjoy.
hospitals, and then the claim settlement. As you can see in the treatment part, there are two categories which are defined in the scheme itself, which was notified on 5th of May 2025. There are two categories. One is the designated hospital, and other category is about the non-designated hospital. The designated hospitals are those hospitals, there are again of two subcategories. One category is of those hospitals which are already empaneled under ABPMJY. So if they have the facilities, they can provide the establishment treatment and any other treatment for which they have these specialties. Whereas there could be other set of hospitals which don't want to be empaneled under the PMJY, but they want to get themselves empaneled, particularly for this particular scheme. So we are calling this as a CTRAV only hospital. The other category is the non-designated hospital, which is the category which is not falling in the first category, obviously. And this covers all the hospitals across the country. And these hospitals are supposed to provide establishment treatment in case the victim reaches to that hospital. The claim settlement is for the insured vehicle. If the accident has been met because of the insured vehicle or the insured vehicle is involved, then the GI Council will be processing the payment, and it is hitting the motor vehicle accident fund. And if it is other than the insured vehicle, then the claim will be processed. The final call will be taken by the district collector of that particular district, and then it will hit the PFMS system. So this is quickly about some of the salient features of the scheme. This scheme, the point number 1 and 2 I have already covered. Point number 3 is what is the time which is available for a district police for confirmation of the road accident. Now there is one very beautiful thing which is built in the scheme, is that it is defined the condition of the victim either as a non-life-threatening condition or as a life-threatening condition. So under the life-threatening condition, the district police has to confirm within 24 hours, that is the electronic detailed accident report, EDAR. It has to come within the 24 hours. However, in case of life-threatening condition, another additional 24 hours are given, so that makes it 48 hours. So EDAR can come in such cases in 48 hours. The full treatment, if a victim is already under the life-threatening condition, he will be provided full treatment for first 48 hours, that is till the time the EDAR is received. However, if the victim is under non-life-threatening condition, then in such cases, he will be given the establishment treatment only for the first 24 hours till the time the EDAR is received. Once the EDAR is received, I will be explaining in the upcoming slides. Now, this is quickly about the type of hospital, the designated and non-designated, which I have already explained. The special feature in this scheme, which has been built up by NHA, is the CTRAV only hospital. The CTRAV only hospital, as I've explained, they are those hospitals which have the trauma facilities. That is, they have the general surgery, general medicine, and the orthopedic facilities available with them, combined together. So that hospital can get themselves empaneled under CTRAV only scheme. Any other hospital which is already covered under the PMJY, these hospitals will be automatically empaneled as a designated hospital under the scheme. The second category is the non-designated hospital, which I have already explained. These hospitals will be providing only the establishment treatment. So that is quickly about the hospital under this scheme. Yeah. So this is about the workflow which was I was explaining earlier. So there could be three scenarios when suppose there is a non-life-threatening condition. So there could be three scenarios. Whether one is the EDAR is approved, EDAR is not received in 24 hours, or EDAR gets rejected. So this whole scheme revolves around the receipt of the EDAR from police into our transaction management system. So once EDAR is approved, the salvation and other treatment will be opened, and victim can be treated for 7 days up to 1.5 lakh, and the cost will be borne by the MORTH. That is for the uninsured vehicle, and for the insured vehicle, it is through GIC. If the EDAR is not received in 24 hours, again the establishment treatment will be given. However, the victim will be discharged from the scheme after 24 hours, and the cost will be paid by MORTH in such cases. and the EDAR is rejected, suppose the victim is not a genuine road accident victim, then in that case, though the establishment treatment will be given, because the moment the victim reaches to the hospital, he has to be provided the establishment treatment. However, in such cases, the cost will be borne by the victim or the patient. The other scenario is about the life-threatening condition. So if a victim is under a life-threatening condition, there is a difference now from the previous slide. So when the EDAR is received, the establishment, the only difference here is that the moment it is declared, the victim is declared as a under the life-threatening condition, all packages will immediately open without waiting for EDAR to come, and the treatment will start immediately. All the treatment will be given. However, the limit is again 1.5 lakh and 7 days, and the cost will be borne by MORTH or the GIC, as was mentioned in the previous slide. However, if the EDAR is not received in 48 hours, in such cases, again, just to promote that the hospital should not deny treatment to a life-threatening victim. So in such cases, the cost will be borne by the MORTH. Even if EDAR is rejected, again, the cost will be borne by MORTH. The only difference is that the cost will be limited to the treatment which has been given to that victim in first 48 hours of the admission. This is quickly about the cashless scheme workflow. This is the simplest form. There are many logics which are built inside the transaction management system. The NHA, that is the National Health Authority, is responsible for making the TMS. But this TMS system will be talking to the EDAR to get the police response. This system will also be pushing the claims to either to GI Council or to the district collector, depending on whether the offending vehicle is insured or not insured, which this information will be coming from Vahan. And then it will be hitting two different set of accounts which are under MBAV only. Either it is a TSA account of the district collector, or it is the account for the insured vehicle under motor vehicle accident fund. So this is the exercise we have already done in few months. We have already conducted training in 3 batches from 16 July to 24 July, and then also conducted theme-wise capacity building sessions on 25th, 26th, and 27th. That is very recently. We have also held overview the sessions with the CEOs on 11th and 18th of August, where we have discussed about the coverage under the scheme, the hospital embezzlement module, the IT system demonstration, and also we have had long discussions with the participants. There were a number of queries which we could answer to their satisfaction. It's not changing. Yeah. So again, we are planning 4 more sessions starting from 6th to 9th September, and we have divided into zone-wise, in which our target is to train the master trainers in the respective states. Here, that's the reason I'm here in front of you today. There were, when we asked initially from all the states, we received a list of 10,035 hospitals which are capable of providing the trauma care to the road accident victim. So this was as per the list provided by the states. But we cleaned that list, we found there were some missing entries, and therefore we could only ingest 6,063 data out of 10,035, which we have already given to CDAC. And CDAC has shared this data, has already integrated this data with 112, so that the person, the responder who is sitting at 112 can immediately know the location of these hospitals. Because in this scheme, suddenly one entry which was earlier there in our database, that is the geolocation, has become very important. So without the proper geolocation, the longitude and latitude of the hospital, it will be very difficult for that responder sitting in at 112 to direct the victim to reach to the nearest spot or nearest hospital. So remaining data, we have again requested the states. I will show you in the next slide, where we have requested the states to please update the data. There were some missing fields. Again, out of this database of ABPMJY Empanelment Hospital, we could find 12,824 hospitals which are fit for providing not only the establishment treatment, but other treatment as well, depending on the kind of specialties available with them. There are around, in the next few slides, I will be explaining about, there are around 3,000 plus hospitals for which we have again requested the states to update their records, at least to provide the SFR ID so that we can know about the longitude and latitude of those hospitals so that we can plot it and share the same with the CDEC for further integration with the 112. Now this is something very interesting. Now there are 34,000 hospitals. This is, I'm sorry, this is wrongly written. There are total hotspots available in the country are more than 34,000. So we have plotted these 34,000 hotspots on our country's map. As you can see, these are mentioned by red spots. And these are the 6,063 hospitals which are mentioned, the green spot. You can see there are some gaps on the map where there are no hospitals as on date, or the hospitals are there, but the data is not available with us for sharing the same with the CDEC. So if we plot these two, we can see the red spots versus the green spots. So these gaps itself, gives a reason that the state should identify more and more hospitals so that the victim can reach to the nearest hospital in the event, in the case of his or her accident. So this is the support required from the state. As I mentioned, the ABPMJY hospital, 12,000 plus hospital, we have already ingested and shared the same with the CDEC. There are 3,361 number of hospitals, and the list is shown here where we have sent 2 emails to these states requesting them to provide the details, because the missing items were HFR ID, the name of the enrolled person was not there, or the contact number was especially the geolocation. So this information is to be provided. Similarly, for the trauma hospitals, out of that 10,035 hospitals, 3,971 data was not correct. So we wanted this to be updated. And we have already sent an email to the states. So this is the support required from the states, the strengthening of the hospital network, to create the awareness and the sensitization, which is very important in this case, because without the active support of the state, this scheme will not be a success. And also to carry out the capacity building exercise, for which NHA support will always be there. That's all from my side. Thank you. So if there are any questions, I'm ready to answer. Yeah, please. Can you use mic?
I'm from West Bengal. I was just looking at the data and the number of, since I was a transport secretary also earlier, so I know the number of road victims. When you say PMJY in panel, suppose the state doesn't implement Ayushman.
Yeah, that's the problem. If there are West Bengal.
So we have our own insurance scheme. Why don't you take those names? We will run the schemes well. Why to go for any other thing? Think about it. At the end, we are also implementing a scheme. There is a Swasthya scheme that we do. We spend 3,000 crores. You cover that in all our hospitals there. We'll give you a list. Even if it is not implemented, take a policy call on it. That's what I wanted to say, because there's a huge network of roads there. There are road accidents.
Yes.
Find a way on that.
Yeah.
Thank you.
Thank you, sir. So I'll be sending an email to the person.
I think you deal with the transport department.
Yes.
Can you send the mails to us also, to the health secretaries also?
Yeah, sure, sir.
Because at the end we have to handle it.
Sure, sir. We'll be happy to have the data, but you have to provide the data in that particular
No,
format.
we will provide you. See, the PMJY or our scheme, both of them almost maintain the data in the same format. So if those hospitals are covered, definitely people will get treatment.
Yeah, sure, sir.
Thank you.
Thank you.
Sir, I just wanted to hear, sir.
Yeah, please.
Somebody else speaking?
Yes, sir.
Sir, there are 2 issues in my mind, sir. One is this non-empaneled hospital. This concept means that that hospital is now obliged to give treatment up to the stabilization. Now, one thing is, sir, I don't know, you people have put in my, this after stabilization, if that patient, first of all, it does not get stabilized, or should not be advised to be moved to some other place, that hospital which is non-empaneled, if it has all the facilities to provide further treatment for up to 7 days, whatever logic we are taking for payment up to stabilization, can't we extend that logic for non-empaneled up to the full period of 7 days, so that Now, whatever rates you will be paying, sir, I am not aware that what rate you will be paying up to stabilization. So that will be a fixed rate. The hospital which is providing stabilization will have to accept it.
Yes.
And now that person, let's say, is on ventilator or something, stabilization doesn't mean that you can now start moving that person. So one is under some law where we are forcing or where we are mandating the hospital to provide treatment. Can't we little bit extend it? We were deliberating in our state this Good Samaritan Act. Under that, our limited reading was that the hospital is mandated, obligated to provide treatment, and then government is obligated to reimburse at reasonable rates. The word there is reasonable rates, not at his actual rates. So we can always say that the rates what we are giving under the scheme, because it's a pan-India scheme, these are reasonable rates.
Yeah, so these rates, basically, there are 196 packages out of those 1900 plus packages which are otherwise there in the ABPMJY. So out of that, 196 packages have been identified by the committee of experts, which are especially meant for only treating the trauma, the road accident victims. That is one. Second is the scheme is notified by the Ministry of Road Transport, and they have defined that the non-designated hospital should be able to provide only the stabilization treatment. Because the rates are ABPNJY rates, so any hospital has to agree with that. And obviously when a hospital is, non-empaneled, the control over that hospital, the kind of treatment they are giving, or any court case which may happen later on will be very difficult for anybody to deal with. So that's the reason we have targeted the ABPNJY hospital as a first. And we have also given a freedom that such hospitals who are capable of providing treatment and they don't want to get themselves empaneled under ABPMJY, they can always come up for the CTRAV only, as a CTRAV only hospital where there's a separate module, they can empanel themselves under that module and become a part of the scheme. So nothing, that doesn't stop. For the established,
I was flagging that issue. I'm sure you would have deliberated all these aspects.
We have deliberated in detail, but we thought initially that let us increase the number of ABPMJY hospitals which can provide the establishment treatment as well as other treatment as per their the facilities available. And we want to identify more and more trauma hospitals. As I've mentioned, there are 10,035 hospitals, so there are around 3,000 more data has to come, 3,900 data has to come from the states. If it will come, it will cover a vast area.
Sir, another thing just connected to this is, we are getting a feeling that this is now a parallel system is coming, sir. Under PMJY, a lot of procedures are covered. Now, this is a sort of a parallel system. If it could have been integrated seamlessly. Now, for example, you are saying here that states have to share some hospital list for geolocation purpose because you have to share it with 112.
Yes.
Sir, this 112 ultimately is run by the state only.
Yes.
We are running it.
Yes.
Our 108 is linked intrinsically to 112.
You are.
Now, how we are managing for the rest of the victims or rest of the distress calls, in the same way we manage that. Those people who are CDAC might have developed the 112 software, but they are not driving that software in the states. They have given it either to the police department. Now in our state, we are trying to work with them for 108 also. So they give the software to us. And we use it the way we want, and we not only for these hospitals, for all other, whatever for different purposes, we may require the geolocation. So I was wondering that why are you so much, because it is like getting into too much of implementational detail. You are providing funding, sir, that is correct. And that the scheme is there that every hospital is obligated to provide. Now, these two concepts being there, could it have been sort of integrated with PMJY rather than now you taking stress for all these things that providing all these details?
There are differences between PMJY and MORSA, as I have already explained. The biggest difference is the number of packages which are there, 1900, here only 196. Even in the 196 packages, there are around 10 new packages which have been made especially for the trauma treatment. So those 10 packages are different, including the establishment treatment. So to provide the treatment on the golden hours. So there is a difference, that is one. Another difference is the 1.5 lakh rupees and 7 days. In PMJY, it is not so. And the third difference is that it is open for all nationalities. It is not limited to the Indian alone. And the fourth is that you and me are not the beneficiary of PMJY, so, but anybody can meet the accident. So in such cases, how that particular victim will be treated. So therefore, there is a need of a separate scheme. And there are many other differences, but these are the four major differences which I am trying.
One question, please.
Yes.
In Tamil Nadu,
The question is, the reimbursement fashion is basically two. Either the SHA will reimburse to the hospital or the district collector will reimburse to the hospital. So my question is, under PMJY, for example, SHA has an advance money. Will the GI Council provide the SHA and the district collector some advance money to quickly reimburse so that the hospitals are encouraged to, treat the next victim?
This point was thought of, sir, and the solution and the guidelines which says so is that the benchmark which has been set is within 30 days, the hospital should get their payment. And there is a TAT which is built in. If the GIC is not making the payment, suppose, in such case, in 10 days, it will go for auto approval. So GIC will not be given more than 10 days of having received the claim. And from that point, they will have only 10 days, that is one. Similarly, for the district collector, for the uninsured vehicle, it will be hitting the PFM system. The district collector is required to open the RBI account, and all those activities are already going on because the Ministry of Road Transport is planning to launch this scheme again in a soft launch in 6 or 7 states in next week or so, maybe next 10 days, and then pan India by the end of September, probably if everything goes well. So that's the reason I was sent here, just to introduce you briefly about the scheme. What was your question, sir?
My question was whether the SHA, for example, can have some advance money so that they can quickly reimburse. But you are saying GIC is obligated to give this.
Yes, it's 10 days. Similarly, for collector, it is 15 days. So collector has 10 days, and then 5 days additional were given. But again, in the PFMS system, they have to go with their DSC and then push the claim.
For a collector, number of cases will not be very high. But
Very
for
high.
an SHA for a state like UP, the number of cases will be very
GIC,
high.
for the GIC, it is TET. So and another thing is whether the vehicle is insured. If the vehicle is insured, GIC will have to pay. They cannot stop the payment for more than 10 days, otherwise it will get auto-approved. Even if GIC has any doubt, in that case also the payment will hit in another 10 days or 15 days, 10 days time. And later on, if something is, they want to discuss about this, then there is a proposal of a quarterly meeting between the GIC and the Ministry of Road Transport to settle such cases where there could be a dispute that a vehicle is insured, but another vehicle which met the accident is uninsured, and all those complications can be discussed later on. But payment will be made to the hospital, and that benchmark is 30 days, sir.
Whether a pedestrian hit by a road vehicle is
Yes,
covered.
motorized vehicle should be involved. It cannot be a belgadi or a cycle rickshaw.
But the pedestrian is involved.
If a pedestrian is hit by a motorized vehicle, the only thing is that EDAR has to capture that accurate details. If the EDAR says, yes, it's a genuine victim of the road accident, then yes, he will get the treatment. Yes.
This NK48 scheme, which is similar in nature, but only the difference is that it is again open to any nationality, but there is no EDAR, is not captured, and if a victim says that he has been a victim of a road accident, then it is taken in face value, and then all the treatment is given, and state government is spending around 100 to 150 crores annually. So we have written to GOI whether it is possible to reimburse the cost. But only thing is that our apprehension is that if as soon as EDR is introduced, it will again delay the treatment, and then hospitals will hesitate, and it defeats the very purpose for which the scheme is designed.
See, I will only repeat what Ministry of Transport has said in such cases. They said this scheme will take precedence over any other scheme because this is as per the Supreme Court directives. That is important. So once the victim, so you can spend 1.5 lakh rupees and 7 days, treat the patient. If the patient or the victim requires longer treatment, he has to be discharged from the scheme, and then the state can take over whichever way they want to treat him or her for the remaining time. This is what I can say. I cannot comment on what should be done by Tamil Nadu. Your scheme was the first scheme. There are good things, but the thing is, it is well integrated with the, with the IT system, with the PFMS, with the bank, with the EDAR, with the CDAC, the 112, the geolocations, the location of all the hospitals have been captured into this. So this is, we have been working for last 5-6 months, and we have come out with this particular IT integration as NHA.
So only our request is that if the state government is running a parallel program, at least Marth should reimburse that cost.
You have to make this request to Marth.
Yeah, we have been making requests.
Yeah. Okay.
Thank you, sir. Do we have any more questions? All right, ladies and gentlemen, please join me as I extend our thanks.
Thank you.
To Shri Sanjay Maharshi ji. Thank you so much, sir, for sharing the framework of CTRAV in detail. And with that, our next topic in focus is health sector disaster preparedness and response. It's my pleasure to invite our speaker, Dr. Pradeep Khasnobis, to join us on stage, Deputy Director General, Disaster Management Cell. He's going to be guiding us through our preparedness as a country and the response mechanisms that we have in place. Good afternoon, sir. Welcome.
Good afternoon, all. Respected dignitaries of the dais, friends, colleagues, I will just run through exactly, because this is a topic which is not dealt upon much in the health sector. It is generally the NDMS and the SDMS, NDRF, SDRF. But with passing time, country has also felt that this is a need that we need to be prepared with. Because whenever we talk about the disasters, when we talk about the health disasters, we don't have that kind of a bandwidth. It is generally the NDRF that goes ahead with just giving the initial treatment. So coming out regarding the introduction part, when we talk about the National Policy of Disaster Management, which is the NDMS baby, which mentions about the National Disaster Management Plan of 19. When we talk about the Ministry of Health becomes the nodal ministry for any kind of a biological disasters. So initial response is from this ministry, or maybe subsequently our sisters in the states. So India's preparedness, this is also having a bit bigger ramification into the international desk with the international health regulations in place, Sendai framework of disaster risk reduction, sustainable development goals. Everything talks about some amount of time about in disasters also. So virtually this is one such important topic that is also important and imbibed into the system of health, which we need to be a little bit mindful about. When we talk about the preparedness, it is about a whole hazard preparedness plan. Generally, when we talk about biological disasters, it is more towards, we look about only diseases, but when we talk about a disaster per se, it have to look into the chemical, radionuclear, and other disasters that can strike on us so that we are prepared for it. Because it is ultimately the humans who would get infected or affected, and then subsequently we have to take the care about. So for that purpose, it is generally a whole of government, whole of society approach. When we talk about a disaster preparedness, these are some of the basic principles of conducting an hazard risk and vulnerability assessment of any location, whether a district or coming down to the districts below. So these are some of the policies and governance framework should be in place, an emergency coordination to be there, a capacity building, infrastructure development, logistics, risk communication. These are some of the pillars on which this disaster management stands upon. So basically, when we are talking about what we have done, already a crisis management plan exists at the level of Cabinet Secretariat, which mentions and talks about the roles and responsibilities of different ministries during such kind of an event that can occur. So we have also internalized into our systems, and we also at the Ministry of Health have a crisis management plan.
And we made a similar template, and it was shared with all the states with the request that kindly make such kind of a plan in your place so that we did not just run around to find out exactly who has to do what. So similar kind of a crisis management plan was shared and repeatedly shared, I can say, with the request. Till date, we have only received around from 8 states that they have made some kind of a crisis management plan. So there is a request to all the states that for a disaster preparedness, a crisis management plan should be there, which should be handy, and that should be utilized. Similarly, post-COVID-19, we are talking about a lot of PM ABHIM. So we also had prepared some kind of a pandemic preparedness plan, which was shared by our Madam Secretary Health to all the states to look into them, and they can also make such kind of a plan in place. We were talking about the new assets coming in. Critical care blocks were there. From since morning, we are hearing and learning that such kind of things are there. So those are some hard to be incorporated upon in this particular plan to find out exactly how this plan should look upon with the new assets in place, and that would be helpful in our crisis if there is such kind of a thing that comes in future. So now coming into the capacity building at the national level, these are some of the capacity building proposals that we generally go ahead with. We have a hospital preparedness for the public health emergencies. Generally, we have a course on the management of public health emergencies in the field level officers. Generally, the state and district health officers take place. Then medical management of the radionuclear emergencies. This is something which is very important. This is something we have to be prepared upon with. Psychosocial care in a disaster setting, because post-disaster, it has been seen that whether it is the victim or whether those who are looking into the victim, they have some kind of a psychosocial trauma. So how they would be looking into such kind of a trauma, that has been also been, we are training through different specialized institutes throughout the country and training on the National Emergency Life Support. Today we had a wonderful stall, so we are just looking into how the trauma services can be given. So similar kind of courses have been run by Government of India, Ministry of Health. We would request all the states to just kindly send the nominations. Many a times it happens, the states are saying that no, we don't have people around people that they can be nominated during such a kind of a place. So these are some of the glimpses when we are doing this training, how people are getting involved with, and these are some of the glimpses how the training moves ahead with. And all this course material also we have put forth in a public domain so that people can just go through in the Ministry of Health website. And all the databases, the people who are getting trained, we are also putting forth in the platform called, we will be taking a length maybe on the IHIP, that is Integrated Health Information Platform. So we have the name, numbers, and the people who are getting trained in. So the resources can be utilized in future dates so that they can be utilized either to carry on a mock drill, to make their plans, and then subsequently even they can be also be utilizing it to do those kind of a plans. And this kind of a maps can be utilized with. We have given the user ID and password to the nodal officers of disasters in every state so that that can be helpful in planning purposes. So this is the second concept, that is we are just going ahead with building up of a secondary and a tertiary level chemical, biological, radionuclear facilities. There are 2 tertiary level facilities. That is, one is coming up in Chengalpat Medical College, that is very near to this place. And the second one is coming up in the Bhopal Memorial and Research Center in Madhya Pradesh. And 10 such institutes are also coming up in these following states of Andhra Pradesh, Karnataka, Rajasthan, AIIMS, Delhi, Bhubaneswar, Raebareli, Guwahati, Rajkot, Vijaypur. So basically, these are been specialized center wherein we can cater to such kind of a CBRN victims so that they can be taken a proper decontamination and decorporation, and then subsequently treatment can be taken place with. Now we are talking about the PM ABHIMs, this HEOCs we have been establishing. Now at this state, for this particular PM ABHIM 1, we can say, because PM ABHIM 2 is coming up, so 16 HEOCs have already been sanctioned and the work has already started in progress. And yesterday or day before yesterday, we had shared the TORs of the manpower, a suggestive TOR to all the states, so that these are the manpowers, because the work has started and from October onwards, they will be functional. This is just a little request that you have shared the manpower, we have shared the details. You can start the recruitment process and help us so that once the structure gets ready, we have some people around. And we will like to start some kind of a modular training which will help us to strengthen further. So these are some of the glimpses of the states where the things are coming up with. We have more pictures, but we just thought of showing some of them only.
We come up to another important part regarding the oxygen infrastructure that is also there with us. During COVID-19, we had seen that there was a lot of oxygen scarcity. And from there onwards, we have seen the lot of support and lot of resources were given to. So like PSA plants, around 1287 was allocated from the national level, oxygen cylinders, LMO tanks, MGPS, oxygen concentrators, and ventilators. They were allocated to different states, to districts at the district hospitals. Moving forward with that, we already have a portal, we call it to be the OxyCare portal, wherein people can look into what is the kind of data that has been fed from this particular PSA plant and what is their functionality like. The request is that it is kindly requested that the plants, at least if you are not utilizing, but still it has to be kept working. If the need arises, should not happen so that we are just grasping to get those oxygen plants running. And this is already been seen through this OxyCare portal, because the portal gives us a whole picture. When the plant starts running, the portal starts ticking. It's just like when you're switching on your car, your speedometer starts working upon. So many a times it happens at a particular juncture, not more than 200 to 250 plants are working, knowing fully well that around 1,000 odd OxyCare portal data has to be fed into this particular portal. So generally, we time to time, we conduct some kind of a mock drill so that we are in a practice to see that our cars are working, that is the PSA plants are working. So this is how the picture looks like regarding the functionality and the full functionality of the pictures. I don't want to go into the state-wise, but this is there. Other issue is that along the plant which was given through the PM CARES, around 1225 plants were given, of which DRDO had supplied with 869. Now, of these plants, most of them are out of warranty at this juncture, and neither DRDO helped us with. We were requesting the state, and Madam had very rightly supported us, MD NHM ma'am. She just helped us that she said that it can be asked for in the state PIPs, and kindly going ahead with the state and PIP, and they have to be submitted as early as possible so that these plants can be taken care of, which we are just allocating in the DRDO plants that is there. Regarding the two other plants, that is Heights and CMSS, which were given at that juncture, Heights has still till 2026, they had the 5-year warranty. If there is any issues, they can be kindly be catered to. And regarding the CMSS plant, that is also till 2031, that is there. But regarding the DRDO, that is something which I will request all the states to kindly look into and see to it that they are made functional as early as possible by asking money through the PIP route so that plants can be made functional. Now we come to the OxyCare, now we come to the oxygen training part. Already from today onwards, we have started, this is the booklet basically, medical oxygen management booklet, which was already nationally launched, which has also again been posted in the public domain. Along with it, there is a clinical training that is going on from today onwards. It has started with the AIIMS Bhubaneswar, wherein we have requested the states to kindly nominate their people, and we are trying to make a cohort around 250 to 300 master trainers. And these master trainers can in turn be utilized in the states to train their further people on the oxygen management part, the clinical part. And for the technician part, those who are working in this PSA plants, we are proposing a training at NIHFW sometimes in September, October, November, through 3 months for different states, where the cohort will be much broader so that they can be trained further. This is a new concept that is coming up in some selected states based on the request. We are giving certain booster pumps. These are nothing, but especially in hard-to-reach areas, we try to utilize these PSA plants and boost the oxygen production and giving the cylinders in those hard-to-reach areas so that there should not be any oxygen scarcity, number one. And number two, the dependability on the vendors should reduce down. We can make our in-house oxygen and we can give it to those which is needed more. Around 112 functional PSA plants and booster pumps allocation has already been received at this juncture. We have shared the MOU, some kind of an MOU which is there. That is also, we will request you kindly sign those MOU and give it to us so that we can start the processes. Because this is funded through the Global Fund. And at this juncture, the funding is till December. We want to complete this activity as early as possible. This is the request to all the states. That would help us with. We come to the ABHIM cube, that was the latest entrant. Many a times it has been told to be the mini hospital or something, but in disaster setting, this is something which was path-breaking, we can say. It started through the army people. It was designed by the army people, armed forces. And then subsequently, we had tried to introduce in the civilian sector. So there are around 338 items. 66 specially designed aluminum cubes, and we have already given it to 22 AIMS and INIs. We already had prepared an SOP for this particular thing also. Now, what is the need of the hour is that because during Operation Sindoor also, this was also utilized at that juncture, we had given it to northern states so that they are prepared to, if there's a need, they can be utilized. So we will request that already the SOP is in place. Now we need to do some kind of a mock drill. It is generally said for any kind of a disaster, the better we practice during the peacetime, the lesser we bleed during the war. So if these are utilized, practiced, and have the SOPs in place, wherein we put in people, we know exactly who has to do what and at what time. That would help us in a big way so that we don't have to ponder upon that exactly what has to be utilized with the Bhishma Cube. If there is a permission, there's a small video after this, which we would like to show. Can you switch on the video, please, from this? You have to increase the volume, please.
Every life matters.
During the COVID pandemic, India's Vaccine Maitri initiative supplied made in India vaccines to over 100 nations. I would now like to announce a new Arogya Maitri project. Under this project, India will provide essential medical supplies to any developing country affected by natural disasters or humanitarian crises.
Introducing Project Arogya Maitri. Bhishma Cube. Ready to deploy in minutes. Introducing Project Arogya Maitri, Bhishma Cube. The cubes are made in India. Each master cube fits 36 mini cubes. This master cube cage locks to form a cuboid structure with structural elements incorporated into the cage. When deployed, it can cater to a mass casualty incident of up to 200 casualties. Project Arogya Maitri, Bhishma Cube, meets toughest standards in different types of terrain and topography. Most recently, Project Arogya Maitri ABHIM Cube have been successfully drop tested. Mini Cube. Each mini cube is durable, waterproof and light. It has been designed to open in different configurations and can be carried by a single person or a drone. The RFID technology provides effective product tracking, inventory management and much more. ABHIM app is user-friendly app developed for medical and paramedical professionals that provide information about loaded inventory of medicines, surgical and emergency medical equipment. Inside each cube of this master cube, there are items packed as functional kits which cater to medical as well as non-medical functions. Non-medical items have been arranged into personal kits, survivor aid kits, cooking kits, and power kits. Response to any mass casualty incident involves procedures which require a particular set of items to be used in a specific sequence to achieve a specific objective. ABHIM Cube 1 is equipped with medical items catering to triage, OPD, TC3, ATLS, and evacuation kits. It also contains the crew survival kits and survivor aid kits catering to 200 casualties. ABHIM Cube 2 is equipped with advanced surgical kits, anesthesia, X-ray, ultrasound, ECG, laboratory kits, operating table, and structural elements. We now present you a quick demonstration in the event of an emergency during a mass casualty incident. This patient has severe bleeding. Bring major limb bleeding kit.
Major bleeding kit. Major bleeding kit. Mother cube 1, box number 9.
Box number 9 confirmed?
Okay, it's confirmed.
Major limb bleeding kit. We will put Equostat to stop bleeding. We will put crepe bandage. This patient has pain. Get pain relief kit.
Pain relief kit. Mother cube 1, box number 13.
Box number 13 confirmed?
Confirm.
So a diagnosis is made, a particular kit is asked for, which has been incorporated in the cube. The person checks it with the tab. That particular kit is opened, and he gets all the things to manage that particular kind of medical condition. Quickly, get normal saline kit.
Normal saline kit. Mother cube 1, box number 15.
Box number 15 confirmed?
Confirm.
IV cannulation.
Normal saline. IV set.
Patient has been given first aid and now patient needs to be transferred to a hospital. Project Arogya Maitri. Bhishma Cube, a Make in India product for the world.
Thank you. So I feel we are coming to the last slide before I can just close up. Sorry. Basically, we just wanted repetition only what we was just covering in my slides. The crisis management plan and the pandemic plan, kindly look into them. Nomination of the healthcare personnel, especially for the trainings which we are conducting, it would be really helpful. And some of the states still have to nominate one of our nodal officers who can do such kind of a disaster kind of a stuff. Most of the states have one, but at least if some of them are missing, kindly help us with. This Bhishma Cube, which has been given to, we have started with around 22 AIMS and INIs. So that would be helpful. If the states want, they can always, HLL had already done this kind of a procurement for us. They can always approach HLL for doing so. A proper functionality of the PSA plants, that becomes very important. So that would be very helpful if you can just ask in the PIP, get the money, and make the DRDO plants functional as early as possible. Because those are some of the resources, a lot of money are spent on this in making those things happen. And also, trainings are already been done on the oxygen management part from the national level. So these resources can be utilized and some money, additional money can be asked in the PIP funds for carrying out this training. So I close over here, and with that, I'd like to thank each one of you.
Thank you, sir. We're happy to open the floor to any questions or thoughts that anybody would like to share. Thank you very much. Yes, sir.
Annual warranty of this PSA plant supplied by DRDO available in GEM. Money is not the issue. We can give from state also.
Correct.
But is that AMC category available in GEM?
We have to explore, sir. That I haven't, to be very honest, we haven't checked out. We have to explore if that is available in GEM.
So one more suggestion, sir. Here. Besides the mock drills you mentioned in your video, the presentation, I think we can practically use these cubes during mass casualties because you have this road traffic accidents sometimes and huge number of people get hospitalized. So I think it will be a very good opportunity to get in touch with the cubes as an easy opportunity in the mass casualties, followed by mock drills, so that when the actual pandemic or actual disaster happens, people's skill set will come into play immediately.
That is very true. That is the basic purpose for which, for the mass casualty incidents, this would be really helpful. So there are around 22 AIMS. I could not just show because they were all hyperlinked. I was not able to just run through the hyperlinked slides, the name of the states and the name of the AIMS and other things. But those you can just have, the slides would be shared with you. You can see the AIMS, the nearest AIMS where you are having, and you can just contact them. Already, we have completed a first round of training at the AIMS. All of them are having these cubes now, and first round of training on AIMS have also been completed now. Just a few days back in Raebareli, we had this training at AIMS Raebareli. So I will request you kindly contact them, and then subsequently we can utilize these cubes in a much better way. It should not be something that we just keep it with ourselves, knowing that, yeah, we have a gun, but we don't know how to use it.
The other doubt is now, as part of the PM ABHIM 2.0, are we going to take this as one of the component, or this is to be looked upon from the state disaster fund?
So we have not planned as if to give it. It was the initial part that was given to 22 AIMS. Regarding the state funds, that was something which we are now proposing at this juncture. If the state wants, they can always get it from the state funds, such kind of a Bhishma Cube. That is there. Thank you.
One last question. Sir. You said about this booster pumps in the PSA plants, right? Sir. So we were planning the PSA plants can be made functional only if they're commercially viable. So we wanted them to make commercially viable with putting this booster pump and then supplying through cylinders to other private facilities and even, we have given the identified places also. But if you can just give us the specifications of these booster pumps for what kind of different PSA plants, what booster pumps should be used, we can use our own funds to get the booster pumps done and make it commercially viable.
We will do so, sir. That's a good input, sir. We will do so, sir.
Sir, one question regarding maintenance. Here.
Yes, sir. Please, sir.
Do we have to propose funds for maintenance of all PSA plants or only plants approved under PM CARES?
At this juncture, DRDO plants. बाकी सारे आपका covered है AMC में. So there is no point in just asking another fund for them. Abhi DRDO plants are out of warranty. You have to ask for DRDO plants.
DRDO plants under PM CARES.
Yes, sir.
Thank you, sir. On behalf of all of us here, a very special thanks for that wonderful presentation, how we are on multiple fronts strengthening India's healthcare safety net. A round of applause, ladies and gentlemen, as we extend our thanks to our speaker. Our next presentation is titled National Disease Modeling Consortium. It's my pleasure to invite Professor Sarika Mehraji, Principal Investigator, IIT Bombay and ICMR, to take us through the topic. The vision, the progress, all of it is going to be shared with us here on stage. Good afternoon, ma'am.
Good evening to everyone, and thank you on behalf of NDMC for giving us a platform to talk about some of the work we've been doing. So I'm presenting on behalf of my, colleagues at IIT Bombay, at various other institutes, and at ICMR. And together we have this National Disease Modeling Consortium, which was set up about 3 years ago. And the vision of this consortium was to essentially bring together different people in the country who are working in the domain of modeling and data analysis, and to do that, to be able to support some of the programs, health programs in the country. So the primary vision is for us to be able to contribute to the disease elimination and control programs. And primarily here is by using various sort of modeling approaches. Okay? A big part of this, a big part of modeling is that we also want to be able to do modeling that can actually also be translated to some policy decisions, right? Another aspect of the consortium is, in the area of teaching and training. So we hold a lot of workshops to build, a pool of modelers in the country who can actually support, again, the various health programs in the country. Now, NDMC is a unique effort in that sense. It was one of the first in the country. It's set up at IIT Bombay as the nodal center, but it's national consortium, so it integrates various academic and public policy groups within the country. So here is the governance structure. For some of you, most people I think don't know about us. So we, at the helm is the advisory council, which is chaired by the secretary herself. And it is co-chaired both by DG ICMR and the DBT secretary. We started out by looking at mostly infectious diseases. So we have, various disease-specific advisory groups, which include, again, people from the program, clinicians, policymakers, academicians, who together essentially debate and sort of guide us towards what sort of questions are really relevant, in the country currently. Okay? So at the moment, we've been working with, these 4 major domains: the vaccine-preventable diseases, malaria, tuberculosis, and the tropical diseases, both LF and VL. And we've now ventured out into looking at also, AMR and various non-communicable diseases. As I mentioned to you, IIT Bombay is the anchor institute, both for the administrative as well as all the research and development activities. We are partner with ICMR to look at, the clinical and the policy questions, and also to align our goals with the National Health Mission. There's faculty from all across, domains. So we have people looking, background in mathematics, in physics, in engineering, in environmental science, spatial analysis, economics, social sciences, and so on. Because as you know, health is sort of a multi-dimensional sort of domain, and you need people, all of these, even to build these mathematical models, right? And we have a secretariat and and then of course, a large number of RAs who actually do the work. Okay. What I will do is, so yeah, I wanted to sort of stress that we have academic partners, all across the country, and these are some of them. So some of the other IITs, work on various sort of diseases. We have, for example, like our Nivedi, we have PHFI, and this is sort of an expanding list. The idea really is that, we can bring together all the people who are working in this sort of domain. And then we also are expanding to look at, more partners who work on the economic aspects of modeling, looking at, the environmental surveillance aspect, for example, with the Gujarat Biotech Research Center and so on. Okay. These are our current sort of focus areas. As I sort of mentioned, under the communicable diseases, we've been working with, the TB program. We've been working with, in the LF and the VL domain, various vaccine preventable diseases, and so on. And with the non-communicable diseases, with ICMR, we've recently started, this massive exercise of starting to think about building estimates of the burden of NCDs right across India, down to eventually the vision is at the district level. And to do that, what we are beginning with is, some of the diseases, including diabetes, hypertension, and so on. Okay. What I wanted to do today was just give you snippets of 3 of our works, just to sort of see what sort of models we've built, and then how it can potentially, be useful for the various programs at the state, and happy to discuss later on, in terms of feedback of what more can be done. So what really can NDMC sort of help with, right? So when we build these mathematical models, right, and we're building that in different, at the national level, sometimes at the state level, and sometimes at the district level, there are various sort of questions that can be sort of asked, right? For the first one is, if you want to assess what would be the impact of the interventions, right? So for example, for vaccination strategies, right, what would be an optimum interval between 2 supplementary immunization doses, for example? Various interventions like, active case finding, what's the relative impact of these different interventions using a modeling approach, right? We can also look at, risk factors, and when we, using various sort of approaches, you can look at risk factors from across sort of the domain, not just the disease data, but integrate it with other socioeconomic factors and so on, right? We are now, in certain cases, I'll show you examples of also integrating climatic variables to understand, risk factors and their spatial variation across the country. So to do this, what I'm going to do is, I'll just tell you, as I said, 3 sort of case studies, right? Let me begin with some of the work we did in tuberculosis, right? And the question that we were asked in this case was that there are a lot of different, interventions that we are currently implementing, right? Or which are sort of proposed in the TB elimination program. And how do we rank them relatively in terms of the impact they would have in reducing the incidence as well as the mortality in the case of tuberculosis, right? So to do this, as you sort of know, right, the goal really is that, so in the question we were asking is that, okay, based on these interventions, until 2030, where can we, reach? So you know that we've been declining, but can we decline enough to eliminate, right? That's the question. So we built a mathematical model, and what that model does is basically takes into account the entire history of tuberculosis infection, right? How you go from a susceptible to an infected to a diseased population, how you interact with the public and the private, programs, and these models are calibrated to data that we have from either, the TB program, which is, there in the NICSHE, or with to the prevalence surveys that are carried out, right? Now, once we build that model, right, and when I say build that model, we've sort of have the model that can actually predict some of the, actual estimates that you have from the prevalence survey. Then we use that model to find out what's the impact of the different interventions. So what you see here, let me start from the bottom, is, for example, the diagnostic rate, right? So we can improve the diagnostic rate of, tuberculosis, right? We can improve the care-seeking behavior of having more people, with symptoms or without symptoms come to either the public or the private health centers. Diagnostics, so the diagnostic efficiency in the public sector and the private sector is very different, with the public sector being much higher than the private sector. So you can strengthen both of these health services to improve the diagnostic services. And the other things that we look at, which is prominent in TB, is the active case finding. And then the top one is the stabilization of infection, which essentially in this case means that people who are infected with tuberculosis but have not necessarily progressed to disease, if they are provided with nutrition support, for example, the disease, the infection can be just stabilized at that stage and doesn't progress to infection, right? So these are different interventions, right, that the program implements. And we use some realistic sort of estimates in terms of, for example, in the active case finding, we are saying that, okay, let's say at best about 25% of both symptomatic and asymptomatic patients, right, can actually be detected in addition to who are already coming to the sector. With all of these together, right, you can see that you can reduce your incidence about 65%, which means that currently it's about 178 per lakh, and it can go down by 2030 to about 71, right? That's what the model predicts with confidence intervals. What it also sort of tells you that the two most important interventions that according to us are of impact, keeping the economic aspects and the actual implementation aspects aside, are nutrition support to stabilize the infection and also active case finding. The other question that we were asked by the program was about looking at what can be done to reduce the mortality in TB, right? So here we looked at the data that is there in NICSHE across different states, to sort of understand what are the risk factors based on the information that is available with the program in terms of mortality. And some of these results, I think, are probably intuitive for all of you. And what you can see here are basically the different risk factors that we've looked at in terms of the age, the diabetes status, the HIV status, and the weight. And what the numbers that you see are the adjusted odds ratio for mortality. And as you can see, for example, that elderly population is at much higher risk of mortality. And similarly, of course, as undernutrition is sort of expected, there is much higher risk. Also, what it also shows that this risk is very different across the states. Some of this analysis also points out to maybe some gaps, right? For example, there are a lot of patients for whom the status of diabetes is not known in the program, right? And for these patients specifically, the risk of adverse outcomes turns out to be very high. So this is sort of a feedback sometimes that we can go back and give to the program to basically see if some of these specific parameters can be collected more. So as I'm sort of saying, in terms of policy consideration, what this essentially, as I've already talked about, means is that in terms of interventions, these are the two top interventions. It also gives us some realistic measures of where we can reach. And similarly, in terms of risk factors, elderly population has a much higher risk of adverse outcomes. Okay. Moving on, I'll give you another story, which is from the measles work that we've done, again, right now at the national level. And here the question asked was in terms of, optimizing the various immunization strategies and to evaluate what would that impact be in terms of elimination of or reducing the measles burden. Okay. And just before I sort of begin, this chart here sort of shows the variation in the vaccination coverage over the years, right? And it also sort of tells you, the measles dose 1 and the vaccine 2 coverage. And then we also have, in between some of the supplementary immunization coverage aspects. Although both of them are happening, you can see that towards 23, we have, the number of cases increasing. Another aspect of when you really look into these cases, as you may know, is that there's a lot of heterogeneity in the measles cases in, based on age group, right? So there were more cases at the very young, infants. And therefore, when we build a model in this case, right, we cannot have a model which is the same for all age groups. And therefore, these models were sort of age stratified. Was that for me? Okay, all right, okay. So here we had different scenarios that we looked at for, in terms of the vaccination strategies. And what you can see here in this graph is that what we're projecting is from 2025 to 2050, how the measles cases would reduce, and then that is converted to, DALIs, and how that would impact finally the reduction. So these are different, scenarios that we sort of evaluated, and what we sort of propose here is that you need these targeted SIAs and IMIs together. Of course, it's a very expensive strategy, but that together among the various strategies that we, okay. I wanted to give one example, which is more at the, at a sort of a sub-national sort of level from LF. And in this case, the idea is that how many MDA rounds would I need at different block levels, right, to achieve my elimination, right? So, and this is going to be different at different blocks. So in this particular case, we built a model which was different, right, for different blocks. And what you can see here is a hotspot analysis of, the basal rates of MF. And what you can see, the red ones essentially show that these are spatial clusters where, the rate is very high, which also means that migration between this can actually impact, the rise of cases. And using a model which is, again, at the block level now, we can actually now predict that given a baseline, coverage of your mass drug administration and your basal MF clearance, what is the number of MDA rounds that would be required to achieve elimination? So these predictions go down to the block level and not really at the, just at the national level, okay? And this is what translates to policy consideration that we can actually, give these estimates. Of course, migration, never treated population, these are also important factors. And now we're sort of building models that incorporate all of these things. I'll close because I'm running out of time, but one small study that I wanted to point out is that we also sort of want to look at, socioeconomic factors and climatic factors. So the malaria group, for example, looked at, the number of malaria cases across all districts of India from 2019 to 23, and incorporated along with it, various climatic variables, the land use variables, and then sort of predicted what sort of variables are important in different regions, right? Now, there are certain things which come out, which are similar across the different geographies. For example, maternal education, it has a negative correlation with the risk of malaria cases. But otherwise, you can see on this map that the factors important for malaria are different across the different regions. Okay. All right. We're also building sort of a visualization dashboard, more for providing sort of a handle to policymakers for our modeling outputs, right? So that, for example, you could try out different vaccination strategies based on our model by just inputting, what you sort of think would be relevant parameters. Okay. So coming back to my thing, how can NDMC help? So these are the various areas where, we're looking for collaborations with the state in terms of answering any of these questions, both across communicable and non-communicable diseases. I brought along one of our newsletters. Please pick it up on your way out of this room. It's kept just at the exit, where you can find more details about work that we do in different areas. So, thank you.
Thank you, ma'am. If we may open the floor to any questions, right there at the back. Sir, you should have a mic on your table. Can I please request you to find it? We'll bring it to you.
Madam, thank you for your presentation. One thing which was very interesting to observe was your tuberculosis model. So where you have shown that disease stabilization using nutritional support has substantially contributed. So based on the public health common sense, we trust a lot on treatment part. So the treatment for the disease must be one of your important logistic regression variable, I believe. But having said this, your model, whichever model you have worked on, and since nutrition has come out, is it going to be a serious lesson for everybody? Because I was little interested. I thought the disease stabilization, you meant probably treatment as well as nutrition supplementation. But the bar diagram clearly showed nutrition and supplementation coming out almost like 50% or 53% of your total modeling figures. If I'm wrong, correct me, but just I want your input.
Yeah, so when I meant stabilization here, it is not nutrition support to only the patients. It is actually to people who may be latently infected with TB, right? So that they don't progress to the disease, right? So that is where we are talking about nutrition support, right? Which is, I know, is a much harder problem than just identifying patients, right? Because the studies, the Poshan Yojana is more for the household contacts, right? But here we are actually talking about the impact would be the maximum if you can identify latently infected people and then provide nutrition support, which actually corroborates with the risk factors also, as you say, because underweight is an important risk factor for an adverse outcome.
So can we take it as to take it forward, can we take it as one important strategy for addressing latent TB?
Absolutely, absolutely.
So is this going to come into a national perspective?
That is for the audience here to really, debate upon. From our end, yes, the modeling definitely suggests this, but yeah.
Thank you, madam.
Thank you, sir. If we have any other questions from the audience, yes, sir. We'll pass the mic to you. Over to you, sir. Good afternoon.
My question is that the role of AI in epidemiological modeling for transmission of disease, because we are having the real-time data of disease surveillance, but we need voluminous data so that we can take the help of AI algorithm for disease kinetics. How do you?
So, it depends on sort of the question. So, for example, the TB model is not an AI model. It's actually a compartmental model. When you understand reasonably well what is affecting your disease or what the progression is, a traditional epidemiological, what we call as a compartmental model works well. But for example, when we are talking about, risk factors identification, or for example, we want to sort of develop a model where we want to see across all sort of different factors, social, economic, right? Health parameters, and we want to build some sort of a risk prediction, then the AI model becomes important. So we are using all sorts of approaches, right? Statistical, traditional dynamic sort of models as what we call them, AI-based models. It sort of depends on the question, that we are asking.
Okay, in your presentation for MDA analysis, you have shown, and two were the variable. One is the coverage, and another is MF rate. So what was the confidence level in this study? Because yeah.
So I don't have the confidence level numbers as such, but we do have, when we build these models, right, we do have confidence intervals. I can give you the details, but I don't remember them from the top of my head. But yeah. But all of these numbers come with a confidence interval, like I was showing you in the TB, right? What is sort of the range? But everything comes with that.
Okay,
yeah.
Thank you.
Yeah.
Just a short question. Thank you for this wonderful presentation. Did some modeling exercise you did during the COVID-19 times, and what was the impact on that?
So, so NDMC was sort of set up somewhere in between, right? So officially, NDMC hasn't actually done, because we didn't exist during COVID, but there are colleagues who are part of this who did some COVID modeling at that time. Sometimes at the Maharashtra level, right, to look at sort of various aspects. So for example, one of our collaborators or one of our partners has this agent-based sort of BharatGen, if you would have heard of it, which is, a model for COVID. So there were various predictions that were done. Yeah.
Just one more. I think
returning to TB, a very fascinating graph you showed about the mortality and the adjusted odds ratio. Very significant variations between states. So if I pick up just age 60 and above, for MP it's 5.14 and for Delhi it's 13.48. Any insights into what could be the reasons for this?
So I couldn't hear your full question, I'm sorry, but I think you're asking about why that variation, right, in the risk factors. So for example, when we talk to the program, like for example, Delhi had a higher risk ratio, right, for the elderly. So one important factor is actually migration, right, and people moving in and out of that state, right. So and also for TB, for example, since the treatment is long, right, the diagnosis may happen, at the metro cities, right, whereas then they move out to, sort of a lower, a village or town. And that impacts many of these numbers a lot, right? So I think as of now, I won't read more into it unless we really investigate, other socioeconomic parameters of these states to find any correlations. But I think migration sometimes plays a big role here. Yes.
I'll just share with you what I think you should have started from the very beginning. As per the COVID time, a lot of modeling was done by independent researchers as well as groups. So people like me, along with my colleagues and all, we did a lot of modeling on COVID. What we realized was that small, region-specific, short-duration models are more effective. Otherwise, the old saying of all models are wrong, some may be useful, was proving to be correct earlier on. And when WHO came up with 4 models of mortality and gave a staggering figure of the mortality in our country to COVID, there's a time we reviewed their models, and that paper was presented by the previous HFM in the World Health Assembly. Until then, since then, WHO is not talking about their own models because we came out with the flaws. And there's a time a decision was taken by Government of India to create this NDMC. And from steering group, we have asked them now clearly to look at state-specific models instead of country-specific models. That's why this presentation today, so that from states you can share your problems and also your interventions. They will look at the model and come back to you that yes, whether these interventions will work. Even state level, district level also, can also be done by them. And we now also ask them to look at non-communicable diseases, go beyond the communicable and create models for those also, to whether the preventive aspects or screening aspects, which one will be more effective as such in prevention and control, looking at that. That's just to put in perspective why this has been created, what is their role, and what's the kind of expertise we have which is available right now. Thank you.
Thank you. Thank you, sir. With that, ladies and gentlemen, please join me as we extend our thanks to Professor Sarika with a huge round of applause. Thank you so much, ma'am, for detailing that concept for us and how it could be so much more than a scientific exercise. On that note, our next presentation on stage focuses on a topic that has already been kind of touched upon on stage and off stage as well with a few of the comments, and that is surveillance. Ladies and gentlemen, the topic in question is strengthening surveillance of infectious diseases. It is my pleasure to extend a very warm welcome to Dr. S. Sendilnathanji, DDG, PHIH, followed by Dr. Himanshu Chauhan, Joint Director, NCDC. They're going to be taking us through the concept. If I may please request you to give them a round of applause as we welcome Dr. Sendilnathan on stage. Welcome, sir.
Good evening to all of you. As we transform from more of clinical and treatment part, infrastructure strengthening, we will now, this session will start with how we can do the preventive part by surveillance and also for the outbreak response. So point of entries, in an interconnected world, we are the gatekeepers at the point of entries. It can be also the point of exits for our country because disease does not only comes from outside, it also goes from one country to another country, whatever is happening in a country. So basically, our capacity at present is we have 30 airport health organizations working in our country, and we have 11 port health organizations, which is covering 13 major ports and all the minor ports in that particular states. And we have 4 land port health organizations in our country. So these are some of the services we do. We do the international health screening, yellow fever vaccination and polio, quarantine of healthy suspects, clearance of human remains, food and water surveillance, which is very important with international health also, and vector surveillance. We have to ensure the point of entry is free from vectors to prevent vector-borne disease transmissions around the world. Aircraft and ship inspections, which is a regulatory requirement under IHR, and also training on public health measures to all the stakeholders who are at the point of entries. And we also coordinate all the health measures which have to happen during any PHEIC. And we are always on the lookout for any disease which can enter through the travelers, conveyances, or through goods. So the disease during the pandemic or any emergencies, it normally starts with an alert from international WHO. Then the point of entry officers monitor all the travelers who are coming through the point of entries. Then if there is any alert, it goes through a system of, to the district and state surveillance system and to the central surveillance system. The IHR NFP of the country again connects with all the NFPs all over the world. So there is always a back and forth information happening day in and day out. Any disease which is alerted goes through this system to track. Even a TB cases or MDR TB or measles or cholera, it all gets transmitted from different IHR NFP to our IHR NFP, through which it is again sent to the surveillance system of our country. So under the PM ABHIM, we have total 17 new POEs going to be established. Already there were 33 existing before the scheme started. So these are some of the things which are going to come. 3 airport health organization and 3 more land port health organization. And we have already the existing quarantine centers are in Delhi, Mumbai and Cochin, and Bangalore and Hyderabad will be operational by this year. And all the rest 14 will be coming in under the PM ABHIM in the next, it will be starting probably in a year once we have the things sorted out. So what we request from the states is that the nearest district and medical college referral hospital should be designated for each of the POEs, so that all the public health emergencies which happen at their point of entry can be referred and followed up for further care. And also all our point of entry health officers can be part of the district and state surveillance committees in whichever district and states they are there. So this will also help in the routine sharing of information of the quarantine of passengers. And we always have the back and forth request about the number of contacts which happens during any pandemic. And also, many of the district surveillance officers are also part of their activity. They do the vector-borne diseases and also for the food safety surveillance in the local area. So there will be effective coordination not only during disaster management, also during the PHIC. So the other thing is most of the health sector professionals are not aware of existence of POEs and their activities. So it is important that we have one orientation training for all the community medicine team and the entomology students to visit the nearest POEs to understand how the POE functions in the whole health system. And also the referral hospital professionals can have a visit to the POEs to understand about the IHR related activities which is going on there. So the frequency of trainings can be yearly for the students, and as and when the health staffs change or rotate, they can have a visit and understand the working of the POEs so that they can have a regular coordination. So, and in the PM ABHIM 2.0, we are actually planning to expand all the point of entries by covering them with health infrastructure. So in that, we want most of the infrastructure has to come within the point of entry premises, but in case if there is a challenge, we may also request the states to assist us to have those facilities or to be provided nearby the land or to be provided nearer to the point of entries. Thank you.
Thank you, sir. If we may please request Dr. Himanshu Chauhan to join us on stage to take us through the next part of the presentation. Welcome, sir.
A very good afternoon to all the respected dignitaries of the dais, colleagues at the back. I'll be talking about the Integrated Disease Surveillance Program and the Integrated Health Information Platform that is being used by IDSP. We've been talking about it since morning, and it's often mentioned IHIP in each of the interventions that were touched upon in the morning. So this is basically under the domain of strengthening surveillance of infectious diseases and outbreak response. So I won't go into the historical details, but it's been 20 years that a systematic approach to detecting outbreaks, early warning signals of outbreaks, and responding to them has been in place. Obviously, it has evolved with time, with the most recent development being in 2021, when the system of reporting the early warning signals and the data was transitioned from a paper-based weekly reporting system to an electronic near real-time reporting system. So these slides, they just go on to show that as the program was evolving, there were major pandemics, epidemics that the country and the world faced, and they also shaped the development and the evolution of the program. Like in 2006, these pictures at the bottom right, they indicate the first avian influenza outbreak that the country faced in Maharashtra. This was just about 2 years when the program was just initiated. So the main objectives of the program are to detect early warning signals of impending outbreaks of selected communicable diseases. And once they are detected, there needs to be timely and effective public health action initiated. This requires a trained cadre of rapid responders at each level, from the district level upwards till the national level. These are the rapid response teams. Ultimately, the aim is to reduce mortality and morbidity due to outbreaks. This requires a nationwide presence, which the program has. It's a program under National Health Mission, as we all know. And district public health laboratories and rapid response teams, they are present in all the districts of the country. There are 3 levels of routine reporting. The syndromic from the community, which is used by the ANMs, the P forms, the doctors using at the health facilities, and the L form, the laboratories which use them. In recent edition has been the community reporting, wherein virtually the entire adult population of the country has been connected to this surveillance net, wherein any unusual event in the community can be reported without the need for having credentials or username, password to report unusual events. The early years of IDSP, they were just about establishing a system wherein we can have early warning signals coming in. In 2012, we all remember the AES outbreak that left 120 children dead in Muzaffarpur, Bihar. This was again a test for the program at the state level and the national level. It was consolidated. There were many new additions to the program. Ultimately, as I said, in 2021, which was can be considered a watershed moment, when the reporting was transitioned as the country was facing the second wave of COVID-19, the system was also transitioning into an electronic real-time reporting system. I'll just come on to some other noteworthy initiatives, and then we can look at the data as to how does it look like and what actions can be taken. In January 2024, the Honorable Health Minister launched the community reporting tool, making community as partners in surveillance. A full-scale preparedness and response drill was conducted named Vishanu Yuddhabhyas, wherein multiple sectors came together and tested our preparedness and response capacities. We are conducting public health emergency and disaster. Disaster was touched upon by the previous speaker. So bringing the 2 responders together as one. And 20 years last November. This is how the program is organized, with a presence in every district, ensuring that it's a true nationwide program. The glimpse of the diseases that the program is mandated with. Some of them are not there in India, but then readiness has to be maintained, especially at points of entry and then in the community too. So Ebola, yellow fever, and MERS coronavirus are not there in the country, but still the surveillance program keeps a vigil over them. Essentially, these are the diseases which is the entire bouquet of outbreak-prone diseases, vaccine-preventable, vector-borne diseases, diarrheal diseases, and so on and so forth, respiratory illnesses being obviously the most important ones. The integrated health information platform, rather than talking about what it is, I'll just give you a demo of, so this is the integrated health information platform. It's been mentioned a few times since the morning. It's essentially a technology solution to hosting surveillance data of multiple programs. And currently, the ones in the blue are those programs, national health programs, that are already onboarded. They are users of integrated health information platform. IDSP, I'll just give you a glimpse of how IDSP data looks like. So username passwords have been provided to some more than 250,000 users across the country. And if I can request the team there, these slides, they don't work on hyperlink mode from here. So the reporting status dashboard, this is being monitored. What we see here is almost 1 million+ cases being reported every week from across the country. And that's huge data, given that it is case-based surveillance data, wherein every number is an individual who can be identified, traced, tracked, and followed up. So the reporting we see, most of the country is in green, which means a satisfactory level of reporting happening from the country. You just probably lost one bit over there. If you can go to the previous slide. Next. So this is the outbreak performance that I just wanted to focus upon. Outbreak has many components. There are 10 essential steps that are being monitored, scored. Every district is given a score on the basis of their outbreak performance. At the national level, what we see is that the country is doing satisfactory with a score of more than 80. But There are gaps, especially in terms of collecting samples from those outbreaks, sending them to the laboratories for confirmation, and then updating the results of those samples which have been sent. And the district-wise, we can see while most of the country appears in green, there are a few red zones which are being followed up. A weekly bulletin is shared by the Central Surveillance Unit to the state health leadership to give an idea of how the states and the districts are performing. Back, please. Data visualization is another I think you are clicking a couple of, yeah. So the heat maps and the individual cases. There are some cases which need to be monitored on an individual basis. AES cases like in Assam, they would know the importance of each case of acute encephalitis syndrome, which is visible on the right side. While the heat map, where are those areas where most of the cases are clustered and therefore resources and action and manpower can be directed to contain the outbreak in those areas. Go back, please. Move on to the next slide. Next, please. Special surveillance dashboards can also be created wherein for disease specific, like influenza, whenever there's a new variant or whenever there's a seasonal surge, we can have a look at how influenza is behaving, what are the trends, who are the people who are getting affected, and so on and so forth. Back. Click on the back arrow, please. Ahead. Yeah, this one. Okay, I'll take it from here. So such a program, such an effort, which is truly pan-India, and there's hundreds and thousands of users who are connected on a daily basis, near real-time reporting is being done. This requires lots of support. So the leadership at MOHFW, Government of India, and the states, they are the ones who are responsible for the success of the program. The state and the district surveillance units, many of whom are present here, and they are actively following it up, monitoring. The lab network, the NCDC and all its divisions, which are partners, ICMR, NIV, and the VRDL network, which reports data on it. The Animal Husbandry Department, many of the early warning signals emanate from the Animal Husbandry Department, and we then follow them up, and vice versa. FSSAI, NIDM. Just click on the MSVC. This is something that I just wanted to highlight, the AI-driven media scanning tool. So it's no longer done manually. There's an AI tool which scans continuously round the clock all the media reports which have keywords related to outbreak or unusual mortality and morbidity. And it is tagged and then shared with the districts. My request to the leadership from the states is that these alerts, when they are shared with the state and the districts, they require to be followed up in a timely manner. Within 24 hours, it has to be verified or rejected. And if it is found true, then action has to be taken. Back, please. The Public Health Emergency Operations Center, these are being set up as part of PM ABHIM in 15, 16 different states. The national PHEOC that we have at the National Center for Disease Control, please click on that PHEOC link. We have activated it since 2015. It has also evolved. The current version is the state-of-the-art Public Health Emergency Operations Center. Next slide. Yeah, the arrow, hyperlink. So this is a glimpse of, it is a nerve center wherein all major outbreaks and responses across the country, they are managed in terms of logistic support, information, and resource management. Go back, please. Yeah. And most importantly, community. Just click the next slide. This is what I was mentioning, that this message hasn't really percolated down to the community. In all our trainings, we are trying to have this message percolate to the community. They are the ones who face the early warning signals of any outbreak in the first instance. And if they are aware, they can report, then that is something that the system can be alerted by. This doesn't require any username, password, just a mobile number and an OTP authentication so that we do not have false reporting coming in. Back. Next. Some of the milestones, some 3,000 outbreaks have been detected in the last year and responded to, which is to say that there's lot that the program, although a small program in terms of the financial implication or the total budgetary outlay, but the performance, as you can see, has been major performance in all domains, especially when it comes to outbreaks and natural disasters. Next. I'd like to also take a pause and reflect upon some key challenges and the way forward, the last two slides. So the challenge that we are facing, while most of the PHCs, Ayushman Arogya Mandirs and the CHCs, they do report regularly. But the reporting from the tertiary institutes, especially from AIIMS and medical colleges, that's been, so if you can just click on that reporting from AIIMS, What I want to show in this slide is this is severe acute respiratory illness, one of the most important conditions, priority conditions for any outbreak that needs to be followed up. What this slide shows is in the first 6 months, 7 months of 2025, the medical colleges across the country, 554 medical colleges are onboarded on IHIP. The number of severe acute respiratory illness cases that they reported was 6,458. That means we estimated, with Secretary DHR taking the lead and having an in-depth discussion, it was estimated that there are some 50 lakh cases of severe acute respiratory illness in the country every year. Even if we assume that 50% of them approach the hospitals, there should have been some 20 lakh, 25 lakh cases. 6 months, 10 lakh cases should have been reported. But what we are seeing is just a minuscule. So we are missing reporting from mainly medical colleges and large private hospitals. Go back. Private sector reporting, this is also a monitoring indicator for PM ABHIM project, the disbursement linked indicator, DLI. We see that the target for this year is 30% of the PMJY facilities report on IHIP. We are just about at the mark 29.2%. And this is a challenge. I'd like to request once again the leadership here that there are multiple issues why PMJY facilities do not report their payment, their pending dues, and so on and so forth. But this is being monitored. At least 30% of them reporting regularly on IHIP is expected. Next year, the target is 40%. Back. Vacant positions is again another appeal. We have analyzed there is vacancy to the tune of 30 to 40% at the district level. District epidemiologists, data managers, etc. are some of the key components which are required to be in place so that timely and efficient response can be undertaken. Integration of portals, while health is a state subject and states have created their own portals too, but it needs to be ensured that they are connected to the national portal also so that we are not in the dark when we look at the national picture. VPD surveillance transition is the latest kid on the block, as they say, and it has been transitioned from the WHO and PSN network to the domestic surveillance system. While IDSP is still trying to understand fully and take over that transition, the request is that the vacant positions would only hamper this transition, and maybe we require to project additional requirements in terms of resources, manpower, money, etc. And data safety is something as with any digital platform, it has been so far safe, but then tomorrow is another new day in terms of digital data safety. So the way forward, my request in the last slide is the quality of data. While we have ensured that more than 80% of the units are reporting regularly, we need to look at what they are reporting, the quality of data. Once we have quality data coming in, we can really move. The modeling speaker on the modeling, she conveyed this point very strongly, that quality data can help us in many ways. We can actually predict outbreaks before they happen, rather than detecting them early and then responding. Dedicated state and district surveillance officers. This is an appeal that officers tasked with multiple programs, although it is a huge challenge at every level, but then officers tasked with multiple programs would obviously not be able to do that much justice. So if they can be dedicated state and district surveillance officers, then capacity building of these key officers, and also placing those trained officers. We have many EIS officers which are nominated by the state who are trained at NCDC for a 2-year course. And then when they go back to the state, return to the parent department, they should be placed at appropriate positions which is related to surveillance and response. Filling up of vacant positions, I have already mentioned. Can you just click on the last hyperlink, MSU? Yes, I'm done. MSUs, can you click on that? So this is a glimpse of the metropolitan surveillance units, another important component under PM ABHIM. While 6 of them are functional, progress has happened in all others in terms of moving ahead. Budget has been released to all of them this financial year. We appeal that the HR recruitment in these units be taken up on a priority basis so that all of them become functional by the end of this calendar year. Go back. And this requires regular monitoring by senior officials at district and state levels. When we launched this program, In Jammu and Kashmir, I'd like to specially mention UT Jammu and Kashmir, wherein weekly review was undertaken at the state and the district level, and the performance of the state UT at that time was more than 95% of the units were reporting on a daily basis, and this continues. In whichever state there has been a regular monitoring at senior level, the performance has been above benchmark levels. So I'll take a pause here, stop. This is the presentation that I wanted to make. Thank you very much. If there are any questions, I'll be responding to them. Thank you.
Check. If any of our guests would like to share a question.
So,
Right there at the back,
myself, sir,
sir.
Dr. Hitain, SSO Himachal.
Right there at the back, sir.
Sir, just wanted to ask you about, like sir, in IHIP we are having reporting for the facilities. So is there any plan to involve ASHA also, like for example in suspected cases of outbreaks, how you are going ahead in that, sir?
Yeah, so great question, and ASHA happens to be one key worker. Currently, obviously, the community reporting tool is available to her, or maybe she informing the concerned ANM. That is one way of involving her. But currently, she is not a part of the system stops at sub-center level reporting, therefore ANM. Sir.
My last question, sir. Like you you in your slides, I had seen that there were challenges of medical college and AIIMS not reporting, sir. Definitely, sir, being a state surveillance officer, we are also struggling with that. Anything going on at the level of national level, how to take them into the reporting processes, sir?
Sir, there are then again arguments from both the sides which are valid up to an extent that there is a huge patient load there. But then the doctor who's seeing, there have been developments like apps on mobile phones. They have been developed. So despite the busy schedule in the clinic, one or two cases which are truly unusual, which needs to be reported, can be done easily. Then the electronic record system in the hospital, that is the ultimate solution, wherein every patient registered on OPD basis and IPD basis, that data can be just connected through API.
So that means the API of IDSP are available for joining, because we have HMIS in our state, so we would love to join it with the API through IDSP. So it is available, sir? Right. Thank you.
Yeah.
My question is about from Uttar Pradesh, you must be aware, we have a unified disease surveillance portal.
Yes, sir.
And the API linkage has been done after around 2 years of discussion.
Sir.
But the data flow is still not smooth. So my request is that please put your technical team and our technical team together so that data flow is smooth. UDSP has many advantages which we cannot neglect.
Sir.
One, the data comes from the ASHA also. The private sector's compliance is much higher. We can customize it locally, and VPD is already there.
Yes.
So we will not give up UDSP. Please put your technical team so that the data flow is smoother.
Sir. Sir, our team is in touch continuously. The last meeting, I think, happened last month somewhere. And yes, it has come a long way from what it was 2 years ago. There's a lot of reporting which is happening. But then, yes, as you said, there's scope of improvement of that too, sir.
Thank you, sir. With that, while we extend our thanks to Dr. Himanshu Chauhan for this presentation, may I also request him to stay on stage for the upcoming presentation as well. His next topic is going to be IHIP, IDSP, and upward-downward linkages with BPHU and IPHLs. Over to you, sir.
Yeah, I think sir would be making that presentation, and if there are any comments or questions later on, then we can respond jointly.
By all means, ladies and gentlemen, if I may please request you to give him a loud round of applause as sir joins us on stage. Welcome, sir.
One of the important things, because we have been all talking about this surveillance, IHIP, and other things. This is the diagram which you are seeing. This we have envisaged in 2020, 2020, when I was working in my earlier assignment with Niti Aayog, when we had this position paper on Vision 2035 for disease surveillance, where we envisioned that we will be having a service element and the surveillance element. As we have encountered and seen that how the PM ABHIM has created new infrastructure, BPHU, IPHL. We have totally focused on the service element, how many number of diagnostic, how many number of tests that should be happening. And how to utilize this information for our surveillance purpose, for improving the service element, that is the key. And that's, here comes the role of linkages with the existing system and other things. If you look at the diagram, the source is Vision 2035, Public Health Surveillance in India. It's a Niti Aayog paper where which we envision that the service aspect, that means the Apex institution, they are providing services. And the laboratory, the referral networks, and the P form, L form, and the S form, which we have, which Himanshu has presented, that's there. But who is analyzing this information? For disease modeling also, we require a good quality information. Unless we have the digital interface for collecting information, how can we ensure a good quality information? That's why this linkages becomes very important. When we were talking about the surveillance during the COVID times, they always wanted to have a new surveillance system. But when we started exploring that, we have 7 types of surveillance system, and IDSP is one of the part of that. ICMR is having ILI and SARI system. Influenza network is there. Then INSAGOG network is there. So many people, so many systems are there. And all the information is coming to IHIP. I think invariably it has to come to IHIP in the subsequent. That's why upward linkage, downward linkage between the facilities, communities, and the upward linkage to the district surveillance unit, the state surveillance unit, and the central surveillance unit becomes very important. So this is the role of this. As we have since morning, we have seen that first aggregation point for morbidity and mortality data, supervised reporting from CHOs, PSCs, village health sanitation, nutrition and sanitation days. It validates and uploads the data into IHIP portal. That's why this is the key. It's not that it would be doing analytics, because as sir has rightly mentioned that the data comes to the central level and the analytics can happen. But who will ensure the quality of data which flows from the community and the system and the facilities to the portal? It validates and uploads the data into the IHIP portal, provides local level analysis and rapid response. The moment the data is fed into the system, triggers are generated, and the rapid response teams are alerted if an outbreak is there, outbreak investigations happens. Then if you look at the role of IPHL, we have been entirely focusing on number of tests which have to be provided through that, but they have a role for confirmatory tests. Right now, the laboratories are keying in the information through the L form of the IHIP. For a disease to be confirmed, you have to wait for the laboratory test to happen, and then the report is fed into the system, and the system will go to the IHIP, and then the triggers are generated. And it consumes a lot of time, and in the epidemic time, it's a time which is very important so that you can institute some rapid actions. One of the important role of this IPHL is provides lab-confirmed information of suspected cases flagged by IHIP, then ensure quality assurance and supports outbreak investigation, house for sample referral from peripheral laboratories, and closest loop, suspected, tested, confirmed report, that it is usually to do that thing. Then this is the linkage overview which I would be talking about. That means there are sideways linkages because most of our CSCs and your block program BPHUs would be connected with the ICMR, VRLDL network as well as the multidisciplinary research units. I think that information also flows there. From there, the information goes upwards, so that later side linkages are also there. But upward linkages to the state units as well as national units is there. But apart from that, you should be having a downward linkages in the form of your actions, the advisories, and other things. And these are the two-way solutions which we have to think about when we talk about the linkages. One is the service aspect. We have to see that how the patient-centric aspect is taken care. And the second is your surveillance aspect. I think the corrected slide is not there. The surveillance aspect, that is, which is more or less system-centric. The service aspect, we have to see that how we can strengthen it by use of unique ID. I think already work is in progress through generation of ABHA IDs, increasingly use of ABHA IDs into the records, so that this aspect is also being taken care, which can result in timely diagnosis, faster treatment. Besides that, we have to see that how the range of tests from the basics to the advanced they can increase. Digital reporting will reduce in less paperwork, reduce turnaround time for results and patient follow-up and continuum of care. These are the service aspect where we can have a solution in that. And already many of the things are work in progress and we are working towards that. In the system level aspects, that is real-time linkage of case and laboratory confirmation. Then automated form filling, S form, P form, L form is avoided. Right now it's manual. Whatever the symptomatic forms comes, it has to be verified by the medical officer at what particular level. And the presumptive diagnosis as well as the L forms also, that has to be done manually. We have to see that how it can be digitalized and it comes on a regular basis. The outcome detection and escalation to higher levels can happen. Better forecasting, preparedness, reduce duplication, delays, strengthen accountability at the block and the district levels. Because if this information is available, we can know the progression of this. I can cite the example of COVID when the disease was progressing. There was a lot of panic situation. When we were analyzing the data, we told that the disease will, the epidemic will not happen across the country in one go. All the districts would be, the pandemic will be happening across the districts in a different period of time. All the districts would be subjected to epidemic conditions in a different period of time. That's why that will give us a space for handling this kind of epidemics. Then if you look at the linkage challenge, because we are always been seeing surveillance as a reporting upward linkage only, weak download flow is a poor preparedness at block and the facility level. Labs and LMIS works as separate platform, not linked with IHIP. The only linkage with the laboratory, current laboratory is the L form, which is manually filled. We need to have end-to-end integration, that means from patient to the national level, so that a seamless flow of information is there. Then the upward linkage ensure that local signals translate into national action through faster aggregation, early warnings, and forecasting. You see that how the linkages can be, so that seamless information is there. Then the download linkages also are important because we can issue national advisory, disseminate to the districts, reach BPHU, inform facilities, because during the COVID times, what we realized that we don't have the capacity to at least give a downward linkage. We were getting information from the ground, but we were not able to disseminate what kind of action needs to be taken. Only the centralized things were happening. So downward linkage transform national intelligence into local action through advisories, feedback, resources, and community engagement. Then the sample transport is also there because we are talking about the service-centric, patient-centric mechanism also. We have to see that the sample transport is also being addressed so that the timely diagnosis, faster treatment, other things can be institutionalized. Besides that, the sample transport mechanism can almost reduce the time for outbreak confirmation as well as we can escalate the matter to the rapid response team. The laboratory management system, we have around 12 states are using NIC Hospital Management Information System. When we wanted to have a laboratory management information system, then we have studied both the system, the issue and the e-hospital. 12 states are already using the hospital management system of NIC and 10 states are using the issue. And in this, they have a laboratory module. I think the hospitals can customize a laboratory modules to be connected with HMIs, and from the HMIs hospital management information, the system can be connected to the IHIP portal for feeding the information. Then the key benefits would be real-time linkages, better forecasting, outbreak detection, reduced duplication, and strengthened accountability at the block and the district level. This is the ask from the states. We have to see that, as I mentioned, that we have hospital management information software, which is already there. NIC has developed it. CDAC has also developed it. 12 states are already using NIC software and 10 states are using the CDAC software. And they have an inbuilt laboratory module in that. We have to only activate that module, customize it as per a requirement. We can always synchronize what kind of reporting is required, who will be authorizing, that kind of facilities available in that module. We see that how we integrate that module so that it becomes functional in the existing hospital management system. The installation of the LMIS, I think that requires some training. and aspects, and that can be supported through NIC, and the CDAC can also is willing to support that. Then this will ensure that the digital reporting is implementing instead of L forms. That can happen. And it will also ensure interoperability between the system, hospital MIS system and the HIV portal. They would be integrated through this. This is the linkages operational, what to do and how to do. We can link the HIV portal with LMIS, NIC, CDAC software is there using APIs. I think we are in discussion with Himanshuji, so that we see that how we find out, because 10 states, 12 states, they are already using it. Only thing the state starts using and customizing the laboratory module into the hospital management system and linking that hospital management system with the HIV portal. I think we are working in that direction, see that how we are able to do that. Then strengthen the BPHU, IPHL roles, ensure all suspected cases are tested and results are reported back. We have to push lab results and the advisories back to the facilities and the communities. Then district surveillance unit, state surveillance unit review with IPHL nodal officers and the NCDC. I think this is also already institutionalized. They usually carry out on a monthly basis or as and when required, they usually have this governance and accountability. And how to do it, we can test integration with few IPHL and BPHUs, the existing software. We see that how we integrate that. We can test it by showing suspected, tested case, confirmed case in one view for sample collection, data entry, reporting feedback. These are all the things which we can do for integrating and linkages with the facilities. We have to build on the NIC CDAC platform already in place. We see that how we prioritize IHIP, LMIs, interoperability under the ABHIM portal. We have, the other thing is train BPHU, IPHL staff for integration, regular joint reviews by MOHW, NCDC, and others. I think in the capacity building part, in the coming sessions, we will be talking more about that, how to train the BPHU, IPHL staff. So all the things are in place. Only thing is we have to explore and see that how these things can be integrated, how we can take the things forward. So that's all from my side. Thank you very much.
That was Dr. Madan Gopalji, ladies and gentlemen, Advisor PHA NHSRC. Of course, we'd now like to share any questions that anybody in the audience would have. All right. Thank you so much, sir. Looks like we have a 100% clear audience. Have a fantastic evening. And with that, ladies and gentlemen, our next session focuses on capacity building initiatives when it comes to BPHUs and IPHLs. This one comes with a keen focus on outbreak response and pandemic preparedness. To highlight these very initiatives and their very role in safeguarding public health, it is my pleasure to invite Dr. Meera Dhuria, Joint Director, NCDC, to join us on stage. Welcome, ma'am. Ladies and gentlemen, if I may please request you to put your hands together as we welcome Dr. Meera. Welcome, ma'am.
This is the one for slide change. Yeah. Good evening, everyone. So I think it has been a long day, even after lunch and just before we break this long day. So it's difficult to keep people awake and also to draw attention, but I'll try to do some justice. So my work has become easier after Dr. Himanshu's presentation and the presentation by Dr. Madan Gopal from NHSRC. So the capacity building initiatives are something for pandemic preparedness and response. If we look at the key pillars, they are the prevention, detection, assessment, and response. And IPHLs and BPHUs are the places or the critical pillars wherein this prevention, detection, assessment, and response capacities are required because they are the ones who will pick up those early warning signals. So with the permission of the chair, I would also like to take this opportunity to talk a little bit about NCDC, what we do. National Center for Disease Control is the National Public Health Institute for the country, which is a subordinate office of the DGHS under Ministry of Health and Family Welfare. So our core mandate is disease surveillance and response, which Dr. Himanshu highlighted, referral diagnostic services through the lab network, and under PM ABHIM, we are coming up with 10 BSL-3 laboratories in the country at selected locations, capacity building for public health and field epidemiology, which actually provides the hands-on experience to investigate outbreaks and to detect early warning signals, operational research for public health programs, and implementation and technical support to various national health programs. NCDC is also the national focal point for various national health programs. IDSP, it has been talked about a lot. Then the National Program for Containment of Antimicrobial Resistance, National Program for Climate Change and Human Health, National Rabies Control Program, Program for Prevention and Control of Leptospirosis, National One Health Program for Prevention and Control of Zoonotic Diseases, then National Program for Surveillance of Viral Hepatitis, and also the upcoming program, National Program for Prevention and Control of Snakebite Envenoming. NCDC, as the National Public Health Institute, is also the referral center for plague, HIV, also the nodal agency for SARS, avian influenza, pandemic influenza, prevention and control of soil-transmitted helminthiasis. We are also the WHO National Regional Laboratory for polio. And Dr. Senthil talked about the international health regulations to which India is a signatory. And NCDC plays a key role in implementation of international health regulations as being the secretariat for it. NCDC is the WHO Collaborating Center for Epidemiology and Trainings, and also for the rabies epidemiology. So coming to the integrated public health laboratory. So since morning we have actually heard a lot about why this integration has happened and how it will be useful for us. So the core functions of this public health laboratory would be to provide diagnostic support for infectious diseases, hematology, chemical biochemistry, microbiology, virology, and pathological parameters. And it will involve sample collection, reporting, and integration with various facilities through the upward and the horizontal linkages, which Dr. Madan Gopal has talked about. The integrated public health laboratories, there was a mention about the district public health laboratories also. So the district public health laboratories are the laboratories which were providing the diagnostic support during outbreak investigation. And now the integrated public health laboratory will have all these various functions. So what are the training opportunities which are available or which we need to actually cater to? As we all know that the education system in our country is like the skill or the competency development is a little weaker. So we will have people who have been posted as lab technicians and data managers in the labs, in IPHLs, and also at the BPHUs, but we need to have a kind of an induction training for them and to make them understand the systems which are in place. So we need to have some skills, the laboratory skills for the general lab good lab practices, including the biosafety protocols, the sample management, which includes sample collection, transportation, and sample processing, and disease diagnostics, the rapid diagnostic tests, and all the program diagnostic tests, AMR surveillance, biomedical waste management, equipment maintenance, and quality control, which is already a part of NQAS. So if we see this IPHLs, they will be the master trainers for the PHC laboratories or the sub-centers, whatever will be done through them. And these laboratories will have upward linkages with the VRDL network, with the infectious disease research lab network, the sentinel surveillance laboratories, which are there under the One Health program, and also the AMR program, which will further report to the BSL-3 or BSL-4 laboratories if required. So we already have modules which are available, so we will need to come up with a short duration training for the IPHL lab technicians, and also the soft skills on communication and documentation. Then, Sir Madan Gopal sir also mentioned about the limbs. And we also have on the IHIP the lab module. So within the lab module, the labs will be given that reporting ID, and they will be reporting through this. So we also need to have a training or capacity building on the limbs, as well as the IHIP module for data reporting and maintenance of the digital health records. Under the SOS and emergency preparedness, so sometimes they would also be, they should have the capacity for rapid diagnostics and also surge testing. And they also need to have an inventory of the labs which exist in their network, so that whenever they do not have any reagents, they can also look at the inventory which is available with the neighborhood labs. So the block public health unit was a health facility at the block level which provides limited range of clinical services for RCH and selected infectious diseases. But now their role has been upgraded in public health to provide support or augmenting their existing capacity to also deal with the outbreaks and generating early warning signals. So basically, if we talk of IDSP, District Surveillance Unit is our mainstay, and whatever early warning signals or event-based surveillance is generated, so that goes to the state, it is passed down to the district to verify whatever is the report, and then it will go to the block level. But the capacities do not exist at the block level, so we need to emphasize on data management through induction module on IHIP, risk communication and community engagement, which was highlighted by Dr. Himanshu. We have a community reporting tool. So the block public health units need to take this message down to the lower level, at the sub-center level, and Asha and Anganwadi level to enhance the reporting through the community reporting tool. And also under the One Health program, which Dr. Simi will be talking about, we also have a community engagement module, because most of the diseases or diseases of pandemic importance, they are zoonotic in nature. So the early warning signal will usually come through the animal health side, like a death in an animal, or so that has to be reported, and there needs to be interlinkages between the various departments. So multi-sectoral collaboration becomes very important. And then for public health surveillance and management, the disease monitoring system for early warning, alert and response generation, event-based surveillance, and outbreak management. So we have a training module, Sector Connect, for the district level officers, which is a joint initiative of Ministry of Health and Family Welfare and Department of Animal Husbandry and Dairying. So this brings along the rapid response teams, which are multi-sectoral in nature, and they function on the lines of the National Joint Outbreak Response Team, which was also highlighted by the earlier speakers. So this multi-sectoral teams, they are trained in surveillance and outbreak response, along with the laboratory linkages and the biosafety and the biosecurity module, also encompassing some part of the risk communication. And I'm happy to share that the state of Rajasthan, where the trainings have been conducted, they have also notified the state joint outbreak response team and also requested the districts to also notify the district joint outbreak response teams. Then for emergency preparedness, the block level epidemic preparedness and response planning, Dr. Himanshu showed us a tool for outbreak management, like if an outbreak happens, what are the 10 steps on which the readiness or the response is measured. So epidemic ready PHC toolkit is available, which can be used by the blocks to have a look at how the PHCs work and what is their capacity. Also, the public health emergency and disaster management training for tier 1 and 2, which is the sub-district level, is available, and we can support the states in case the need arises to conduct such trainings. Program implementation and disease control under the various national health programs. The implementation would be required because disease could be anything. It is not only the pandemics or the outbreaks, it could be the non-communicable disease as well. And under the One Health program, the Digital Academy for One Health and allied courses is also being launched. So this is a glimpse of the various training programs which are available. So as we have highest level of policymakers from the states, I would also like to make a request for our Epidemic Intelligence Service program, which is an advanced field epidemiology training program of 2 years, wherein the officers from the state level, they are posted to NCDC and various other placement sites which are under the various programs, and they are trained in applied field epidemiology for 2 years. So we have not received nominations from various states, and there are many states who have not sent the nominations, so we would request the states to also have a look at the letter which has been sent by the Secretary Health and Family Welfare, Government of India, to the Principal Secretary Health. And these all documents are available on the website of NCDC. Under the IDSP program, we also have a module for the medical officers, which can be further shortened or briefed to have this training for the block public health units. And I'm also happy to share that Odisha and Rajasthan state are a few of the pioneer states which have launched their state action plans on One Health. And doing the multi-sectoral trainings which bring together the people from various sectors is kind of an implementation of the One Health, because there is a lot of data sharing, there is a lot of resource leveraging. And with this, I end my presentation. Thank you.
Thank you, ma'am. Following that presentation, we'd like to open the floor to any questions that anybody might have. All right, on that note, thank you so much, Dr. Meera Dhuria. Ladies and gentlemen, let's extend a round of applause as we also share our thanks. With that, our next presentation focuses on One Health and AMR initiatives. It is my pleasure to invite Dr. Simi Tiwari ji, Joint Director, Center of One Health, NCDC, followed by Dr. Manoj V. Murekar ji, Director and Scientist G, National Health Institute of Epidemiology, ICMR, to take us through the topic, One Health and AMR initiatives. Welcome, ma'am. Good evening.
A very good afternoon to everyone. Thanks for providing me an opportunity to talk about the most momentum gained topic, One Health. But still, it is the least practiced and least prioritized topic. And yet, it is a very difficult and complex concept to be in practice. But still, I would try to sensitize the gathering over here what all we are doing as of now in the One Health and antimicrobial resistance activity through National Center for Disease Control. Thanks, Dr. Meera, for setting up the stage and context. So, One Health is actually bridging the gap from endemic to the pandemic preparedness. So once we are strengthening our systems to look into the endemic diseases, we are on the gear to prepare ourselves for any pandemic event. So what exactly is the One Health has been defined in various ways, but One Health is better understood as a collaborative, multi-sectoral and transdisciplinary approach working at local, regional, national and global levels. And to achieve the optimal health of all living beings, including humans, animals, as well as our environment. So we can see the very picture out here, which is depicting the environmental health, animal health, and human health with a shared goal and common objectives to protect our communities. Why One Health approach is gained an importance, especially after COVID-19, because we have seen the data from a range of global pandemics which have created a huge socio-economic loss since many years or decades, that 75% of all emerging infectious diseases are zoonotic in origin, and especially 60% of human pathogens are coming from the animal origin. And if we look at the global data, approximately 5 new human diseases are appearing every year. So that can be understood with the range of technology or the diagnostics available with us, or a more sensitive surveillance system we are having in place. So both these things combined together are enriching our knowledge to have a more understanding and in-depth understanding of a newly emerging diseases. If we look into the economic scale, approximately 2.5 billion cases of sickness and 2.7 million deaths are happening each year due to infectious diseases. And the core domains of One Health are basically the climate and human health, zoonotic diseases, food safety and security, and global burden of antimicrobial resistance. Why we should be taking care of One Health in our country? Because countries, and we are having a world's largest livestock population available with us, and we have heavily forested area approximately encompassing 21.5% of the total area of the country, and we are a fastest growing economy. Lot many infra projects are coming, huge wet market sector, although I have not written, but it is important and pertinent to mention here that lot of illegal wildlife trade activities are happening all across the state borders. Rapidly increasing globalization and industrialization activities, loss of biodiversity and landscape changes, and also a huge demand and huge consumption of antibiotics to meet the medical demands. So these all things, they need a particular attention to have a One Health in practice in our country. What are the stakeholders? So whatever we are talking since morning about block level health structure, integrated public health laboratories, what exactly is the health mechanism at the state level? One Health defines that we should be looking the same kind of institutional mechanisms and arrangements in the line departments like veterinary sector, forest sector, and as well as the State Biodiversity Board. So as we understand that many of the stakeholders in the states, especially those who are already there in the health sector, they are not, as of now, are systematically communicating with their line department. So if we look into the health of all approach, and if we want to practice One Health, in true sense, we need to know the counterpart in the other sectors. So the stakeholders for One Health in India, other than the health, are a veterinary sector, which is a very important for us to have a close and systematically licensing at all levels. Similarly, the forest department at all levels that need to be there on the same platform. And local governing bodies and corporations, they are also a huge role to play for few of the zoonotic diseases like rabies and snake bite and other zoonotic diseases, science and technology, agricultural sector, and also some of the other departments, those who are the research institutes and the state level environmental department or the meteorological department. Other than this, the private sector, they have to play an important role whenever we are looking at a One Health approach, and also the professional bodies, not only in the health sector, but the other sectors like veterinary organizations. Now we all know that National One Health Mission under the chairmanship of Principal Scientific Advisor to our Honorable Prime Minister of India is very much in place, and NCDC is one of the strongest pillars of operationalizing One Health in India through its various national programs. IDSP and IHIP, my colleague Dr. Himanshu Chauhan has already spoken about, but one of the important program wherein we are trying to build the linkages with the other digital platforms which are available in the other sectors. National program for antimicrobial resistance is being run by National Center for Disease Control, then National Program for Climate Change and Human Health, National One Health Program for Prevention and Control of Zoonosis, Rabies Control Program, Leptospirosis, and also a program on prevention and control of snake bite and venoming. So all these major programs are housed and being coordinated by National Center for Disease Control under Ministry of Health. So under National One Health Mission, NCDC is playing a major role. Apart from these national programs, NCDC is also tasked with 2 advisory and review committee, which is tasked to have a technology-enhanced surveillance and integrated disease outbreak investigation, and also to build an integrated digital platform on One Health. So under National One Health Mission, so these are the roles which has been entrusted with the NCDC. This is an institutional mechanism on One Health. I will not go into detail, but just to apprise the gathering here, that just to look into the zoonotic diseases, we have already made the state-level zoonosis committees and district-level zoonosis committees. So my request with the state officials to look into these committees and to operationalize and to hold the meeting of these committees from time to time to look into the zoonosis situation in their respective states and districts. Center for One Health at NCDC is the nodal center for implementation of all these committees. So all these programs which I have spoken about, these have all dedicated funding through central sector component and centrally sponsored components through National Health Mission. This is a snapshot which is talking about National One Health Program for Prevention and Control of Zoonosis and its various components. So we have 6 components under this. Community outreach is one of the important components other than integrated surveillance activities, and also to undertake the operational and implementation research in collaboration with ICMR. A network of laboratories is available. Various laboratories are there, like Sentinel surveillance site of zoonosis are being created. As of now, 75 Sentinel sites are functional. But the limitation is this, that our primary healthcare physicians, they are not having an adequate clinical index of suspicion, because these are not the routine pathogens. All zoonosis, they are special pathogens, require special capacity. They know a heightened index of clinical suspicion. Once they know about the zoonosis, then only they are going to elicit the history from the patient, and then only the samples can be given to the designated laboratories. But once the capacity is there in the primary care physicians or frontline workers, these zoonotic diseases, they can be diagnosed at an early pace, and we can save many lives because of early diagnosis and giving the treatment to these patients. Now, many laboratories are there other than VRDL network. BSL-3 lab network is coming up. Now, disease-specific laboratories are there, rabies and leptospirosis, but I would request states to plan the trainings for these diseases, so that these diseases, they can be diagnosed early and we can institute the treatment. Many IEC and guidelines are there which are freely available on the NCDC websites, but unfortunately the resources are limited. So some earmarked resources that would be required by the states to undertake the dedicated awareness campaigns for these priority zoonosis. This is a regional coordinator network which we have created under the National One Health Program. So approximately 11 regional coordinators other than few selected aims. So these regional coordinators, these are linked with the special pathogens, capacity building, and also a range of One Health activities like support for lab diagnosis, workforce development, operational research, community outreach activities, stakeholder sensitization like mobilizing the state-level zoonosis committees and district-level zoonosis committees, also extending support to the various states for undertaking complex joint outbreak investigation operations. Apart from this, we have also liaised with the veterinary institutes through this regional coordinator network and Wildlife Institute of India, and now the upcoming Zoological Survey of India is the next partner to extend the augmented zoonotic disease surveillance in the biodiversity hotspots. This is again a Sentinel surveillance site network. As of now, 75 sites are operational, and these are again providing a range of activities. Many of the states, they have given proposals to us for Sentinel surveillance sites, but few of the states, they have yet to submit the proposals to us, like Jharkhand, MP. Many states, I would request that if they can send the proposal to us for Sentinel surveillance sites, so a range of activities being provided. you can have a look on the list of pathogens which are being covered. These are all special, these are not the routine pathogens. Like anthrax is a bioterrorism agent, and we need to build capacity for diagnosis. Creman Congo hemorrhagic fever, rabies, influenza, Kyasanur forest disease, lepto, scrub, West Nile, brucellosis, Chandipura, hantavirus, Lyme, many pathogens. These are not the routine pathogens which are lacking a kind of technical expertise in the frontline workers. So these all capacities are being extended by NCDCs through their institute network. Augmented zoonotic disease surveillance at human-wildlife interface is again a very important project which is being extended in the biodiversity hotspots in the selected states. You can see we had a very wonderful presentation by IIT Mumbai. So you can see the list of wildlife host species which are there. So until and unless we are having a look onto these wildlife reservoir of these pathogens, and none of the predictive model can be successfully predict the disease. So this is again disease-specific laboratories for rabies and leptospirosis. Many digital initiatives like Zuvin and rabies helpline. Only in the 5 states we have extended the rabies helpline. But Andhra Pradesh, MP, Assam, Delhi and Puducherry. But other states, they can also link for these helplines, which is directly helping the beneficiaries for dog bite incidences and snake bite management protocols. So One Health Workforce Development, my colleague has already spoken in detail about this One Health Workforce. Sector Connect is one of the unique program with us which is providing joint multidisciplinary training for the district and state level officials. But this need to be extended to the block level and down up to the grassroots level for the ASHA and ANMs. Antimicrobial resistance, I would take through 1 or 2 slides only. We all know the antimicrobial resistance is a huge burden, but National Action Plan for AMR containment is very much in place, again, which is built on One Health principle, have multi-sectoral. But for the health sector, we need to look into the hospital-acquired infections, capacity building, and also to detect the outbreaks at an early, as early as possible to limit the infections going on into the hospital premises. So this is a snapshot wherein highlights of various AMR containment related activities are happening throughout the 2017 onwards. These are the pillars. So these are various multi-sectoral engagement glimpses. We are starting not only from the disease-specific technical advisory committees, but also into the legal framework aspects. What are the legal challenges in implementing the One Health activities? Various resource materials, these can be downloaded. And again, as Dr. Meera has already highlighted, the Rajasthan and Odisha, they have already launched their State One Health Action Plan, but it is a complex exercise, stepwise exercise. So, but NCDC is there to support the formulation of State One Health Action Plan. Challenges in implementing One Health, we know that priorities are different for the different sectors, wherein largely the veterinary sector is more concerned about the economic perspective of disease. The human health sector is there to look into the prevention and management of the disease aspects. But regular engagement with the veterinary and forest, we can save many more preventable diseases at an early, early time. Limited logistics, this is a challenge for each and every sector, but somehow we need to. But fortunately, we are having a very strong political will to implement and operationalize One Health at all levels. With this, I would rest my words, but my only ask from the states, please do prioritize the zoonotic diseases and One Health. Thank you very much.
Thank you, ma'am. At this juncture, it is my pleasure to invite Dr. Manoj V. Murekar-ji, Director and Scientist G, National Institute of Epidemiology, ICMR, for our final presentation. Welcome, sir.
Very good evening to all of you. Can I have my first slide, please? So I'll be basically giving you an update about important research initiatives taken by Indian Council of Medical Research and Department of Health Research in the area of One Health, especially under National One Health Mission. I won't go into this slide because Dr. Simi has already talked about it. But National One Health Mission was established to coordinate, support, and integrate all One Health related activities in the country. And wherever there are gaps, this mission was also expected to bridge these gaps by initiating new activities. So this is the structure that Dr. Simi talked. And to anchor the activities of National One Health Mission, a National Institute of One Health is being constructed at Nagpur, and this is expected to be operational by next year. So One Health, National One Health Mission has a broad range of objectives or activities assigned to it, starting from undertaking integrated and holistic R&D in the area of One Health, primarily to identify the threats because of emerging diseases, zoonotic diseases, establishing models for integrated disease surveillance. Another important activity or objective that has been assigned to One Health Mission is development of medical countermeasures, be it vaccines or monoclonals or diagnostics. So I will be talking about some of the important initiatives that were taken by ICMR in this regard. In the first objective is undertaking holistic research. And in that context, during 24-25, 20 projects worth of 23 crores were approved by ICMR and have been initiated. And the implementing institutes range from, these are some of the implementing institutes that you could see. The second objective is to strengthen disease surveillance or establish models for disease surveillance, integrated disease surveillance in spillover areas. And here I want to talk about three important, I want to give three examples. First is model surveillance projects at animal-human interfaces that we have initiated last year. Second, I'll talk about wastewater surveillance, especially for AMR. And third, I'll talk about syndromic surveillance for infectious diseases that ICMR has been coordinated. So last year we started surveillance in slaughterhouses. This project started in 1st of August 2024. And this is a collaboration between ICAR and ICMR. And the project is currently ongoing in 11 slaughterhouses in different states. And as part of this, samples from the animals which are slaughtered, humans who are manning these slaughterhouses, as well as environmental samples are collected periodically and tested for emerging pathogens. The second project is surveillance in bird sanctuaries. This is in 11 bird sanctuaries, 7 in Sikkim and 4 in Maharashtra. This project is ongoing. Again, here as a part of this project, biological samples are collected from birds, from the people who are working in bird sanctuaries to see the emerging pathogens. The third project which I want to talk about is Institute for Genetics and Society. And the objective of this project is to study the AMR signatures at 60 VRDLs, virology research labs, by metagenomic analysis of wastewaters. And this project is currently ongoing in 60 labs in the country. Another important project which ICMR is coordinating is a pan-India syndromic surveillance for respiratory viruses. And the objective here is to monitor the trend of circulating respiratory viruses. This project is currently ongoing in 73 VRDLs. And from patients of ILI, influenza-like illness, and severe acute respiratory tract infections, the samples are tested for 5 important pathogens, including influenza, SARS-CoV-2, RSV, and HMPV. And in West Bengal and Kerala, the samples are also tested for Nipah virus. The influenza viruses are genetically characterized, and the data is shared with the WHO in the influenza network. One important achievement or observation of this was this network picked up spillover events, human cases of avian influenza in West Bengal in July 2021, in March 2024, and recently in March 2025. And this again tells the importance of this surveillance in detecting a spillover of avian influenza in humans. Then last year we also started again a large network of AES surveillance, acute encephalitis surveillance, where 14 labs 14 hospitals are participating in this surveillance, again funded by ICMR, and this is coordinated by JIPMER Pondicherry. And the objective is to determine the etiology of AES in different regions, and to detect unknown or novel pathogens by NGS. This year, ICMR also started a big project on Chandipura virus, and as you may remember, last year we had the largest outbreak of Chandipura ever reported in country, and we really don't know much about the epidemiology of Chandipura in India. And this is a One Health project where, as part of human component, sero surveys and AES and AFI surveillance has been established in selected districts and sub-district hospitals. Entomological surveys are conducted in different vectors as well as rodents to see the virus and potential reservoir of the virus. Animal surveys are conducted by Nibedi. And in addition to that, vaccine development is being taken by NIV Pune and NARFAR. And all these activities are conducted in collaboration with the government of Gujarat. Talking about the third objective of developing countermeasures. So KFD, as was told by Dr. Simi, is an important disease in Karnataka, Kerala, and Goa and Maharashtra. And ICMR, NIV, and Indian Immunological, through their collaboration, developed a candidate vaccine. And this vaccine was tested in mice, was found to be highly immunogenic. And the phase 1 trial protocol has now been approved by the PRC, and it will be the phase 1 trial will initiate very soon. Similarly, for Nipah, we again know that we don't have any monoclonals available indigenously. We have been depending on the monoclonals imported from Australia. So ICMR floated a UI, and 3 institutes, THSTI, Zydus Cadila, and NIV Pune, developed monoclonals for Nipah, and 2 of them were found to be highly immunogenic in animals. And animal studies have been conducted with these 2 monoclonals, and both of them demonstrated a very strong prophylactic potential and could be potentially used in future Nipah outbreaks. Similarly, for Zika virus vaccine, ICMR has signed an MOA with Indian Immunologicals Limited, and they have developed a live attenuated Zika vaccine. And phase 1 trial of this vaccine will again initiate very soon, and this will be funded by ICMR. For the vaccines on avian influenza, ICMR is working with 4 companies for the development of avian influenza vaccine. Talking about diagnostics, and again, ICMR has been collaborating with industry partners for developing high-quality, low-cost, multiplex molecular diagnostics for syndromic surveillance of infectious diseases. And many of the diagnostics are being developed as a part of this arrangement. Talking about the last objective, that is training, lab strengthening, and outbreak investigation. And there is a BSL-3 network. The primary aim of this network is to undertake testing of priority human, animal, and environmental pathogens. And this network is being funded by National One Health Mission. And this year, all labs, our BSL-3 labs were trained at NIV Pune and NISAR Bhopal for biosafety precautions that needs to be followed while handling human, animal, and environmental samples. So I'll skip this slide. I'll only talk about the last part, that is the National Joint Outbreak Response Team, which has been established as a part of, to respond to zoonotic disease outbreak. And this network has, in fact, investigated outbreaks of Chandipura in Gujarat last year and Nipah outbreak this year. Last year, ICMR also conducted this mock drill called Vishanu Yuddha Abhyas. The primary objective of this mock drill was to assess the readiness of NGORT to mount efficient response in H5N1 outbreak, and to assess the intersectoral coordination, preparedness, and efficiency of different stakeholders, and to identify gaps in terms of administrative challenges, resource constraints, and in communication. And as a part of this mission, as a mock drill, outbreak of H5N1, avian influenza was simulated. And so several lessons were learned through this mock drill. And these lessons have been incorporated to improve the pandemic response of the country. So, and just for your information, there is a web page of National One Health Mission, an ICMR website, and the activities of this mission are listed in this. So if you have time, you could kindly visit that. Thank you very much.
Thank you, sir. That was our final technical presentation for the day, ladies and gentlemen. So if you do have any questions, now would be a fantastic time to please share them. If not, if I may please request. Okay, we have one question right there at the back. Good evening, sir. Just a second. We'll pass the mic to you. Can we pass a mic there, please?
This is with reference to Dr. Mureka's presentation. Sir, I would like to know two things. One was on pan-India syndromic surveillance of respiratory viruses you did. In that study, is it only the WGS which is looked into, or other methodology or adopting to look at this surveillance? And any take-in message for the future prospective COVID pandemic? Second one is on the M antibody thing which you have done. You mentioned there is a potential for prophylaxis. Currently, we know monoclonal antibodies are of value in treating cancer, autoimmune diseases, and infections also. But there is prophylactic value, which are the ones is being focused.
Thank you, Dr. Gerard. The first question about the surveillance in the respiratory syndrome surveillance. So it is not only NGS. First, the 5 pathogens which are targeted, that includes influenza, that includes RSV, SARS-CoV-2, HMPV. So these are initially tested with PCR. And then it is sequenced. So this is the protocol that is followed. It's not that everything is NGS is done in that. About your second question on monoclonals, these monoclonals have been found to be highly immunogenic in animals. And now the studies will happen in humans before it is recommended for human use.
What kind of prophylaxis we are looking for? Like out of your study on M antibodies, monoclonal, what are the prospective prophylaxis you are considering right now?
I mean, there are several diseases where it can be tried. Nipah is one example where mortality is very high and we don't have any other treatment available. One could even try in case of Crimean Congo hemorrhagic fever, or even in rabies it has been tried. So in such diseases it could be tried, but currently the target is Nipah.
Madam.
We have another question, sir, right there at the back.
Okay, this question is related to the last 2 or 3 sessions. And one thing, the first question is regarding the availability of diagnostics. So we've been talking about improving our diagnostic facilities. But the fact is that there are a number of diagnostic modalities which are available in the private sector, which have been approved tests, but the quality of which is not monitored, or the mechanism of monitoring the quality. Are we looking into, shouldn't we have some sort of look into that aspect of quality of the tests which are undertaken. Even in our subcenters or our this HWCs, there are under the 15th FC as well as other things. There are a lot of tests which are rapid diagnostic tests, point of care tests, which are brought from the open market, which are the quality of which we have to do. We have to have that quality building mechanism. The second thing is about the availability of this newer diagnostic methodologies such as whole genome sequencing and next generation sequencing and all. And again, the private sector, many of these private sector hospitals, major hospitals are actually using it, and the regulation as well as the utility is something which we have to look into. And how, suppose we are able to get these results, and those results are to be reported through our IDSP, through our reporting systems as part of the surveillance. So as part of this PM ABHIM 2, should we look into this availability of this genomic sequencing facilities in our public health institute, or is such a horizontal expansion needed, or should it be available in some institution, institution at some level at that level? So are we looking into it? So this is not only for you, sir, it's for last related to 2 or 3 sessions.
So I will first answer and then request Dr. Simi to add. So I showed you one slide where ICMR is collaborating with industry to develop low-cost, high-quality diagnostic for identified zoonotic pathogens. About 30 priority pathogens have been identified. And ICMR is working with the industry partner to develop low-cost diagnostics. ICMR also has been collaborating with CDSCO to validate these kits. Because you very rightly mentioned that there are a lot of kits available in the country, but not every kit is properly validated. So there is also a mechanism to validate these kits. So these are the initiatives from ICMR side. Dr. Simi, if you could add, that would be great. I don't know where is she.
Dr. Simi, do we have you here with us? Yes, ma'am. Can we please pass a mic to Dr. Simi Tiwari, please? Dr. Simi Tiwari, ladies and gentlemen. Over to you, ma'am.
Can you please repeat the question?
Sir, if we may please request you to repeat the question for Dr. Simi's benefit.
Ma'am, I was just asking about the role of this whole genomic sequencing and next generation sequencing, which are being used by many private institutions. And some of us, even from the public sector, have started referring it to some premier institutions for some purpose, either for individual patient benefit or for some research activity. And should these be part of our PM ABHIM 2, these facilities? Especially since we are looking at this One Health component, there are many pathogens which might be circulating in the community, either among animals or humans. So this offers an exciting possibility, but is it really needed, or should we look into it as part of PM ABHIM 2?
Sir, actually, the whole genome sequencing and next generation sequencing, these are cost-intensive activities. So, in general, in the public health, from the public health perspective, these are not very viable options. Rather, we would be looking into a more cost-effective aspects which are directly benefiting the patients in a public health setup, like IGM ELISA. But definitely, the WGS and NGS platforms, they are going to play a promising role for a specialized surveillance setup, like we are enhancing our surveillance at human-wildlife interface, wherein we are targeting, like ICMR is doing surveillance, NCDC is going to establish surveillance in the biodiversity hotspots, wherein we are going to target a very high-risk population, and the proportions of those acute undifferentiated fever cases or acute febrile illnesses cases where a larger chunk is remain undiagnosed despite exhausting all kinds of diagnostic pathogen profile testing. So for a small subset of samples, these practices should be there, and these samples, they should be transported to the linkages laboratories like NIV Pune or a BSL-3 network which is coming under National One Health Mission to look into a special genomic sequencing or to identify any unknown pathogen. So that strategy is already being practiced under National One Health Mission and also under the NCDC Augmented Zoonotic Disease Surveillance Network. So not as a general practice, we should not be looking into this, but many commercial options are there that wherein, like I was just speaking on this topic only with my colleague Dr. Meera, that some of the NGS options in the diagnostics are there in the market which are both telling about the pathogen involved in a disease entity and also at the same time they are talking about the resistant pattern about that pathogen. So there are many things which are commercially available, but that is a very crucial policy decision that what exactly is benefiting the patient and a larger chunk is getting benefited and what is the cost involved in that. Thank you.
Thank you, ma'am. Any thoughts to add, sir? Ladies and gentlemen, a loud round of applause for Dr. Manoj Murekarji. Thank you so much, sir, for closing the day on such a wonderful note. Ladies and gentlemen, it's been an interesting day exploring the evolving framework of the Indian public health infrastructure under PM ABHIM. Of course, strengthening it from multiple facets has been an interesting conversation as well. And the juncture that we stand at is from exploring possibilities to addressing the need of the hour. What a lovely place to kind of wrap up our technical deliberations. On that note, tomorrow, I'm sure that all of you are aware that we have a host of activities planned for you. If I may please request Mission Director, NHM Tamil Nadu, Dr. Arun Thamburaja Avargal, to join us on stage and give us an insight into what tomorrow holds for us at the National Workshop. Welcome, sir. Good evening.
Presentation. A very good evening to all of you. So tomorrow, based on the instructions of ASMD ma'am and JS policy sir, we just like to run through the presentation for tomorrow's field visits. Next. So we have divided into 5 teams, team 1, 2, 3, 4, and 5, to different locations. The team 1, for the information of all the members, the teams will start by 8:30 in the morning tomorrow. So request you to have an early breakfast, and you know the traffic in Chennai. So to travel from the suburb to that city will take almost 1.5 hours to every center. So we want you to please board the bus and leave from here by 8:30. So these are the 5 routes. We will be sharing all these routes in your groups. And your liaison officers also will be briefed about this. So you can get the copy of these presentations. So route 1 is from the hotel. We go to the Government Medical College at Chengalpet. So to have a look at the critical care block, 50-bedded CCB. And then you can also have a look at the Thai ward there, which is Tamil Nadu Accident Emergency Initiative. Following that, a visit to the block public health unit at Kelambakam. So the team 1 will be visiting 2 facilities, Chengalpet critical care block in the medical college and block public health unit at Kelambakam. This is the first route. The second route will go from Taj Fisherman's Cove to Kelambakam block public health unit and then to the DIPHL at Tambaram headquarters hospital. So the second team will visit 2 facilities, the block public health unit at Kelambakam first, and then go to the district headquarters hospital where the DIPHL, District Integrated Public Health Lab, is situated. The third route is from Taj Fisherman's Cove to the block public health unit at Kelambakam. And from there, they go to the state public health lab within the city. So there are 2 facilities. One is the SPHL and the BPHU. The route 4 will go only to the state public health lab and have a look at the trauma and the Thai facilities also there. And also briefing on the 48-hour cashless treatment. And also the maternal mortality rate MMR reduction war room is there. So those facilities, only one facility will be taken to by one location for route 4, which is the state public health lab and the 108, 104 operation center. And the route 5 also will go to only one center, which is the NIRT Tambaram, NIRT Chetpat, National Institute of Research in Tuberculosis, where the BSL-3 lab is located. So there are 5 teams. First, second, and third team will go for 2 facilities. Fourth and fifth will go to one location only. Grouping has been done. The CCB and the BPHU will be sharing the names I don't want to read out the names, but we'll be sharing the names to all the participants, the ACAs, MD-NHMs, SNOs, and also officers from Government of India, NHSRC, and hosts from the state side, and the vehicle numbers also been arranged. So, I mean, you can note, we'll be sharing all these names. So, I'll not be reading out the names. The second group, and then the third group to BPHU and SPHL. This is the fourth group to the State Public Health Lab and the 108 Operations Center, Trauma Management. And the group 5 to the National Institute of RT, Research in Tuberculosis, where you will see the BSL-3 lab. So these are some of the points I just wanted to stress about the travel and logistics arrangement. As Chennai, in the morning is a peak hours, the school time, the office going time. So if you go by 10, 15 vehicles, you definitely get missed. So we've arranged for a Volvo air-conditioned bus. So the bus will be stationed for every team. So you can board from here at 8:30. So 8:15 you can start boarding, 8:30 the bus will leave sharp. So that is what you have mentioned there. The team 3, which goes to BPHU and then to the State Public Health Lab alone, has to leave 15 minutes in advance. By 8:15 are requested to leave. So request you to please stick to these 2 timings. The buses will be parked at the entrance of the hotel near the reception, and there will be teams to facilitate your entry into the buses as well. And we request you to kindly use a shuttle service instead of using the cars. Because if you use cars, you're definitely going to get lost, and you're not going to reach that thing in any point in time. So request you to please kindly stick to this shuttle service, and request you to kindly follow the timeline. Breakfast will be available from 7 a.m. at Seagull, the restaurant where you had the breakfast today morning. And water bottles and refreshments will be available in the bus as well. And after the visit, we are planning to reach here by 1:30. And after that, you have the lunch. Following the lunch, we have 15-minute presentation by each of the teams. So 5 groups will make presentation of 15 minutes each before the Union Health Secretary, Madam. And the template for the presentation will be shared. Kaustubh Giri and team are working on it, so they'll be sharing the presentation for the template. And each team also has a consultant who will be helping out in making the presentation. So you can give the information inputs to them. They'll be facilitating in the making of presentation. So you can have a look at the infrastructure innovations, challenges, interaction with the field officials, best practices, and our people and the Ministry of Health and Family Affairs consultants will be guiding and assisting you in this process. So as I just repeat, team 1, 2, 4, and 5, except team 3, you leave by 8:30. So boarding should be complete and buses will depart by 8:30. Request you to please stick to this time because we will be taking the bus. We also instruct the liaison officers to keep you informed, so they'll also be informing you. And 9:30, and we'll be back for lunch by 1:30, and then we'll start the presentation. Similarly, the team 3 alone, 8:15 are requested to board, and the buses will depart. And this I was asked to inform by ASMD Madam and JS Policy Sir that the Union Health Secretary Madam wishes to have a discussion after dinner tonight at the boardroom, which is there located at the lobby, only for the MD NHMs and secretaries. So I just wish to state that tonight at 9:30 onwards, after a dinner, cultural dinner, just an informal discussion over a dessert is being arranged with the Union Home Secretary. Request the secretaries and MD NHMs to kindly take note of it and join. Today, from 6:45 onwards, we have arranged for a cultural evening. It has been carefully scripted by our team. Request you all to please join. It is at the same venue from 6:45 onwards. We have something called the Tappatam, which is the state dance. So it's a percussion instrument with dance steps, which is quite interesting to watch. So I request you to please join by 6:45, following which we have a team, Anarthana. It's a team which is present before the Finance Commission as well. We have roped in the team to showcase the culture of Tamil Nadu and also the national integration aspects. And then we have a Veena recital by one of the greatest persons in Tamil Nadu, Rajesh Vaidya. So request you to please join us for the cultural evening from 6:45 p.m. onwards. And there has been a photo booth which has been placed there. We request you to kindly take photos. We'll be giving the photos to you when you leave. So I think only 30 of them have taken photos. We wish to make you remember the good moments you spent with us. So request you to please make use of this facility as well. And based on the request of some of the participants, they're requesting us to arrange for some sari shopping here. So we have arranged for a stall to be placed from the Kanjipuram district administration. So the Kanjipuram silk sari stall will be placed where you take the photo today. So from tonight at around 8 o'clock, they have been asked to come there. So those who wish to go and choose and select sarees, it's on a payment basis. We have requested them for discounts. So I request those who wish to make use of that. Many officers were requesting us. So based on their request, we arranged it at a shorter notice and duration. So they'll be available tonight. So after the cultural dinner, they'll be there. So you can have a look. And also tomorrow, they'll be there in the same location, which is the photo booth outside in the lawn. So those who wish to have a look at the sarees can have a look at it. So thank you from my side. Hope you're having a great time, and thank you once again.
Thank you, sir. Ladies and gentlemen, we draw to a close our formal proceedings. We'll look forward to hosting you 6:45 onwards for a lovely cultural evening celebrating the wonderful spirit of Tamil Nadu. We hope to put together a lovely, memorable performance for you, and we hope to see you back here at 6:45 p.m. Thank you once again. Have a great evening.